She's going to join us video conference.
Okay.
Good morning, everybody. A very warm welcome to the first workshop of telemedicine being conducted at RMLIS. I hope this is one of many to come. I'm Dr. Malika from Medical Surgery, and on behalf of the team of telemedicine, I welcome all of you today. I would like to first welcome Professor Sonia Nityanand ma'am, the director of Dr. RMLIS, as well as congratulating her on becoming VC of King George Medical University. Congratulations, ma'am. I request Professor Mishra sir to please felicitate her. I also welcome Professor R.K. Dhiman sir. He is the director at Sanjay Gandhi Postgraduate Institute of Medical Sciences, and he is joining us on video conference.
Good morning. Thank you.
Welcome, sir.
Yeah.
I also welcome Mr. Mohammed Ba. He has come from International Telecommunication Union, straight from Geneva. I request Professor S.K. Mishra sir to also hand over a small token. Welcome to our Dean, Professor Nuzhat Hussain ma'am. I think she is also away and she's going to join us over video conferencing. Welcome, ma'am. Welcome our CMS, Professor A.K. Singh sir. I request Shelly ma'am to please felicitate our Chief Medical Superintendent, Dr. R.M. I also request Mishra sir to please felicitate Shelly ma'am. And last but not the least, Sonia ma'am, I would request you to felicitate Mishra sir as well. Without him, I don't think telemedicine is going anywhere in India. Thank you. I would request you, the dignitaries, to please proceed for lighting the lamp. With the lighting of this lamp, we hope the lamp of telemedicine has been lit at our institute. With this, I would request Professor Hike Singh sir to please give us a few words of welcome.
Thank you, madam. Good morning to all of you. I feel privileged to be here and welcome all of you. Respected Vice Chancellor, Ma'am KGMU, and Director Professor Sonia Nityanand Ma'am, Director SCPGIMS, Professor R.K. Dhiman sir, Mr. Mohammad Ba, Senior Coordinator Digital Innovation Ecosystem, ITU, Headquarters Geneva, Dean Professor Nujhat Hussain Madam, Professor R.K. Shukla sir, other senior faculty member, guest students, ladies and gentlemen. Today's workshop is on the telemedicine, digital health ecosystem, readiness for last mile telemedicine. We are here today because of visionary guidance of Director Ma'am. Since Ma'am has joined the institute, Ma'am is working constantly to upgrade the infrastructure facilities and introduce newer technologies, establish departments which are already in lower functional stage, or newer departments such as Cancer Institute, Thalassemia wards, and etc. Transplant Center, Thalassemia Emergency. In this chain, in our institute, telemedicine program is also not up to the mark and needs improvement. Although this is working since COVID period, but output is relatively not up to the mark. Respected Director Professor R.K. Dhiman sir, I welcome you. As we know, SCPGI is pioneer institute in this part of the country regarding telemedicine services. Sir, SCPGI is having huge department, conducting many research activities since last 20 years, and has collaboration with ISRO, such a reputed institution in the country. I welcome to you, sir, Mr. Mohammad Ba, Senior Coordinator, Digital Innovation Ecosystem, ITU, who is having more than 25 years of experience in developing, launching, and operationalizing products.
Please unmute yourself.
आपके आने से हमें उम्मीद है कि लोहिया आयुर्विज्ञान संस्थान के टेलीमेडिसिन सेवाएं भी रोगियों के इलाज में रफ्तार पकड़ेंगी। दूर दराज गांव के रोगियों को स्वास्थ्य लाभ और जीवन दान देने में ये वरदान साबित होंगी। During COVID period, we have learned that telemedicine is absolute requirement of the country. In rural areas, and they can come to the institution very frequently For them, this is very good facility which should be utilized up to the maximum potential. As we know, our institution is having very little space. So in OPD, there is too much crowd. If you can reduce at 20-25% of the crowd, then we will be providing better facilities. In OPD, one person, it's very difficult to negotiate to the room. So much crowd is there. Even if we can treat those patients who come for only just follow-up routine visit, and we used to write just check BP and pulse and continue same treatment, very little modification. These 20-25% of the patients can be treated at home with this telemedicine services. So I hope that today's workshop will guide us to control these patients, to treat them at periphery. So we all know telemedicine services, and I think most of us are utilizing in day-to-day life at personal. Maybe it is WhatsApp or mobile. But when we look at institutional performance, we are lacking, and we are far behind our countrymen, other institutions. And we are below the government expectation in what we can do. E-Sanjeevani is such a portal, which was started by government. But unfortunately, we are providing our services too little. During COVID periods, these telemedicine services, we have saved many lives. And telemedicine increases timely access to appropriate interventions, intervention including faster access and access to services. Just for one example, in neurology, stroke patients, where only 4.5 hours is there to give thrombolysis treatment. If they can be, these patients can be treated at community health center level or district health center level, where CT scan facility is available. They will need just monitoring for 24 to 48 hours. And if we call them to Lucknow, nearly 4 to 5 hours it will take in journey. And ambulance and other facilities also, that takes few hours. So intention to treat these patients which usually fails. So these patients can be managed with the utilization of telemedicine services. In such a way, in most of the departments, we can utilize and encourage these services. So here today, Professor S.K. Mishra sir, Director ma'am, Professor Dhiman sir, all three have worked in the SGPGI, and they are attached with experience of more than 20 years of services. So I hope we'll get their blessings, and they will guide us how to improve our services in institution. Last but not the least, Dr. Malika Danda. Thank you, madam. And we welcome you for your effort to organize this extremely useful workshop. Thank you. Thank you.
Thank you, sir. I think that was a very practical look at telemedicine and how it can benefit RMN. We hope that this workshop is going to help us reach a point where it is beneficial not only for the hospital to reduce the burden, but also for the patients who come from all points of not only Uttar Pradesh, but as far as Nepal. I would request if Dr. Nusrat Hussain ma'am has joined us. I think she's yet to join us. So let's wait for another 10 minutes for her while Mr. Muhammad Ba can tell us about the workshop and the conduct of the workshop. He can come and speak a few words about what is expected, what is the expected outcome, and how we as RMPs at a tertiary health center can influence this outcome.
Well, thank you. And again, thank you to our distinguished guests. Just step up. Okay. It's a pleasure to be here and really to It's not my first time in India. I think this is my fourth time in India right now. But it's my first time in Lucknow, which I'm discovering is a beautiful city. But we're not here to talk about Lucknow. So we're here to talk about technology and how technology can really improve the healthcare system. We've sort of organized this workshop under the umbrella of some serious work that we're doing in India, which was a work that was launched in terms of ITU trying to establish an innovation center in Delhi to help the whole region. And you'll hear more about this in my presentation later in the day. But I think just picking up on the previous speaker and very specific benefits about technology. Technology has an opportunity to really change the world. Technology is changing the world, and we are in that world where everything is changing rapidly. If you look at areas like telemedicine, which is something that has been around for almost 20 years, if I'm not mistaken, the question is, why isn't telemedicine making an impact across the board? And so the intent of the workshop is for us to deep dive into what's happening in this area, how we can specifically understand where this future will be, what is changing, what are the other technologies that can come in complementary to telemedicine to actually help support from RML in terms of this specific workshop is exactly what we're looking to do. How, and I understand there were 3 points being made. One is basically that's fine, I muted it. I think we're all expert at Zoom now. So the first being over crowd and capacity. And capacity, I think this is really pertinent everywhere, but it's not just about the crowd and capacity, it's also about the reach. How do you access actually all of these rural areas? How do you access people remotely? The second is really the performance that you can get from all of these systems, right? Today, if you think about healthcare, healthcare is, everybody says data is the new oil. Well, healthcare's got the fastest growing data collection process in the world. How can all of this come in and help clinical decision-making, patient selection, prioritization, everything that's related? And also the performance of any operation in healthcare. And the third one is really has to do with the services and service quality. And so in a sense, we look forward to everybody's participation in this workshop. This is all about the shared learning we can do together, because I think you're all an expert in your own areas. And what we're looking to do is to ensure that we share understanding of the problem, share understanding of the system that this is related to, and share understanding on how we can act to actually drive the future. And I'll stop here to say that future has to be an equitable health access for all. I thank you very much for inviting me here. Thank you.
I would request our keynote speaker, Professor R.K. Dhiman sir, Director at SGPJ, to please deliver the address and welcome the gathering, as well as his experience of telemedicine and SGPJ. Please, sir.
Thank you very much. Professor Sonia Nityanan, Vice Chancellor, KGMU, and the Director, Ram Manohar Lohia Hospital. Professor Mohammed Ba, who is the Senior Coordinator, Digital Innovation Ecosystem, ITU Geneva. Professor Ajay Kumar Singh, CMS, Professor Nuzhat Hussain, Dean, and Professor S.K. Mishra and other dignitaries, ladies and gentlemen. It's really a proud privilege for me to be the part of this workshop on digital health ecosystem readiness for last mile telemedicine. I have been associated with telemedicine in and many other forms since 2015 onwards, approximately 7 to 8 years from now. I had an observation when I was professor and head of the department of the hepatology at the PGI, that too many patients with hepatitis C are coming to the PGI for the treatment. And we were treating about 1,500 patients in our department per year. But if you look at the burden of the SCV in the Punjab, Punjab is the state in the western side and in India, the burden was 3.6% of the 30 million population, and that comes to about 1 million. That is 10 lakhs. And if you look at the 70% of these 10 lakhs, they are having the active viral hepatitis, means HCV RNA is positive and needs treatment. Then our efforts of treating 1,500 patients per year is grossly inadequate. And the same problem of the burden of the hepatitis C in the Punjab was sensed by the then government. And the then Chief Minister, Prakash Singh Badal, called us to do something for this menace. At that time, then we devised a SOP for treatment in the state level. And the government promised that they will provide the free of the cost treatment, free of the cost diagnostics also. We devised a algorithm for treating such patients. And what we did, we make a capacity building of the doctors who are situated peripherally in 22 district hospitals and the 3 medical colleges, that means 25 sites and 125 doctors. We had a workshop with them in person for 3 to 4 hours where we taught them about the hepatitis C various aspects. And thereafter, we took the help of the telemedicine. In particular, that is the ECHO. You know, the ECHO is from the America, from the Texas, Albuquerque, and I had gone also there. So they were also having such programs for any public health related issue. So we used that one. And after that, whatever the problem the doctors were facing, we were discussing each week on Tuesday between 11 to 2 o'clock. And that's how we trained our doctors how to treat, how to diagnose these patients, and whatever the requirement is there, that we have done. In addition, we trained the pharmacists also and the other paramedical staff also. And that's how we started. Then whatever the treatment of the C patient was localized to the PGI, now it is decentralized to 25 sites. And I tell you, first year result, we treated 48,000 patients with the hepatitis C. So that is the power of the telemedicine or the ECHO that we did it. So I was amazed by thing, and I become very sure that the public health issues has to be dealt with this approach only. And the telemedicine is going to play a very, very important role. And then I shifted to this place, and before shifting, we treated more than 1,28,000 patients in Punjab also. And I came to the SGPJ in 2020 in February. And the next month, that is March 2020, the COVID came, and we utilized the same system here for capacity building of the doctors, paramedical staff, and many others also. And I tell you, that we trained more than 50,000 paramedicals through only the telemedicine that that we have at the SGPGI. And we were organizing every evening when we were having the wave 1 and the wave 2 also, that we were just discussing all of the patient on the 358 beds in the evening for about 3 hours, and providing the best of the care who are admitted, sick patient who are admitted in our COVID institute or the COVID center. So that is the power, actually. We not only that, we also made the tele-ICU available 6 old medical colleges, including at Gorakhpur, Prayagraj, Meerut, Kanpur, Jhansi, Agra. And we make the capacity building that all these ICUs, they were functioning very well with the help of the SGPGI on a model, what you can call hub and the spoke model. So that's something that we did in the COVID also. And besides that, telemedicine, they have already also started the EOPD, EICUs, many other things. And that was an amazing experience that we are now convinced, whatever the public health issues now you have, for example, the fatty liver disease that you have, that is basically the lifestyle disease also. You cannot treat them with the medicines actually. You have to convey the message, what they have to do to reverse the process. And this is only possible with the telemedicine. That is very, very important to me also. And based upon our COVID experience, the government of UP has started the tele-ICU project on a hub and the spoke model. Hub is the SGPGI and the spoke is again the 6 old medical colleges. They will be having 10 to 20 bed ICUs, and that is the state-of-the-art facility that we are providing. That the hub would be having the control of the spoke ICUs also in that. Not only we will be helping them, but also we will be doing the capacity building of the doctors as well as the paramedical staff. And that is going to start by the end of the November or the beginning of December this year only. And I was in a meeting only a week ago with our Honorable Deputy Chief Minister Brijesh Pathakji. The question in front of us was how to potentiate the ICU services of the Lucknow. And all of them, they agreed that the tele-ICU project should also be extended to the hospitals of the Lucknow also, being the SGPGI as a hub also. And I am delighted to tell you that the Sanjay Gandhi PGI has the telemedicine center. The previous speaker has already spoke about it. It is a state-of-the-art facility that was created about 23 years ago. And the first decade was devoted creating the infrastructure, gaining technical expertise, and carrying various telemedicine application projects funded by the state and the central government. The School of the Telemedicine and the Biomedical Informatics were established in 2006, which soon got the recognition as the National Resource Center by Information Technology Ministry of the Government of India. That is a big achievement for this center also. In the second decade, focused on the design and implementation of the national and the state government projects, and I enumerate few of them. One is the National Medical College Network, NMCN, COVID statewide network, EICU network, Smart City Telemedicine, and Sanjeevani Hub and the Spoke Telemedicine Network. And so this center is doing, I would say, the wonders as far as this area or this field is concerned. And now we are in a phase, only in recently in our governing body, we have decided to start few courses over here, academic courses also. And we are in a process to recruit the faculty, 1 professor and the 2 assistant professor in this facility also. I've just given you the few examples that I was associated since my endeavor into this, I will say the direction of the telemedicine, I'm much more than convinced that if you have to solve the national issues or the state level issues and the common diseases or the common problems, I think telemedicine is the only answer, and it is going to create the wonders. And if we follow this, and that's all. Once again, I would like to thank Professor S.K. Mishra for giving me this opportunity to be in front of you and share my experience as far as the telemedicine field is concerned. Thank you so much.
Thank you, Deepa. As you took us to the journey that telemedicine has made at SGPGI, we are grateful to start a similar journey at RML under Professor S.K. Mishra, sir. Unfortunately, Nusrat ma'am, our dean, will not be able to join us in the morning session and will be subsequently joining us in the afternoon session, where she will not only talk about telemedicine at RML, current status, she will also be telling us about a little bit about telepathology and what she has done there. I now request our chief guest, Sonia Nityanand ma'am, to please say a few words.
So, Dr. Dhiman, who's the guest of honor for this function, Mr. Mohammed Ba, who's come all the way down from Geneva, Dr. A.K. Singh, who is our Chief Medical Superintendent, Dr. S.K. Mishra, who's the coordinator for the workshop, and Dr. Shelly Mahajan, the organizing secretary, and of course, Dr. Dana. Thank you very much for organizing this very useful and very much needed workshop. But at the outset, I would like to extend a warm welcome to all the participants and all the dignitaries and all the speakers and the organizing committee. And Dr. Dhiman has very beautifully brought out his journey in the medical field in telemedicine. And before that, a little bit about the establishment of telemedicine in RML-IMS. With the, Dr. S.K. Mishra, who's here with us, has established telemedicine, I think, from scratch at SGPGIMS and brought it to great heights and very useful heights. So when he retired, I always wanted to bring him here at RML-IMS so that he could get it going here in the institute. And initially, of course, he was engaged in other projects after retirement, but finally he agreed, and we've been very fortunate to be able to get him here with his vast experience. So thank you, Dr. Mishra, for being here and helping us to establish this facility here. So if you look at the title of the workshop today, it says Digital Health Ecosystem, Readiness for the Last Mile Telemedicine. The very word last mile telemedicine is very catchy. So we have to get ready for this last mile telemedicine, and that's why this workshop. Currently, this facility is very well developed in SGPGIMS, as Dr. Dhiman has already highlighted and has taken us through the journey, how it has served the population of Uttar Pradesh. And of course, the stark example was during the COVID time. But even now, with the tele-ICU that is going at SGPGI, it is going to impart a lot of training to the different manpower which is deployed in the different ICUs of Lucknow and the state of Uttar Pradesh. So this is the power of telemedicine. I think this workshop, because the country, it's a growing economy. India is really a growing economy. And it's on its path to becoming a global innovation hub. It's very clear now. And it has a strong focus on different reforms, on different infrastructure development and investment in key sectors. So India is really poised to sustain this growth trajectory in the field of healthcare. So with continued focus and the investment in healthcare solutions, as well as recognizing the future thinking as an approach and discipline for future scenarios, India can address unique challenges and create a more accessible, efficient, and inclusive digital healthcare system. This is the milieu of the country. So in this milieu, institutions like RML IMS, apart from SGPGIMS and KGMU, King George's Medical University, need to come onto the path of digital health ecosystems. I think this will be a milestone for all the three institutes to join hands with SJPGI as a center of excellence. And we have RML IMS in the city, and we have the King George's Medical University in the city, that all three join hands together with the Center of Excellence in SGPGIMS to take this field forward for the benefit of people in the state of Uttar Pradesh as well as in the country. Mr. Mohammed, while you're here, we would like your inputs as to how to go forward in this field. And join all the three institutes together. They all are ready. SGPGI, of course, has already gone through the journey, well-established infrastructure, doing very well. And RML IMS, we hope to establish, we're beginning with a unit of telemedicine, but sometime we do hope to have a department of telemedicine, and the same for KGMU. We have a unit of telemedicine, and in future we hope to have a full-fledged department of telemedicine. It's intertwining all the three and taking them forward in the best possible manner. I'm very grateful that you've come all the way and you're here in Lucknow with us to guide us and to steer us forward in this direction. And Dr. S.K. Mishra will also guide us along with you how to take this field forward in these two other institutions. Thank you very much.
Thank you very much, Sonia. It is, I feel immensely proud to be a part of RML and an institute that is looking forward to telemedicine and looking forward towards the future. And also as a student of Professor S.K. Mishra sir, I recently came to know that he has the maximum number of publications in the world in the field of telemedicine, which is a great feat to encounter. I would request him to now come and deliver the vote of thanks.
Morning to all of you. Sorry for my throat. Like a little correction, it's not maximum number of publications in the world, maximum publication in India. Right. Thank you. Okay. So, first of all, I must express my gratitude to all of you who have agreed to gather for this workshop. This very unconventional event. It's not a conference where we meet, greet, and everything. It is a workshop, hard task to cut across our barriers of positions, etc., to all become student, to learn something which is totally innovative in the field of telemedicine. where many things have been done, and we all think we are very great people, but there are so many things lacking behind that is the last mile telemedicine, which are now gathering now here to address it. And it's going to remain a puzzling topic forever. It's just like, I can tell in Indian context, cleaning Ganges, which will take millions of years to achieve. So now, coming to my task of expressing a vote of thanks, I must first thank the Institute, RML Institute, to give permission to hold this workshop. The chief guest today is Professor Sonia Nityan. She not only holds the new position of Vice Chancellor of the King George Medical University, she is also our director. And she has a lot of interest in telemedicine. And I appreciate her commitment and her persuasion to bring me here, which is always a passion for me. Telemedicine, wherever it is, I should be there. Now, her passion also says in the last part of the speech to integrate 3 institutes, who are all icons of the city of Lucknow: King George Medical University, HGPGI, and RML. Some institutes may be a little stronger, some are weaker, but through integration, we can make everybody strong and achieve our mission of how to reach out the last mile telemedicine in a state with the maximum population in India, Uttar Pradesh. People say, if something happens in Uttar Pradesh, this happens in India. Thank you, Sonia, for giving us this inspirational speech. Our keynote speaker today, Professor R.K. Dhiman. He is the director of my past institute, Sanjay Gandhi Postgraduate of Medical Sciences. He is a lot of inspiration for taking forward the telemedicine activities at HGPGI. A lot of things he started in his previous institute at PGI Chandigarh, which continued when he landed in HGPGI. And we got the opportunity to give him helping hands to achieve all those things that was continuing his passion from PGI Chandigarh. Singularly, he also had a lot of passions. During COVID time, introduced this capacity building exercise during COVID times for peripheral institutes, and now landing up in the EISU. This is a massive program that is going to become path breaker in the state of Uttar Pradesh. We appreciate, sir, for your time. Despite a busy schedule, you could give us a keynote speech. Mr. Mohammed Ba, I came to know about you very recently, but your focus of activities really inspired me. And since long, I wanted you to come here and to teach us all those things we have not learned in telemedicine till now. We get all kind of visible things happening in telemedicine, and we all feel that we have achieved many things. But without realizing we're still not achieved what we're supposed to be. It is preparedness. We know very well, in many of the developing countries, we have poor infrastructures to implement telemedicine. It's totally dependent on telecommunication. And the telecommunication is very poor. You might be hearing about 5G, 6G, and satellite, which doesn't exist in the rural areas, or it's not feasible to sustain such kind of expensive technologies in the peripheral areas. So now he's going to really take us in the last, this 2 days, yesterday also we had a big discussion to how to steer this deliberation, so that teach us about those building blocks which will make your telemedicine success or failure. That is the ecosystem preparedness. So we'll try to learn whatever you can, but I'm sure this time may not be sufficient. As Professor Sonia has said, we'll keep pursuing with you also to engage in maybe in the virtual environment to keep continuing, and the massive kind of exercise required to integrate 3 institutes. So we need your guidance and also the other experts in the ITU to join in. Professor Nujat Hussain could not come to such engagement in the Ministry of Health, Government of India, and she has sent a message for complementing our activities. And she was there all the time for us as the Dean, and she herself is very much interested in the telepathology, being a pathologist herself. I know her work for the last 20 years. She's very passionate about this field. I'm sure she will give us a helping hand to take forward telemedicine in this institute. So Salim Mahajan, dental surgeon as a profession, but she has a lot of passion. For the last few days only I came to know about her, and I'm sure with a lot of enthusiasm she has, so she will really be very forced to work on. I'll be fortunate to give her support, whatever she wants, to run this unit of telemedicine, and a commitment from the administration to make a full-fledged department of telemedicine and digital health at this institute. She's already running the program of eSanjeevani as well as ecosystem at this institute. And her colleague is here, Sipra. She's also putting a lot of hard work. And I appreciate the presence of all the experts, either virtually or physically they're present. Also, there are industry representatives. There are also many people from NGO and from health system people who are really going to be workforce, a multi-stakeholder background. They give us a lot of inputs to this workshop. We appreciate the contribution of our IT team here, led by Mr. Akhilan Burma, and all my department colleagues, Malika, Salik, and office staff and IT staff department, and all those institute employees who have supported for this workshop for the function. Lastly, we appreciate the contribution of Adli for giving little support for organizing this workshop. Thank you very much for your kind attention and for being present here.
Thank you, sir. I would now like to conclude the ceremony and request everybody to please proceed for breakfast. Some small refreshment. Yes, why not?
Good morning. Am I audible to all the remote audience? Hello. Hello. Is the audio open?
Sir.
Can someone respond from the remotely? Am I audible to everybody?
Yes, sir.
Well, thank you. So we welcome all of you who are present remotely as well as present in person here to this workshop. And you know, this title of this workshop is Digital Health Ecosystem Readiness for Last Mile Telemedicine. This workshop is being conducted by in collaboration with International Telecom Union and being organized by Dr. Ram Manohar Lohia Institute of Medical Sciences. Myself is Dr. Mishra. And we have many other in-person experts present here. So I'll ask them to introduce themselves. We can see all of you in the remotely, your names are appearing there. And in this workshop also, we have two more institutions that is being participating with us. That is King George Medical University and the Sanjay Gandhi Postgraduate Institute of Medical Sciences. And we have the experts, Mr. Mohammed Ba. He is an expert in digital information system at the ITU headquarters in Geneva. And with him is his assistant, Ms. Udita Chaturvedi. She will be also here throughout these 4 days and helping us guiding Mr. Ba. And the workshop will shift tomorrow to Sanjay Gandhi VGI afternoon in the KGMC. However, we all will be present virtually wherever we go. And we'll come back here on 24th and 25th to continue this workshop, dedicated interactive workshop by Professor Mr. Mahapat, and we will all be present and interacting with him. I just want to request all of you to understand this is not a conference. This is a workshop, which means interactivity is the key of the successful of the event. And now, before we proceeding further, I request all the people here sitting to introduce themselves to the remote audience. I start with Mr. Mahapat.
Yeah, thank you, Professor Mishra. Good morning, everybody. My name is Mohammed Ba, and you can just call me Mo. That's because Americans love to call everybody the name Mohammed Mo. So I work for the ITU, and I learned more about the ITU later, and I basically coordinate something called Digital Innovation Ecosystem, which is to help countries build their innovation capacity. And I'll stop over and pass it to actually my colleagues and probably the brain behind all of the workshop today, Ms. Udita.
So I am Udita Chaturvedi. I work with the International Telecommunication Union, but I work remotely from Mumbai. I work on projects that help countries build their capacity and strengthen their maturity so that they can look towards the future. And I'm helping here do this workshop with Mo. And I look forward to engaging with all of you as we go on to the next 4 days. Thank you.
Hello, everybody. I am VK Singh, and I am representing here Trust Community Library, which is an NGO, and we are working in the variety for implementing a telemedicine project in rural areas. So, just I'll share my experience.
Thank you.
Good morning, everyone. I'm Dr. Manish. I'm Associate Professor in Community.
Yeah.
Hello, everyone. I'm Sujoy Jain. I'm representing data communications in the industry for digital health solutions and the last mile delivery of digital health. Thank you for inviting us here.
I'm Arunama Mukhopadhyay. I'm a faculty at Indian Institute of Management, Lucknow. So I am in the IT and systems area, and I work on issues related to healthcare, IT, and related material.
So hello everyone. My name is Nazir Hussain. I'm a second year student at IIM Lucknow, and thanks for inviting me.
Morning, I'm Sai Siddharth, working as a senior technical officer in Taj Mahal. I work in various projects in telemedicine and healthcare, as well as supporting various states all over India in the deployment and utilization of these projects. They are essentially one and bigger challenges. Thank you.
I am A.K. Shukla. I'm a professor in the Department of Nuclear Medicine and representing Dr. Ram Manohar Lohia. Share my experience in this area in a few hours from now.
Good morning, everyone. My name is BK Jain, and I served the health sector in the UP for more than 25 years in the area of digital transformation and MIS. Right now, and I was working with NHM and SIPSA as general manager MIS, and recently I started in the month of January 23. And as of now, I am working as a consultant in digital transformation and with the Gates Foundation.
Good morning, everyone. I am Professor Shelly Mahajan, professor in the Department of Dentistry at RMLIMS, and also heading E-Sanjeevani as the nodal officer, and also the official organizing secretary for this.
Great. So we will move forward with the first program of today's event is
the remote participant.
Yeah, remote participant. Would like to introduce remote participant quickly. Can you just spell out your names and affiliation? All remote participants.
Good morning, everybody. My name is Rajesh Kumar Kaushish, and I am the National Coordinator of E-Sanjeevani and Joint Director here at the Health Informatics and Electronics Division, CDEC Mohali.
Welcome, Dr. Master Rajesh. Anybody else, please? Anybody else want to introduce yourself, please? I just want to introduce Rajesh Kaushish. He is from the CDEC Mohali. They're looking after the E-Sanjeevani, and they'll take part in the panel discussion today. Okay, so we'll move forward and do the first presentation only first on to talk about this today's event.
Hi, am I on? Yes, okay. Yes. Great. Again, welcome everybody, and it's really a pleasure to be here. And I'm humbled to be here. Number one, this is a medical institute. It's not my field, but everything we learn in life as an engineer, we learn from the field of medicine or social sciences. So it's just that you. Yeah, can everybody hear me? Yes?
Yes, you're audible.
Okay, great. So as I said, okay, so first, let me tell you a bit about ITU. Maybe some of you have never heard about the ITU. It's the little UN agency, according to some people, that's trying to change the world, and you'll understand why. It's actually the oldest UN agency. It has existed since 1865. And if you're wondering why it's the oldest United Nations agency, is because it used to be the International Post, Telegraph, and Union. We joined the UN system after the UN was created as a specialized agencies for ICTs of the United Nations. And our goal is to meaningfully connect the world, because it's not just about connecting the world, we have to meaningfully connect it. And a meaningful connection also means people can access their healthcare, people can do everything they need to do in life in a better, faster, and more efficient way. We have three sectors that we deal with. We have what we call the radio communication sector. So if you're wondering, all of the, and also it handles two things, all of the things you hear about frequency coordination, 5G, 4G, 6G is there. Any satellite that goes in space, we have to coordinate where the satellite is going in the space, because the limited space, same as our frequencies. Standardizations. This video conference system we're using today is most likely using several ITU standards to make sure we can make this happen today. And last sector or last focus is what we call the development. And development is not just about developing countries, developing countries, also for developed countries. So it's really how to bridge that digital divide. And it's also the only UN organization who has private sector membership. So Facebook, Google, name it, all of them are actually a member of the ITU. So it's a union. Now, having said that, we're spread geographically. We don't have an office in every country. We do have one in India that was just open. I'll talk to you more about this. And so we cover all countries. And in the development sector, we try to focus on several thematic priorities, which is capacity development, digital skills, and that means a lot of things: security, cybersecurity, inclusion, digital ecosystems, which is the main topic that I really coordinate, services and applications, and all these other areas. Why ITU? So why are we here today? Because, I mean, we are the UN, we're a neutral body. We believe that everybody can really achieve their potential. So today, we want to ensure that, you have basically the potential to unlock your own socioeconomic opportunities. And socioeconomic opportunities are part of social. There's health there's education, there's all sorts of other things. And one is not together, the other one is not together. The economic part is not together as well. So that's very important. But we have a challenge. We live in a world that's, very volatile, uncertain, complex, and ambiguous. In the past, you could actually develop solutions and you could cater to your socioeconomic needs because everything was not changing as fast. But today, everything is changing very fast. And what do we have? We're still stuck with institutions that acts like the old days. They act very linearly. Governance is very slow while the world is changing. And this is not good because your programs, your initiatives, every intervention you do will be slow if you don't change the approach to this. That's where the ecosystem comes in. So again, as I say, it's about our organization being very solid. They operate in the 20th century, which is the silos, when we really need to operate more like this, where we're agile, we're collaborating, we're co-creating, we're co-designing, including with our patients. And of course, the challenge, as I say, is the technology. Every time there's a hype, telemedicine has been around for over 20 years. Why have we still not benefited fully from it? Because we have not figured out how to do this. Because we have not changed the system that we have to actually adapt to it, right? A few people are figuring it out, right? Anybody feels like on the right, they're always on the phone. And the machine is observing you. What are you doing? You're training the machine. And this whole system is controlled just by a few people, few companies. What does it mean? This is not good for global equity. And I think this is happening in every sector, in healthcare, in name it, right? And the world is just changing, and we need to be aware, and we need to do. And when we ask everybody around the table, and if you're from the different pieces of the ecosystem, we'll define more the ecosystem a bit. If you're in academia, you might say, I need more money. Who will not agree with me that we need more R&D money in healthcare in this room? Who will not agree? Raise your hand and be honest. Who will not agree if you're an innovator that you don't need any more money, right? Who will not agree that policymakers can be blamed for everything? But now we blame everybody, then we blame nobody except ourselves, right? So this is a bit of an ecosystem. I took this slide from the World Bank report. This is, I think, the Isanjeev ecosystem. I'm sure they can talk more about it, but the way we put it is on the right. We have what we call public sector. We have entrepreneurs or innovators. We have academics, institutions, research institutions. We have private sector, different roles. When they're not collaborating, this is like a weak link. The weak link does not let you create innovation. The weak link will delay you leveraging the opportunities to make things happen, right? And in healthcare, this is what it may look like, depending on the context, right? You have funders, insurers, investors, we have associations, we have, but again, everything has to be with some kind of common language so we can speak. Like I'm speaking in English, I speak other languages, but we're speaking in English. We have to have that common understanding. So keep that as one of the principles. Whatever we discuss, we are trying to get a common understanding of what that thing is. Otherwise, we cannot solve it, right? So India itself is a very, very powerful country. It's a country that has a big population, big potential, is growing. It has a rising tech ecosystem and what we call the deep tech. but it also has rising sectoral strength. Healthcare being one of them. But is digital healthcare reaching its potential in India? That's the question we have to answer at some point. Benefits in health tech. What is it? Reach. You can reach more people. More people can be effectively reached. It effectively target underserved areas, allow you to do that. Services, better quality, more appropriate services for targeted communities, efficiencies, productivity gain, etc., etc. We heard it, right? You have an overcrowded hospital. You have 75 districts. How do we now start spreading this load around using technology? How do we only get the doctors to intervene only when they need to intervene? Because they don't need to. I'm fortunate to have a watch that monitors everything about my vital stats. Doctors doesn't know about it. If I go to the hospital, there's a lot of things that gets repeated that just doesn't need to be repeated. A lot of efficiency can be brought with health. Now, the way you add value to health is really in 3 pillars. This is from a really good World Bank report. We'll probably share that link so you can read it thoroughly. But it talks about 3 things. One is basically the clinical and administrative processes. These are the services, how you deliver those services, right? And I think the whole e-health sector came in with EMR, right? It's about health records, about that. But this has evolved a lot more into other things, right? Because technology is not the root cause of change. It's trying to help you change something for better. And in the context of health, these are the things. There's a lot more now. And on the other side, we have the technology part of it. And then and then the core component of all this is the data, the information that you can have, right? Because, I mean, if you think about healthcare, if I go to the doctor, it's basic information, data. Healthcare has the fastest growing data collection in the world. If people talk about data being the new oil and the new gold, it's in healthcare. It's really nowhere else. The number of data points, etc. But this has to be leveraged. So let's step back now and understand a bit why we're not getting innovation to market fast. Right? You want to use whatever telemedicine or related application and services in health. Somebody has to have an idea. Usually this is starting very early in schools, in universities, research, right? I'm sure if you go back and look at research, and I'm sure Professor Mishra will tell us more, probably people started visioning and experimenting and tagging with healthcare more than 50 years ago, since the first AICTs came. But it took a long time before even the word healthcare was, telemedicine was coined. Then in health or in any other sector, it will take another 17, 20 years. However, that is changing. If you're still on a timeline where it takes you 17 years to take from the signal of innovation to using it, others are doing it much faster. And because we're in a globally connected world, the network wins, right? So doctors or all hospital system may be replaced with some machines in the future. With robots, you go there. So all of you could potentially be out of job. Now, if you really want to think forward, right? We still don't have a flying car because flying cars are not practical. I'd rather still have a driving car than a flying car because my risk of dying is higher. We had a bit of chat about that yesterday. But it's still going to happen one day, right? Not today. So we have to figure all these things out. Of course, once that happens, at some point, people have to create product and services. This is called the valley there. At the bottom of this valley, you have product and services. We have product managers there. I'm sure they can tell us what they took to get to that valley of death, right? At some point, there's a small and medium business. At some point, it's a high growth company. This is where it scales, the benefit scales to everybody. Now, is that stuck? Okay, so the another thing you need to understand to diffuse that innovation, there is a process. This is a social process. There are people who always say, yeah, I want this. This is cool. Everybody, you want the latest phone, you want the latest. They don't even care what this thing does. They don't even care that it's an application, right? That's for people who say, wait a minute, I will wait, because I used to be a BlackBerry user. I love BlackBerry, so it took a while before I could switch over to the next slide. So this takes time, right? Now, today in healthcare, in telemedicine, and all of these applications, there is a portion or a big chunk who are reticent to use this, starting with your patients. Guess what? When COVID happened, did they have a choice? No. Are they going back to their old behavior? Yes. How do we make this sustainable? You have to understand this system, and we have to actually build it, right? So as I say, I mentioned this, from the time a new technology comes in, it takes a long time. This is 17 years, probably longer. There are a lot of applications that are increasing, right? You have robotics, you have 3D printing for, making limbs or whatever you want. You have a lot of new applications that is allowing. And this is not only available because of telemedicine, which used to be video communication related. Now it's getting into AI, data, and then the intelligence and the algorithms you can bring to support the doctors. Because what does a doctor do? You go by process of elimination, but you need to have really good information to do that, right? So, okay, so we are at a crossroad in the world. This is not just in health, but in everything. This is why we're doing this, right? And this crossroad can lead to a very negative future for our communities or a very positive future for our communities. We need to identify what it is that future is and how we drive it. So this is why, just to bring it back down to earth and my work at the ITU, we have launched something called the Innovation Entrepreneurship Alliance for Digital Development. We're here within the scope of that. And I'll tell you a bit more. Our mission is to really support new approaches so you can help navigate this changing world, to bridge the digital innovation divide, and to help you build local capabilities. So our expectation out of this workshop that you have some capabilities, some kind of roadmaps, and some kind of action plan that you can move forward, and some systems to solve a systems issue, right? So our strategic objectives, trend research to help you to see where things are going. This is strategic foresight. So we're doing actually a big component of this workshop is the foresight to get ready, to understand, to agree, to disagree, and to move forward with a plan. Then we have all the elements that we're trying to help you with the roadmap that we'll get to. I won't get too much into that, but this is what the Alliance has. I run the center in Geneva, which is the Digital Transformation Lab. We have a center here in India. So these are the ones that are owned by ITU to support and provide the services, but we're also building a big network to connect this. And this network is really, so you can be, RML can be an Alliance partner member, not necessarily a center, but an Alliance member, and also benefit from these services. This is the footprint of what we're rolling out in the next few months, which is a big network. The one in India, you see that's the ITU one, and there's several other countries. So we're looking forward to create a peer-to-peer capacity building, knowledge creation, innovation creation, as well as something that gives you this capacity to navigate your environment. So that's what we're doing. The office itself was inaugurated by Prime Minister Modi in March, I think. And this is what the India Center will do and support. So we look to make sure you're collaborative, harmonized, and work in the same way so you can unlock your own potential, in this case, for last mile rural health. This is a bit of our center, the kind of things. We'll go through some of those processes here. Services we usually do through these type of centers. And this is my last slide. How can we accelerate an equitable rural health for all? There are many possibilities in the future we need to drive. You want to drive that future, or somebody else will drive it for you. And I promise you, it will not be to your benefit. So we will understand what we don't understand, that we don't understand. And then we will start acting and prepare and figure out how we activate this future that we want. That's my last slide. Any questions?
So request all the participants, both in person as well as remote, to ask some questions to Mr. Moore before we proceed to the next session. any clarification questions? She had informed some few things which are very relevant for us, the establishment of the Innovation Center in New Delhi, and also the Digital Transformation Lab, where you can become alliance member, both institutions or state or whatever. So these are all new information that has come to us. So any question to comments?
So in this digital lab that you have, digital transformation lab that you have in Delhi, so what is going on? Are you doing ideation there, or are you creating products, or which stage are you in, and how do we connect onto this ecosystem as we're just talking about? So.
Yeah, so basically, this whole thing is a massive ecosystem orchestration model. We don't have an incubation space sitting there. We don't have an acceleration space sitting there. What we have is processes and services and connecting to other systems. For example, we are in CDAT, in the premise of CDAT right now. There next to CDAT, there's incubation centers. There next to CDAT, we also have TCOE, which is actually provide some of those services. So think of this center in India as a restaurant where you come in and you order certain services. And these services then are orchestrated in the back end through the kitchen, which will be the other stakeholders in the ecosystem. And this ecosystem is not only local, regional, but it's also global because they're all connected as a network. Now, the services you have access to is very simple. So let's say what we're doing today is a strategic foresight on the futures of rural and last mile health within your country. That's a service, right? To deliver that service, I can do it there, I can bring you all there, or I can come here and have it done here, which is what we're doing. And the outcome of that then activate the ecosystem you need to take action, to understand what you don't understand, where you want to go, and to take action. Another service is, for example, what we call open tech innovation, which is really taking the next step could be that we take this ecosystem that we have identified, we activate it, we put a governance system in place, and it has a roadmap. It works forward, and then it has an innovation process. So call it like a living lab, a living ecosystem. The next process is that we may have some talents, SMEs and entrepreneurs, who have developed services, they're product ready, but they need to scale globally. Then we support them through services through the network to scale globally, using, again, an ecosystem approach, because scaling is not going to another country. It's understanding how to go there to another market, how to connect to that ecosystem, right? Think of it, Uber developed their business. It's also fine-tuning your business model to be ecosystem ready. Then all the scaling is about ecosystem. It's not about, because all of the model changes. And the fourth one is really policy experimentation. You may need to experiment with some technologies that you don't have permission because they're new. Is to help you put together dynamic sandboxes that can allow you to do this. And the condition you need to experiment and then to take it to the next level. So it's a lot of the anticipative policy, but also active policy, experiment and acceleration. And the last one, capacity or service, is to allow people to create initiatives together as an ecosystem. So I'll stop here, but that's just a bit of the, and we have these capacities distributed throughout the different parts in peer-to-peer model, and also owned by the stakeholders. The only entities owned by ITU are the one in Delhi and the one in Geneva, and they just serve as a sort of orchestrating, building, pass-through sort of model.
I'm just very curious because you said a very exciting thing. So, so what is the project like? That you have 5 villages where you want to provide healthcare delivery, or is it even such bigger scale? So I'm just very curious at what type of projects that you're rolling out, or what do you have in your mind, and currently what's going on there in this lab?
Yeah, so what's going on is we help other create the knowledge creation, project creation, policy creation.
So are you funding those projects also? Or
no. We don't fund. There's usually all of it is funding by the stakeholders themselves. Even the centers are funding by the stakeholders themselves. What they don't have, think of it this way. You buy an empty laptop. you have a desktop, you have a server room. What we create is the operating system to run it and to share the information and to share the best practices, to share the policies, to say this is the model.
Okay, so we'll conclude this session and go to the next session, that is the panel discussion, where all of you are going to contribute. I request Mr. Mohammed to little bit to outline to this panel how we are going to conduct this panel. I've circulated a mail yesterday evening, so I have all received that. So I'll request Mr. Bauer to expand it.
Yeah. Okay, so again, so this is the first part of our interactive discussion, and I will encourage every one of you to be participant to this. We don't know what we don't know. I know a bit, you know a bit, you know a bit. But when we put it together, we have a clear signal and a clear action plan. So the discussion here.
Should I introduce all the panelists in this?
Yeah, you can introduce, and also you can introduce the session topic.
Yeah, session topic, of course, is the digital health ecosystem and the last mile access in India. In this panel, IT wanted is a multi-stakeholder participation of this panel. So I invited people from different verticals. So studies from our own institutions, so she's managing a telemedicine program. So she's a practitioner of telemedicine in the hospital setting. We have Dr. Priyanka Bagade, assistant professor in the computer science and engineering in IIT Kanpur. We have met Dr. Sanjay Sood and his colleague, Mr. Rajesh, which are already present in the audience now in the virtual setting. They are from the eSanjeevani National Telemedicine Service System located in Mohali in the Center for Development Advanced Computing. They have developed the system and they're operating it and monitoring it and mentoring it across the country. Mr. Sujay Jain, he's here and representing Tata Communication from the industry side. He's the product lead from the Tata Communication, and his boss was supposed to be here. Mr. Ramdev could not join. There was some personal reason. So Mr. Ramdev is the lead.
Ramdev has joined online.
Joined? Oh, joined. Oh, great.
Good morning, I'm there. I'm here.
Appreciate that you could present yourself. And we have Mr. Deepak Srivastava from Meta Plus, which is here. He's supposed to come from startup vertical. So they are working in the rural health. We have Professor Aruna Mukhopadhyay. He's here from IIM. He's the dean in IIM Lucknow, Indian Institute of Management, Lucknow. And he heads the IT system department in the IIM. We have Professor Divakar Jadhav from IIT. I hope she joins from IT virtually. Are they there, Mr. Jadhav? No. So we have Mr. B.K. Jain. He is the ex-general manager from the National Health Mission, Lucknow. So he's here to share the experience during his days in the health system, the policy and the system issues in the e-health. Mr. Santosh Kumar and team from Cross Community Livelihood. I think Mr. Vikas is representing. Okay, he's here. Anybody elect? From our team here, Mr. Manish Singh, Dr. Manish Singh, he is assistant professor in community medicine from our team. And we have other team members also will be joining us. And this session will be chaired by Mr. Mohammed Ba, and I'll be having him. And also Vita from IT also, Mr. Ba. Mr. Ba will be coordinating the session. I request Mr. Ba to take over.
Thank you, Professor Misra, and again, welcome to our distinguished panelists. I am really humbled to be here and to be moderating this. So I think just to set a context, we're talking about a future where telemedicine is helping deliver an equitable future, right? Equitable health for all, or universal health, whatever you want to call it. We've heard earlier in the presentation, in the opening, some of the challenges that it means for the three institutions that represented in this consortium, right? And from basically overcrowding in existing rural urban areas, but as a result, perhaps because some of the capacity in the rural areas are not adequate, so everybody's coming here, from the performance issues that's faced in terms of service delivery to other issues. So what we try to do in this panel is to uncover, to step back a bit. Telemedicine has been around for 15, 20 years, more. We have some of these institutions who have had some good experience with, others are trying. We want to step back to talk a bit about what do you see the future of last mile healthcare access in India is 10, 15 years from now. Okay, not today. We'll come back to today. But let's figure out where we are going. Why 10, 15 years from now? I think 10, 15 years is good timeline because 10 years is usually a political party terms, 2 terms, and then you add another one. So just keep it very simple and structured, right? So if you are going to be the leader tomorrow, and you have to tell the population that 10, 15 years from now, you're going to change this for everybody to create this sort of equitable social future. Well, then we want to know what you see as this future. So on that, so the first question will direct to 3 speakers. If you are looking at 10, 15 years ahead from now, and this the first speaker will be Dr. Sanjay Sood from CDAC. And so if you are looking at 10, 15 years ahead from now, how do you see the future of last mile healthcare access in India? So you have about 3 to 5 minutes for your intervention. Floor is yours.
Mr. Rajesh Kausal, Sood is not joining. He's calling.
Okay.
Thank you.
Rajesh?
Thank you, Chair. On behalf of Dr. Sanjay Sood and on my personal behalf, I once again congratulate the organizers and respected dignitaries, my dear friends. Thank you for this opportunity and very interesting panel discussions. I mean, we always talk about the existing scenarios and try to figure out what has been done in the past in the implementation. So once again, congratulations on choosing the exact theme and the direct pinpointed questions for the panel discussion. Well, just a one-liner to link up the things for the future. As we all know, telemedicine and digital health has now in India is at that stature where it has gone gained significant traction, at least in India, especially during the COVID-19 pandemic, where we have seen major initiative by the Ministry of Health and Family Welfare in terms of first legalizing the teleconsultations in India as a very first step, because every time you would talk about telemedicine, the common questions, the speakers or the users who would use the telemedicine would face was, what is the legal implementation, what is the data privacy concerns, blah blah. So I would say with the introduction of this telemedicine practice guidelines and the lot of other key standards, at least those have been put to rest now, and we can now, with the eSanjeevani, I'm proud to share the figure today. We yesterday clocked 15 crore teleconsultations powered by eSanjeevani, that is 150 million teleconsultations. And out of these, even if we take care of the very genuine and very pressing teleconsultations directly by the patients who would not, deviate from the system-oriented things. That means they are very eager to get the teleconsultations from the service provider onboarded onto the systems, and that figure is also staggering at 1 million direct patient to doctor consultations. So the future, as we are talking about here, is likely to see further integration of the telemedicine platforms and digital health solutions in order to provide the remote consultations, diagnosis, prescription services. And in more specific, in terms of 10 years from now, I would say the system is mature enough to take the next leap ahead, where we are talking about a lot of AI-based solutions already implemented in the existing system, and we would see the amalgamation of the last mile healthcare accessibility in terms of probably the most challenging aspect, where in case I'm initiating the teleconsultation right from my home, but then around in 60 to 75% of the cases, the doctor at the other end would prescribe me the
not the medicine, but would ask me to get some specific test conducted. So in the very near future, it would be very interesting to see how this is to be addressed at home care. That means I am initiating a teleconsultation. We have 24/7 OPDs available into the system. But the moment, even if I am saying that, especially in light of COVID, where even high temperature of, let us say, 1.2.5 degrees centigrade, and the doctor would not directly be prescribing tests done, maybe for dengue, maybe for malaria. But then, the system, from the whole digital ecosystem, then would sort of be immaterial if the person who is down with a 102 degrees centigrade temperature, and he's looking after 3-4 different solutions to book the test at home, then to get the results, get them updated in the solution in which he is trying to take the teleconsultation. So the very near future, I would see in the line where thanks to the ABDM ecosystem, where I can, based on the certain integrations, I can enable all these services, including the wearable devices or small point of care diagnostic devices, which can be integrated, which could be made affordable by the patients and can be self-operated by them, so that whatever in the very first line of treatment the doctor is prescribing to the patient, he is not only able to do that, but also collect them as an integral part of the one single or one solution. In case it is not feasible to get this collected, at least the ecosystem is there wherein I can use different system but still pull the medical records or health records defined by the ABDM across the ecosystem in that one particular solution. Then another aspect which, based on our experience in the last 3 years, I would say needs immediate intervention is the availability of the trained or skilled manpower. So irrespective of whatever digital innovations you do, even today, after 3 years of rigorous implementation, dedicated team involved in the hand-holding of the practitioners as well as the skilled manpower. And when I say the skilled manpower, it is primarily the providers or the CHOs or the health workers at the ground, as well as the medical practitioners, because as we are aware that this program is government oriented, and even the doctors are overburdened. So can we now really thought about having a dedicated cadre for telemedicine or digital health ecosystem, where the practitioners are, we should have innovating financial models. I mean, as on date, some few states have initiated this, where they are incentivizing the doctors for the teleconsultation, but at the same time they are struggling to audit the teleprescriptions in terms of the quality parameters. And that mechanism would be there in the existing system down the line in another year or so. But the key challenge would still remain of that of the skilled manpower and the innovating financial models. And also, of course, because you cannot, race in the chain stating that we are from public. So we need to have a public-private partnerships where we can have unique modeling which can lead to innovative solutions, delivery at the last mile healthcare accessibility. As on date, out of the, let us say, top 5 grievances or suggestions which we receive in the eSanjeevani ecosystem, the top one relates to the connectivity. So owing to, we are even in the urban areas, even in cities like Chandigarh, Mohali, I'm more than sure same would be true for you, everybody in the cities from which you belong. Even at a 4G connectivity in the cities, I am watching a YouTube video or I am doing some digital transaction. There is a certain apprehension in my mind whether this will be completed or not. There are drops in the connectivity. That is something which we definitely need to take care, because even if we are migrating from 4G to even 5G technologies, talking about 6G technologies, but believe me, around 70% of the grievances pertains because the people think that is the solution. But when we deep dive into the technical know-hows, we see that it is not the the digital solution. It is actually the connectivity which needs to play a more reliable and more authentic role in the entire ecosystem. And to sum up, the innovations we are talking about in the very near future, including the next 10 years or so, the future would be data driven in decision making with the help of AI. So the right from the data collection to the analysis of the healthcare data, which can lead to the better resource allocation, specific targeted interventions, and improve healthcare services in the underserved area. I think I have taken more than 5 minutes. I would, because there are a lot of thoughts still in my mind, I would like to share. But thank you so much, my dear colleagues and distinguished persons on the chairs and committees. I leave the stage open for the other panelists to deliberate this.
Thank you, Rajesh. And I'm trying to unpack it slowly, but I think you took us a bit out there and give us a little bit more context. But if I want to recap, I think what you mentioned is that you want this seamless future where somebody can actually access their healthcare from home. And this really has a lot of implication from, getting connected to access this healthcare to having a one-stop shop. So it's seamless and an ecosystem that support that service from, getting an analysis done. I mean, if you're sitting at home, why can't you order healthcare like Uber, including getting your blood done at home? All of this, by the way, all of this is here today. So we're clear, huh? It's possible today, we just don't have the system to do this. And in effect, this should probably be a near-term feature. It's not necessarily even a longer-term feature, right? But as I say, things take a long time and we'll get to the why. You mentioned some of the why, which is infrastructure, partnership, which is needed, which is more on the strategic part, and connectivity and the data-driven part. I would like to now move to, thank you again for that intervention, to our second panelist, Mr. Jain. Can you tell us a bit the same question? If you're looking at 10, 15 years ahead from now, do you see the future of life? How do you see the future of last mile healthcare in access in India?
For you.
Yes.
Actually, I would like to add what Rajesh has said just now. E-Sanjeevani has proved to be a very important intervention as far as telemedicine is concerned. And role of CHOs, as of now, we have more than 16,000 CHOs who are working at these health and wellness centers. The CHO means community health officers. So they are providing they are giving very good services as far as telemedicine is concerned. And daily, we are having more than 50,000 telemedicine consultations as far as E-Sanjeevani is concerned. And Rajesh would agree with me. And they have really played a very important role. And
correct, sir.
Yeah. Then two more interventions I would like to add, which government of UP has done. One is outsourcing the entire operations of PSCs to private providers under PPP, public-private partnership projects. One project is called EPSC project, and wherein a 3 years project is allotted to a private provider called Doc Online. And those as pilot project, we have identified those PSCs in aspirational districts. And aspirational districts are the most backward districts in India or
aspirational districts. They categorized in the very criteria.
So to provide healthcare delivery in medically unserved and the unserved population, those selection of PSCs was done. And as of now, if you look at the data, more than 1 lakh registrations have been done in those 8 PSCs, plus 2 PSCs were selected from Varanasi and Gorakhpur. And those were urban PSCs. Then more than 2.5 lakh telemedicine, teleconsultations have been done in last 3 years. And the beauty of this project is when we say the entire operations are outsourced, that means diagnostic part is taken care by the private provider, medicines are given by the private providers, HR part is also looked after by the service provider. When I say the service provider, HR part, that means 3 persons, 1 pharmacist, 1 lab technician, and 1 A&M GNM level type of worker is there, who is working as a link and connecting the doctors who are sitting at the hub, which is located at Hyderabad. So this is something which is a unique kind of experiment which was done by the government of UK. Then another project.
To put clarification on this, business model.
It is
you're talking about.
Yeah. So we are paying 130 rupees per consultation to the service provider.
Now, I mean, thanks for explaining it.
Here's another point to say.
Plus another intervention which was introduced, Rajesh is well aware of that. That is, we are having health ATMs across all centers in UP. Hindustan Antibiotics Limited, which is a Government of India enterprise, they have placed 290 plus health ATMs. Plus, recently, Government of UP has ordered 400 plus health ATMs from YOLO and 2 other service providers are there. So, as far as HCL health kiosks are concerned, we have a telemedicine solution installed on that platform. What is done? That POCT kind of arrangement is there. 30 plus tests are conducted on the health ATMs, and results of those tests are shared with the doctors. There is initially we made pool of 10 doctors, and those doctors can be accessed through health ATMs. Patient can connect to those doctors who are available at the hub. And after BMI and all those kind of reports are accessed by the doctors and the interaction happens, doctor provides the prescription on the wards of the patient. And since the medicines, they are all free in government setup, patient can take that prescription and contact the pharmacy part of the PSC. So that is another model which has proved to be very successful. And CDAC has also worked in this direction. They were integrating health ATMs with the eSanjeevani platform. And eSanjeevani, no doubt, is very successful model, and that has taken place in the telemedicine sector.
This is a very important point that you please note. This is a model that is running in Uttar Pradesh. The only thing you have to be very careful about the quality. The consultations I'm getting, whether it is really, can be assured, quality can be assured, number one. Number two, the test we are doing at point of care, those tests has to be validated. These are all based on the cartridges. This is a question that is coming up now, because compared to the NABH accreditation of the laboratories, these kind of tests are not being accredited by any agency. So you have to be very kind of...
we did some pilot at Civil Hospital before placing those ATMs.
So have you compared this?
So we have checked, the results are almost
comparable. So this is basically at the local level, state level. But if you want to universalize and teach to the other countries, then how can you really make these things compared to the standardized lab? We should have our own standardization in the state level or national level, whatever it is. This kiosk is a very good model for the...
So can we maybe let's defer the detailed discussions to the actual workshop. But what I want to do is, again, very simple, 10, 15 years from now. So I think most of the things I've heard right now is what we're doing today, right? There could be a completely different model. All of these things you're building today, 5 years from now, 10 years from now, this could be completely replaced by some foreign company or something completely different. So all of this investment will be useless. I want us to step out of what we're doing today. Really, let's think about the future. 10, 15 years from now, what's going to be there? Really, that's the question and then we'll come back to today before we can determine what's right. And as I said, this future is long enough that we're not too much think about what we're doing today, that we can open up our vision to that, right? And I'll be this is about what we want to get is, what does it mean? I mean, there's a lot of technologies that are coming together. You have a lot of people graduating from medical fields. What is their future going to look like? As a healthcare system, what is that going to mean? So, but thank you for really bringing those points about what's being done today to sort of address the situation that you have today. But with that, I'll come back to you on this, but just think about it because I'll come back to another round. I would like to now go to our private sector guys. I'm sure they're going to tell us a lot about the future, right? So, Mr. Sujay Jain, paint a picture for us. What do you see? If you have to travel ahead in time, what do you see?
All right. So if we take the horizon as the next 10 to 15 years, right? So what we see is a completely interconnected and a seamless ecosystem of healthcare. Today, what is the problem that we are facing when we go ahead and deploy certain things, when we go ahead and actually put them into places? There are 3-4 major pillars to healthcare. One, if I'm a patient, if I go to, say, for example, as sir was mentioning about health kiosk. If I go to health kiosk, I might have certain parameters, certain prescriptions in one system. Tomorrow I go to a certain different system, then I have to do those certain things again and then have my information there. There is no linkage between system 1, system 2, system 3, system 4, system N. So the point where we see the next 10 to 15 years, this healthcare space is reaching is the point of standardization. Standardization, or in terms of, if I talk about technology, it is known as a dynamic platform, as we call it in the sphere of technology, as the platform should be dynamic so that it can interact with different systems, pool together the information and give us a complete picture of that patient. So what this entire thing is called as, it's a patient-centric model, what we've been talking about since last, specifically last 5-7 years since COVID came in, and prior to COVID, a couple of years, patient-centric application. So I believe a lot of work is being done towards that, and that is still in the kind of ideation, conceptualization, and some sort of a small POC kind of stage. But in next 10 to 15 years, I believe all these things would get standardized. And what I believe ABDM and NHA have been working towards that as well. Then the next point, what we see is, we see a lot of, because once we have a standardized system, there should be a flow of information. Now, who would own that information? So even that point is being taken care through, for example, ABDM is coming up with the health information exchanges. Now, these health information exchanges, what it is giving the patient the power to allow somebody to utilize their parameters, to utilize their information. So even the flow of data in this entire seamless system is another aspect that would again become stronger in the next maybe 7, 8, 10 years. Then when we talk about this entire ecosystem as sorts. So if you talk about healthcare, there are 3 or 4 different parameters that we look at from an ecosystem perspective. One is your technology, as we were just discussing. The other is your patient. The other is your care providers or the doctors. But one aspect which Mr. Rajesh was also mentioning was the network, the connectivity. Today, we talk about and boast about facts that, network has reached to the and penetrated to the deeper and the rural parts of India. And as I was mentioning that even with a 4G network in urban areas, there are certain drops. But with coming of 5G, 6G, private networks, public networks, PSAT, and the cost coming down, that again strengthens the entire ecosystem. So because we come from a telecommunication background and then we are entering into a space of healthcare, the major reason was that we also identified the problem is not with the patient, the doctors, the availability, the technology. The problem is with the core, which is the network. Without network, at the end, what is telemedicine? Telemedicine just becomes a piece of box, right? Without the network, nothing can move. So again, in the next 7 to 8, or maybe lesser than that, even a 5-year horizon, we see a very strong network penetration. These are the 3 points that maybe we as an organization, a profit-making organization would look at it.
Well, thank you. I think technology, you're right, is changing. Technology is improving. And hopefully the seamless future will come through and will make this healthcare a bit more equitable for all. I'll come back to the idea of the network, but I think we could think of a bit more futuristic picture. And I'll open this question up for our next speakers, because now we've gone to you, the private sector. I'd like to maybe go to our next set of speakers. Here, I want to change a bit the question, right? And we go to practitioners. What stands out as the most critical challenge for India future when you have your eyes set up for the future you just defined, right? And this will be for Dr. Shali Mahajan from RML. Now, again, they talk very much on the technical side. Infrastructure, we're doing this, we're doing kiosk, we want this seamless business. You have to deliver the services. What services do you want to deliver 10, 15 years? What services would you like to see delivered 10, 15 years from now? And what stand out as challenges to do that, right? Because I don't care about the technology, I care about the end result. We have covered all of this now. I think he mentioned three things: patients, technology, right? And the last one was exactly. So let's assume some of those are there. What services do you like to see, and what are the challenges from a practitioner point of view?
Thank you so much for giving me this opportunity. And I would like to say that doctors are all there for patients, and we've all been working 24/7, and it was proved during the COVID times. Right now, what the problems we are facing is, like, when we are to deliver that, first of all, the infrastructure should be such that it should be eco-friendly. We have to have manpower. There are not people. It is telemedicine is still seeing that where Horizon is there, but we do not have it as a specialty. So we do not have many manpower. So that is one of the biggest lagging criteria, that it has to be made one of the specialties in medical field. And apart from that, 15 years from now, I would see that it is made as a department. It is also there in the curriculum of MBBS, where everyone is oriented, that it is, one of the prime reasons where we can reach these last mile places. And there are people, as we were talking, there were people like who are quacks, we are fighting with them. So how eco-friendly we can incorporate them as our, we can strengthen up the delivery part of it, how we can communicate with them and also deliver the best of the practices. Also, administratively, it should be mandate that telemedicine is, one of the equal parameters of delivering healthcare. So that is what I would like to add. And so from next 15 years from now, I think it will be one of the strongest points, as how we are delivering in the urban areas, we will be connecting it, the rural areas of the main way.
Thank you again. And thanks for adding to that context in terms of the practitioner, what practitioner wants, right? Infrastructure, we heard what's happening, what the future should be like. We don't have patients here. We're all patients, by the way. We have to empathize with the patients, right? We're all getting older. I refuse to wear glasses. I read like this. I know I have a problem, but I still don't do it. We're getting older and older. We're going to have issues. So let's empathize with that. Now, I think those are valid challenges, which is some of them are political layers, policies issues. Some of them are system issues. We have medical institutions who are really graduating a lot of people, but this has to be a cause. I'm an engineer, but I'm a policymaker now. I think every engineer should be policymakers, right? You're a doctor, you should be also a technical person, because there's no future without technology, honestly, right? Because we don't exist without the silo. Same question to our second panelist, who is remote, I believe, Dr. Priyanka. Is Priyanka online? Okay, Dr. Priyanka. What stands out as the most critical challenge for India's future when you have your eyes set out for the future we just heard, or that you would like to define 10, 15 years from now?
I would like to see the connected healthcare, where all the hospitals, ambulances, patients, nurses, irrespective of which city, which village they are located in, they should be all connected. So whether it's the urgent care or whether there is some request coming from ICU or whether there is some emergency going on in ambulance, or even in the small clinics in villages, all the doctors should be connected. So AI should allow, or the robot should allow to be controlled the surgeries or the treatment remotely. So even if the experts are not there on the location, they should still be able to help these patients out remotely. And I guess that will save lives of tons of people. So this is what I think, and that's where we are working on connecting ambulances and hospitals together with Tata Communications. So they recently launched this tele-ambulance, and we will be collaborating with them to deploy it starting from with UP and then across the India.
So thank you for your intervention. So you do share this vision that everything has to be connected. When I retire, I'd like to go in an island where there is no connectivity. I'll just say that. But okay,
so connectivity from the medical point of view. Connectivity
Please take us with you on that island.
I don't know yet, but again, it's a joke. But I think technology. But there's a great vision. It's just that I will not have healthcare in that case, so I'll have to figure out something. But I mean, I think we share the agreement. This is where the world is going. And you also share, because you're in an institute that's actually creating this solution. So you mentioned some of the services you have. You have the tele ambulances.
Yes.
You also want the telesurgery, I guess remote surgery. Can you expand on more services that we will see in the future? That in that 10 to 15 year future, what other services do you see needs to be deployed in this area? And what are the challenges to get those services? And this is back to you, Dr. Priyanka, or maybe you can come back to our friends from Tata here as well.
Sure. So I would like our product head and business head Ramdev sir to also give us insights on that. Yeah.
So we can come back and to that, but maybe think about that. Maybe I'll ask just that question. Let's take that question, in fact. So Ramdev, can you answer that? What other services do you see?
So, Mohammed, you will get an island where you will not have a connectivity, but you have to switch off all the devices because we are going to trace you. That's the world is moving on to, right? That is called interconnected that we talk about. Let it be tracking the citizens, let it be tracking the continual care, etc., etc. So I would divide that, and in 20 years from now, currently, I would appreciate the e-Sanjeevani. I'll just take a pass and talk about e-Sanjeevani. I met Mr. Sanjay Sood. 20 years of his dedicated, effective way of delivering telemedicine. Today, they have reached an applause to their effective support. Patients, they believe that India would move towards telemedicine, and COVID has supported I'm taking it in a right sense. One of a positive thing is technology is adopted by doctor. Coming back to the future, the three things that I would see, we divide that into a space called edge, which is called the last mile. The last mile, when I talk about, is a patient, could be for a teleconsultation, could be for an emergency care. And your fitness or some sort of an proactive care. These all are the 3-4 items we consider the last mile. Then we come to the core, which is called a switching, where you talk about the specialist doctor, the rural doctors, provided public and private sector. This is called the core, including the hospital. Then we come back to the final stage where the chronic illness patient, where you do whatever. They just wanted an empathy. They wanted a care. You will not be cure them because we all know, stamp them that This is a chronic illness that you will not be able to cure, but we rest assured, we extend your life. We are there with you. That's called a continual care. These are the three sectors that I would see, which label them as irrespective of public, private, name them various healthcare service provider. You will have only three. What they will do, they all have an interconnected. So edge component, you call the telemedicine, e-ambulance, e-ICU, home care, all that is there for your edge component. It could be a various service provider, but they all are interconnected with one platform. Coming back to the hospital, thanks to NHA for coming up with the policy, I'm sure with the data retention and data security policy, along with who owns and who shares, that particular policy would help to make sure an authentic view for a patient to know where he is, what he has done, and where is he going to be. On your continual care, what we see is basically an empathic, like doctors who are available at the core. We will have a doctor hub, we will have a preventive care hub, we will have a specialist care hubs who will be centralized to support this massive population in a more effective way. The start is what the telemedicine success rate 2 crore is an effective proof that one can make sure the technology is adopted by the hospitals. The technology is evolving in giving a last mile access, and as a core component, a platform is created. So I would see a platform would be a player which both our service provider and your technology provider would combine together and give a proper clinical for the patients. This is what I foresee as a combination of technology and our service providers.
Thank you. Thank you again for taking us forward. Give us another picture. For giving us another picture of how you break this down into the various components and what it means actually that, which is you got, I think some of our previous speakers talked a bit about, because we're getting into this platform concept, right? A platform has these communities, and these communities can get different services, and there is some bit of data that's cross-shared underneath to benefit everybody. So that's something that we have to certainly think about working forward. And in terms of the challenges, there's some that stand out. But let me maybe go to our last speaker on this block about this question, which is Mr. Santosh.
Sorry, this is then team from Trust Government.
That's okay. Okay.
माफ करिएगा मैं हिंदी में बोलूंगा.
So please.
Somebody else can translate.
Yeah. Apologies. I'm reading an old script where the names were not updated. So, but please tell us what stand out as the most critical challenge for this future. We have heard a bit about this future. If you have your opinion about this future, please give it. Then tell us what are the challenges to get there.
ये हमारा जो मॉडल है, बेसिकली हमारे जो ये दो लोग हैं, ये एक तरह से सर्विस प्रोवाइडर का काम करते हैं कम्युनिटी में. ऐप बेस्ड टेक्नोलॉजी है जिससे कि ये अपने सिम्टम्स को प्रीड करते हैं. उसके बाद इनको प्रिस्क्रिप्शन मिलता है, तो प्रिस्क्रिप्शन पेशेंट को देते हैं और उसके आधार पे इधर वो नीड होती है मेडिसिन की या फर्दर किसी क्रिटिकल टेस्ट की, वो करा करके फिर डॉक्टर को भेजते हैं और उसके आधार पे मेडिसिन प्रोवाइड करते हैं. जो मतलब एक क्रिटिकल चैलेंज है वो बेसिकली ये है कि एक तो पेशेंट के लेवल पे ये है कि एक बार पेशेंट इनका करता है, उसके बाद फिर ब्रेक हो जाता है उनका, वो कंटिन्यूटी नहीं रहती. तो उसको कैसे रेगुलर मिलता रहे इनको सर्विसेज. और दूसरी चीज जो टेक्नोलॉजी की प्रॉब्लम होती है, वो रिमोट में होते हैं. बेसिकली कम्युनिकेशन वीक होता है, एक बार मतलब कट ऑफ होता है, 2 दिन लग जाते हैं किसी का इंफॉर्मेशन भेजने में और वापस आने में. तो दीज आर द वेरी क्रिटिकल. और वो कैसे मतलब, लेकिन मतलब जो हम लोगों ने नीड महसूस किया है वो ये है कि आज भी रिमोट में बहुत सारे ऐसे लोग हैं जिनको की सर्विसेज जिनके तक नहीं पहुंच पाती, खासकर ओल्ड एज और महिलाएं हैं. महिलाओं के पास इस तरह के क्रोनिक डिजीज हैं जिनको कि शायद एक्सेस नहीं है हेल्थ सर्विसेज की, उनके तक ये लोग पहुंच पाते हैं और वो बहुत उनको महसूस भी होता है। कई लोग इनको कमेंट करते हैं कि हमसे तो कोई पूछने नहीं आता, क्योंकि जो हमारा सिस्टम है, सोशियो फर्टिलिटी सिस्टम है, उसके चलते उनको हेल्थ सर्विसेज नहीं मिलता। तो वो बहुत नीड है इस तरह के सर्विसेज को। तो इसको कैसे, मुझे लगता है कि अगर लोकल लोगों को ज्यादा कैपेसिटी बिल्ड करके और इस तरह के हेल्थ सर्विसेज को एक्सेस दिलाया जाए तो वो एक बेहतर काम हो सकता है। थैंक यू।
We are also working in Bahraich, which is one of the
further what he said.
I think, can you show that video? It's a 3 minutes video and it shows their work.
Should we come to the video of the workshop?
Yeah.
After
highlight the
issue is they are charging ₹50 per consultation with the rural masses. So what she was telling, she is Isha, local village level worker, and she is helping them in connecting the patient with the app. Through app, some doctor is connected. Within 10 minutes of consultation, the doctor provides the prescription. And with the help of that prescription, the patient has to buy the medicine from the local medical shop. So the problem is people are not paying even ₹50 for the consultation.
So the doctors are being fixed by them.
Yeah, there is a technical partner called Evolco, and they have hired some medical doctors who are sitting at a place, and they are connecting with the help of app. There is an app, so they feed the basic data of the patient and whatever analysis they do at symptoms.
And the girl here, she's a grassroots health worker.
Yeah.
She connects, even he said that old people, women, they cannot reach.
There are many needy people.
She facilitates. You also raised the issue of bandwidth network.
No, of course.
So that is problem is there.
There is very much problem.
Yeah. So I assume we'll solve all those network issues, right?
Dark zones are there.
So I think what you're mentioning here is a new business model you're putting in place, which you're trying to experimenting with. Is still struggling for the self-funding because people have other problems. Maybe they don't see help as the time and you have to feed yourself. There's different issues. Yeah, you want to add something?
I just want to add, like, since we are talking about the last mile, so the most important person or the stakeholder is the patient itself.
Yes.
So what I could find from my studies and all was that we need to build confidence of the patient in the telemedicine delivery of healthcare as well, because the patient is not confident enough to like whether he will be getting the proper healthcare through telemedicine. But it has been shown, and even the doctors have to be more familiarized with the digital things that are coming up. So maybe what Dr. Rajesh was telling, that capacity building of the doctors as well as building of the confidence of the patient, so that we can channelize them through the telemedicine. That will help in reducing the workload in the hospitals as well.
Basically, what is that? Trust deficit. The
Trust deficit is there, yes. So they feel that for minor ailments, they can go for telemedicine, but not for like chronic conditions, not for follow-up for surgeries or for postpartum care, which can actually be covered through telemedicine.
So I think this is great. But again, I'm not a fortune teller. There's no such thing as depends who you're talking to, but I'm not, we can all tell our futures by thinking far enough. The most interesting thing about the human brain is the same place in the brain that recalls the past is the same that's used to create that vision of the future. Do you guys know what a gut feeling is? A gut feeling is something we already know. We just have not connected the dots, right? Now, I want you to be completely out of the box. Before I move to the third question, anybody want to take this and tell me, if you really have to be outside the box, what will the future of healthcare in rural India or last mile healthcare will be in India? Anybody in this room or remotely? Would you take a chance?
Sir, may I have the honor, sir?
Yeah.
Sir, with your permission, sir, may I have a couple of minutes here?
Yes, please.
Thank you. Thank you so much, sir. Mohammed, sir, I was quite intuitive of what you have been saying and inspired by your presentation, assuming that in India we'll have a big leap in the advent of the 5G technologies implementation, which is already currently underway. And to link up to the gentleman's, sorry I couldn't get his name, but very relevant question and very connected with the very aspect a patient would see. As on date, at least in Indian mentality, a patient does not feel himself or herself treated until and unless he has a touch by the doctor. So with that thing in our background, in our mind, we have been thinking a lot that how do we build that trust, or how do we take the technology to the next level where at least the patient can have a feeler of that touch. So we have been working on this, sir, and again, a little futuristic as on date, but yes, we have been working on the immersive technologies use of eSanjeevani within eSanjeevani using the 5G technologies, which can we feel these services can empower the patient as well as the doctor by adding yet another completely different dimension that can provide an immersive experience to the Sanjeevani users on the both ends. So it can be deployed with the combination of such technologies like virtual reality, augmented reality, or the mixed reality, coupled with obviously the capabilities of the 5D technologies, where we can have headsets with the patients, and he can at least feel he will feel a confident that yes, I mean in a video conferencing it is a different thing, but we have technologies as on date also on which the experiments are going on to enable this feeler where the doctors as well as the patients using this technology can engage in more immersive virtual consultations. And these extended reality technologies would not only enable the doctors to visualize the patient data, the medical images or the models in 3 dimension, but also enhancing their understanding and the capability or the ability to communicate the complex medical information directly to the patients. Also, sir, this would, we feel that would not only revolutionize the healthcare services remotely by enhancing the communication significantly, the very essence of the communication, because in India we have I don't know the number, but n number of languages, and mostly people prefer to speak in their regional languages. With that in our mind, another within next 3 years, I would say we would have a technology powered by the Ministry of Electronics and IT's our own parent organization, Bhashini models, where we are enabling, in fact, we have already done this POC on the English Hindi language pair, and we are yet working on a southern language where the patient is speaking in, let us say, Hindi or Telugu. That gets converted into first the text in English, and then that text in English gets converted back to the language which the doctor speaks, and vice versa. So the patient is speaking in Hindi, the doctors understand, let us say, Telugu or Tamil, and then they are interacting seamlessly. So these, very frankly speaking, the models are not, as on date, very effective. It is just like, as you can see, if you enable a voiceover in this VC itself, you will see that the pace with which I am speaking or anybody will ask me a question, there will be errors. But with the proper modeling and training and the data capturing, this model within the next 3 years would be powerful enough to seamlessly converge at least 30 to 1 minute of audio bits and in pieces. So these are the two aspects: speech-to-speech conversion, immersive technologies, and sir, because we get thrashed a lot by the stakeholders in terms of the data, the analytical data which they want to see, which they want to project, or which they want to analyze. It is yet another dimension where we would definitely need to think about the quantum computing in the healthcare technologies analytics. So that is one aspect where, as on date, I have almost close to 300 plus GB data just pertaining to one state's teleconsultation only. Inferring information, let us say that how many doctors completed the consultation within 2 minutes time span, which doctors picked up the medicines from the SNOMED listing, which doctors prescribed the generic medicines, pulling out the data in terms of the analytics as per the stakeholders' need. I think until and unless we have, although we are currently trying to handle this with the implementation of data laking concept, but in terms of futuristics, when we are talking about 150 million as on date consultations to maybe 1,000 million consultations down the line in the next 5 years or so, until and unless we implement some quantum computing level data analytics, framework, I think that would otherwise remain a challenge. Sir. Thank you, sir. Thank you so much.
Well, thank you very much for adding the layers, right? So we're building a map. We started with infrastructure. We started a few problem capacity issue here, skills, language, remoteness. Now we have another layer. He added a layer that's actually interesting because some of the challenges that were mentioned about trust, they can be solved, augmented reality. I am not using a technology today because when I say telemedicine, traditional is just video conferencing. That's what we used to call early days of telemedicine. Now, suddenly, if I have a glass and I'm operating on a patient, this glass is offering me all sorts of intelligent information. When you do this today, what do? You have a whole bunch of people, group of doctors who advise you, no, don't do this, cut here, no, careful, the blood rate. Computer is telling you all this. Will you be more trusting that system? You will. So it's getting there. They have POCs. They have those things. A healthcare in the remote area or somebody who's assisting can have the same information, pass it on, process information more intelligently. Somebody sitting in their living room, right, can have the same information. So I think we have that future we want is here. How do we drive this faster to get what we want? Go ahead.
10, 15 years down the line.
Yes.
AI-based algorithm will help doctors to analyze patient data in a better way, and customized treatment plan will be a possibility.
Yeah. But you know my problem right now is that cycle is too long. In some ecosystem, that cycle is too long. We need to shorten this.
Yeah.
The only way we're going to shorten this is by working together quickly. Yes, you want to finish and then we go to the panel, somebody remote, I think.
Pardon, sir. I just wanted to share that what Honorable Sir just mentioned is a reality as on date in eSanjeevani. It is happy that I am sharing this information that the symptom checker component in eSanjeevani is AI driven already. And based on the data that is being collected, probably within the next couple of months, in fact, as on date already, the symptom checker, the information which the patient or the CHO is capturing on behalf of the patient, at the other end, at the doctor's end, on the basis of the AI algorithm, it is already depicting the differential diagnosis. And within the next couple of months, we are specifically picking up a modality of dermatology, where suppose a patient who is having a derma-related teleconsultations would click on the picture of the affected area, and on the basis of that dermatology image itself, a lot of inferences in terms of the medications, in terms of the treatment would show up. And we already have a roadmap of around 6 months where the last mile in terms of the treatment adherence planning is also envisaged as part of the CI model. So.
Great.
Oh, I think this is good. Anybody else want to take a stab? Yes.
Something we are hearing some exciting stuff here. So we could also do a couple of more things because you talked about a very interesting thing that what is the final outcome Because we are just talking about technology randomly left, right, and center, but where is the outcome? We want the patient to be cured. We don't want overcrowding at a super specialty hospital like SGPGI. We don't want RML to be trounced by people from remote areas, right? So we talked about a very interesting thing a couple of minutes back, that what is the outcome that we're looking at? Nobody's talking about outcome. We're talking about some features here and there. So the outcome has to be very clear. We want mortality to come down. We want patient to be cured. We want the right prescription to be provided to the right patient at the right time. And the patient should be at the remote location. He should not be brought to the city at any cost. And like Dr. Saroj Mishra does also, when he operates the patient, after that, the follow-up, he does only on telemedicine. So I've been able to see his setup in SGPGI, where he does a fabulous thing where the follow-up is actually done from a remote location. And the patient doesn't need to come to the city at all to his hospital. So now we are discussing a couple of interesting things about access. The main focus of the question that was about access. How do I access, how does the patient get access to the doctor, and how does the doctor access the patient? That was the point that we were talking about, right? So we talked about everything. We talked about e-Sanjeevani, we talked about fabulous examples, etc. But what we need to do is that we need to augment it, because, right, so, and we're talking about 10 to 15 years, right? We're not talking about the technologies that are just down the corner, because it's already available. So why are we not thinking out of the box, which we have been pushing for quite some time? So I think we should be thinking about that as well, because we're just talking about technology is all there, right? So we just have to buy it and we can install it and it should be working, right? So what is the technology which should be 10 to 15 years ahead? We should think about those, right? So for example, currently this connectivity, that in terms of the fact that you have done a lab test somewhere, but that has to reach the city, as one of them was talking about, that it has to reach the city. How does it reach the city? Do you take it by a bus? Do you take it by a auto rickshaw? Do you take it by a scooter? Or can you have a drone to fly over and bring it back to you? When you have to send a vaccine to a very remote location somewhere in, say, Arunachal Pradesh, how do you do it? That's a very serious issue. How do you get a guy from Arunachal Pradesh to talk to somebody in SGPGI in Lucknow? How do you do it? So that becomes a serious issue. So then we have all this broadband, 3G, 4G, 5G, but there are other things which are also being talked about, like your satellite-based communications, which your Starlink is talking about, and others. So those should actually be brought into practice where we can actually do this seamlessly, right? So if you're talking about doing AR, VR, brilliant. But what type of bandwidth will you require for the last mile? You require a huge amount of bandwidth for the last mile, right? So those have to be factored in when we think about these issues. Another interesting thing is that, as we all know, once a prescription is created, and if it is in the physical format, the patient has to carry it all along. Otherwise, it's not of much use, because the history goes, there's no longitudinal view of the patient, right? So that's happened mostly in India, because I go to a doctor today, then I go to another doctor tomorrow, the entire history is lost. So can I have a mechanism by which I can actually collate that history, and can I put it on something like a blockchain or something of that sort, where I'm not talking about technology, it can be any technology, right? Where it should be immutable, and it should be actually being seen at any point in time, at anywhere, and it should be accessible to anybody.
So hold that thought. In the workshop, we'll talk about the job to be done and what's preventing those jobs, right? Because you're right, we don't care about the technology. It could be anything. I'd like to move on to our last set of panelists, which is to answer the third question, and we'll come back for if we have any time. The first question would be to Mr. Deepak Srivastava, not here. Okay.
Is Deepak there in the virtual audience? I don't think so. Okay.
Okay. And do we have Professor Diwakar?
No, he's also not there.
Okay. And then we have Professor Arunabha. Okay. So, well,
management background.
We might as well go to you and you can explain what you're saying. So what strategies and action need to be put in place to overcome these challenges? You actually started mentioning many of those challenges, right? But I like your thoughts. What job do we have to do? What does it mean?
Exactly.
Right? But then what challenges are we facing to do those jobs? And then what are the strategies and plans and action? You mentioned many of these drones, all of these. I mean, why are people going crazy about drones and all of this? It could be done the same way. By the way, do I really want to hire a drone if I can hire a human person and pay that? How far would we go with technology? I'll just put that question to you, because at some point we need to be realistic, because we will create that inequitable feature if we don't put some kind of rein into all this. There is a balance. But again, what strategies and actions? You heard everything. You heard this feature. If you want to add to that feature, please do. Challenges, we heard. What strategies and action should we put in place to overcome some of these challenges?
Right. So let's take up one by one. So there are many stakeholders involved in this game, right? So there is the patient, there's a doctor, there is the service provider, there's the insurance company, there is the telecommunication bandwidth guy, there is the software guy, right? So there are many people who are involved in this, right? And what are they trying to provide? They're trying to provide, as you all mentioned, a patient-centric system, right? So patient is the center of the entire thing, and you want to provide value to him at the end of the day, right? So he has to feel happy, and he should be not happy, but his ailment should get cured at the end of the day. Right? That's the most important thing, because he has some problem and that should get cured. So how do you do it? So, and we have a very eminent set of doctors also in this room. So they are ready to provide that level of consultation. So now the issue is that how do you reach out to that last mind? So one is that you have to have connectivity. That's the one of the most important thing that we all understand. But again, the question comes up is how much of connectivity do we need? It's 2.5G is more than enough to do a video conferencing between point A to point B, right? 2.5 to 3G is more than enough. So when we are facing such a huge challenge in terms of reaching out to the last mile, and we have got regions which are very, very dense, like for example, a forest in Indian context, or we have a hill which is very remote, or you have a desert where you reach there. So how do you connect? So you have to have some mechanisms of doing it at a frugal bandwidth, right? So as far as I know, some of the experiments which have been done by SGPGI, they have even done using dongles, etc., and that's have been really great. They went up all the way to the Himalayas in the Jatra, and they were monitoring it. And I think CTAC Chandigarh also was a part of that team as well. So they went to Kumbh Mela. They could do it on again a very frugal amount of bandwidth, etc. So do we need such a flourished bandwidth, or a frugal sort of a thing, as you rightly pointed out when you're talking about development, trying to bridge the digital gap, etc. So a frugal sort of a solution is what we are looking at, where a minimum bandwidth is what should be enough, 2.5G, 3G, etc. That's what I would think in terms of.
So that's one way, right? So it's the service side. We have to think that the service has to be appropriate. Right? You cannot, I mean, what you see a lot is a lot of solutions looking for a problem. The context of the problem is different. So it's not.
They're not fitting the requirement of the truth.
Yeah, so frugal innovation. So that's one strategy. Any other strategy?
Yeah, let's come to the next one. Next one is that since, like, for example, currently we have got lots and lots of startups who have come up with these solutions of telemedicine, right? So you have got Tracto, you have got many of them. But what happens is that you go to one side, you find a doctor there, but you can't find the appointment. Or you go to the other one, you find the price is very high, the doctor is not there. So why can't we have something like a unified platform, which your Ayushman Bharat is aiming at, where we can actually bring all the players who are there onto one platform, so that seamlessly you could connect to each of them. You're not charged a price for it, but you're getting the results as and when that you require. So because what I want is that I have 100 degree, as you mentioned, 102 degree boiling heat on my body. I have a severe backache, and I'm not feeling anything well, and I want a solution, right? Or I want my mother's knee to be checked for whether she at all needs an operation or not, but I'm not being able to do it because she's in Calcutta, I'm in Lucknow. So how do I do it? So that should be possible, right? So if all these platforms are together, or all these providers are together, then I should be able to reach out to that and do it, right? Even sitting in here and my mother being in Calcutta, we should be able to do a teleconsulting with a doctor maybe in Chandigarh. So that should be a reality, and that should be possible, right? So we are what we are doing. We have to, as you also mentioned, that we have to bring the service provider and the user of the service onto one platform. And that should be encouraged by policy, because you can't tell Practo to come and do it on a platform. They will say, I'm fine on my own setup. Why should I come and join you? Right? So there should be some mechanism by which you have to do that. Number 3 is that about doctors, which Madam was talking about and Sir was also talking about, is that they also have to be taught about the advantages of telemedicine as a part of the coursework, etc. that you're talking about, so that they also understand that since they are so busy, and the doctor to patient ratio, as I was reading today, that I think for one doctor you have got around 1,500 patients in India, which is very, very low, right? So, and they're over busy, overburdened. So can they actually use it in a, so there's already a use case, they should actually be told that they should be utilized so that they can cut down on their workload, right? So that is another point that the doctors have to figure that out, that how they can provide some amount of time out of the busy schedule to provide this. Then another interesting thing what Dr. Sharad Mishra also does is that the education. So one is that he does the operation, and then he also broadcasts that to other medical colleges so that the other doctors can be educated in terms of how things are being done in that hospital, and they can benefit out of it. So one is the practice, the other one is the education part of it, right? So that should also be done by other setups, so that this adaptation also grows over time, right? So that is again a important thing that we should all do, I guess. And then another thing that we're talking about is that, well, if we can also have some amount of as you, some of you are already mentioning, that some sort of a PPP model or something where this can be sustained, because currently this is all being borne by ISRO or DST or by ITU or by World Bank, and these are all being borne by some entity who is actually providing the resources, the funds, etc. But can they be all be made self-sustainable so that they can thrive on their own as things go along the path, because that's where the future would be, right? Thank you. I think that these are some points.
Well, thank you for that. Since you mentioned ITU, I think you also asked me, what do we do? I said, we don't have a space for you to give you any money, anything. We just want to connect you. We just want you to do exactly the last point that you talked about, which is the collaboration and the cross-pollination, and also to help you with the policies, the assessment, the curriculum change that the 3 institutes will have to go through. So our young talents can actually get credit for what they're doing, and they're not just appointed, right? Those sort of things. Yes. And these are the sort of things. Now, I want to go back to this, and I'll circle back to our panelists from the beginning to give us their view on this. What strategies and action plan should we really look at, right? So I would like to start with Dr. Sanjay.
Rajesh.
Rajesh, yes, Sanjay was replaced by Rajesh. Sorry, Rajesh. Can we
Yes,
go
sir.
back to you? Yeah.
Sure, sir. Sir, I think very relevant discussions, right questions raised, and very pinpointed aspects talked about. So, yes, I think from the panelist perspective, we are in the very right direction. The ecosystem, the Ministry of Health, as well as the other line ministries are in the very right direction. We already have those technologies in place, that ecosystem in place, that integrations in place, where seamlessly, at least the aspects which we are talking about, like irrespective of the place of the care context where the prescription gets generated, irrespective of the aspect where a discharge summary has been digitized, irrespective of the primarily the ecosystem, whether it is a government-owned platform, whether it is a private-owned platform, at least with the advent of or the introduction of or the milestones defined by the Ayushman Bharat Digital Mission, at least for those platforms who confers to these 3 basic standards, this is very much feasible, very much possible. So e-prescription generated in eSanjeevani, irrespective of the place and time, digitized in eSanjeevani, with the consent of the patient, is accessible from, let us say, the e-hospital ecosystem or the personal health app of the ABDM system itself, and vice versa, that in case a patient is admitted in a hospital and he has let us say 10 test results, MRI, CT scans, and then the discharge summaries particular to that particular, let us say, Tata Memorial Hospital, and provided that the Tata Memorial Hospital confers to these ABDM standards, that prescription, the same person intends to have a teleconsultation in eSanjeevani or in Practo or in Briefcase, that is very much feasible.
I can pull those records in real time from that ecosystem. And as far as the bandwidth issues are concerned, at least in the major metros, in the major cities, the initial drive of the government is to identify the location or the health facilities where at least the connectivity is not a challenge. So that is another good thought before implementing it, because earlier, we'll just select a health facility, implement it, but now at least the basic infra requirements are analyzed, and only if they are okay, only then that particular health facility is onboarded from IT or IT solutions perspective. So yes, it is already in place, it is already happening, and also we are now moving towards a unified health interface, where, as sir was mentioning, that can we have a single platform? Yes, sir, it is happening. In fact, on a weekly basis, marathon meetings and discussions are happening with the ABDM team, where they want the practically the eSanjeevani's backend system to be utilized for this. But without eSanjeevani also it is happening, and it is under a POC where Practo, Briefcase, other platforms using the ABDM UHI are offering free consultations as part of this POC, primarily the appointment-based teleconsultation. So the future is made ready for us. So we just need to fly off. We need to ensure that we are in the right flight and are having the right boarding pass. Our security checks are done, and we would definitely land up in the right place.
Thank you very much. So it's really about orchestrating the ecosystem around, eSanjeev in a way, and what you're doing and the collaboration you can get with that ecosystem and also outside of that ecosystem. I'll come back to you if you have time, but I'd like to go to Mr. Ramdev from Tata in terms of the same question. What do you see as strategies of action that we need to really do here to drive this future, to make this future real, and that it's not somebody else driving our future?
I respect that, Mohammed. The question, the vision that I foresee as a strategy is the mindset that we all are still carrying, certain mindsets, focusing on resource and driving a solution towards it. Yes, resources are important. Now we need to change that mindset to a who owns what and who is going to be the user. Now let's take example of users at the remote place who just need a clinical information, a resource who need a care, a resource who need a cure. There are three sets of people, and the solution are to be augmented or arranged to such levels, and the solutions of network, doctors, specialists. These network doctors and specialists today and tomorrow, it is not going to change, but yes, the future is low orbit satellite network, 5G, 6G is all going to, where now today, as on today, every 70 to 80% of users are at remote, assuming that these all are rural places. Now, how do we take the network there? In another 10 to 12 years, I'm sure we will have a sufficient network, because the replacing switch in a telecom industry from urban, converting that 4G to 5G, all that is going to a rural place only. So by another 5 years down the line, we will have 4G network enabled there. We will have a teleconferencing happening. But the focus of strategy, I would complete with one. Let us not focus on what resource I have and solve the problem against those, rather than everyone come together and solve what we supposed to have. The 2-3 things are, there is a people who require just an information, there is a people who require a care, another set of public who require a cure. These three are a focus area. That's when who, what, and when has to happen. If this 3W can be sorted together, I'm sure that is when the strategy can align towards it. Could be a policy, it could be a technology, it could be the doctors.
Thank you, Ramdev. I couldn't agree more with you. Resources actually is not an issue. What we have is we get into groupthink because we all think the same, or we get into group competition, and then we're all competing for a small pie. Right? If you want to make a big pie and a diverse pie with more flavors, we gotta understand that we have to start collaborating, right? I'd like to now go to Dr. Priyanka to give her view on this particular question. What strategies and action do you see from your side, Dr. Priyanka?
Yes, Mr. Bak, could you repeat the question?
So what strategies and action need to be put in place to overcome these challenges so we can drive this future?
So from the technology point of view, we have to ensure, I can talk about it from the AI point of view. AI does not always give you the 100% correct output. There is always some error involved in it. So we have to ensure that if we are using AI and if we are planning to use that for patients' treatment, we have to ensure that the output that we are getting out of the AI model, which is accurate. Because if we say that the AI model's accuracy is 99%, however, 1% of the time it is giving us wrong output. And if we just keep on using that wrong output to treat the patient, that output might harm the patient rather than helping the patient. So this aspect is very important. When we apply AI in other places, which is not life-threatening or where we are not playing with someone's life, then 1% of the error is acceptable, but medical field is not like that. So whenever we work with doctors, we always tell them that, okay, this is the reality that we have to ensure that there might be, even if we say that, okay, our algorithm is giving you 99.99% accuracy, but still there is this point, not one chance where the algorithm can go wrong. So it can be false or false negative.
So we need to be vigilant in whatever we do, and we need to convince people so we can build the trust. Thank you. I just want to go back to Mr. Jain. Can you give us your view on strategies and actions to move forward?
Many areas where we can work.
Yeah.
Number one is infrastructure development.
Okay.
So we have to invest to improve digital infrastructure as far as rural parts of UP or India is concerned. Plus, we have to improve the power conditions as far as the rural areas are concerned. We need to have reliable power at the rural areas. We have to create hubs for doctors wherever there are scarcity of doctors in the rural parts. Then we have to launch awareness programs for people, for the patients, prospective patients. And we have to, we should try to have this telemedicine as the part of curriculum. Number 5. Then as far as policy and legal frameworks are concerned, there are many myths and problems. People are not aware what medicines can be prescribed as far as telemedicine hubs are concerned. So we have to work in that direction also. Then we have to develop user-friendly telemedicine platforms so that people are able to take benefit of telemedicine. Then data security is another area.
Yeah.
We should have a robust data security, and as you rightly mentioned, blockchain technology can be used. Then we can have PPP models. We can focus on PPP models where private providers can also come and they can also play an important role. Plus, I think community involvement is very important. So, as government has already taken some steps as far as CHOs are concerned, CHOs are from the community itself. They are helping in popularizing this telemedicine program. So these are all main things which I see can become part of strategy and actions.
So thank you. I think that's very detailed. It's covered a lot of topics. The how, of course, we can agree because what you cite is job to be done. I could do the infrastructure with drone. I could do it with a courier. I could do it with a million different. I could solve the power with just solar. It's a million ways. Let's not get hung up in the solution specific. It will be very contextual. So that's good. Let's go back to the gentleman here to give us his view on this topic.
So see, respecting everybody, I believe that we don't have to look at the doctors like Uber drivers. That is the first and the foremost strategic point that we should look at. They are not Uber drivers. They should not come as an on-demand. If I'm not feeling well, I just should log into an app and see if somebody is available or not. Because they have certain kind of educational background. They have certain kind of responsibilities on them. As I was also mentioning that this can become the next Uber. So that is why I just want to bring this point out, because at the end, this strata of the population is the one who's actually driving the entire healthcare.
Yeah.
As again, if there is no network, this becomes a box. There are no doctors, this becomes a dead system. Yeah. So that is the first point. So I believe everybody is pointing towards a manpower build-up. So manpower build-up usually takes time. It is not a 1 day, 2 day, 1 year, 2 year, 5 year activity. It's a complete strategic outlook that you have to look at so for example, if you look at India today, right? As I was mentioning, we have around 1,500 patients to one doctor. If you look back at around 50 years back, the ratio was much higher. It was around 2,500, 2,600. So in those 50 years, we are able to reduce it by 1,000. So you see that the time it requires to build up the manpower. So that is why I believe the clinical decision support systems, the AI, the data, those are the places that actually come into play and actually allow us to build up the manpower using technology. So technology's role is just to enable people. It has nothing else to do. For example, today I have a certain set of parameters that I have captured, say, for the last 1 year. The technology is just enabling me to understand what that data is. At the end, it is the doctor or the paramedic who is actually inferencing and giving me insights out of it. So we have to understand, first of all, from that aspect, that the only reason why I believe healthcare as an industry has not been digitized to that extent is because of the human touch involved. So we have to keep the human aspect at the forefront from a strategic point of view. And as everybody rightly mentioned, that resources are something that we should not focus on. We should actually focus on solving a particular problem and reaching that outcome. So that journey should be there. So that is just the 2 cents that I wanted to.
Well, thank you. And I couldn't agree more. I mean, this goes back to mindset, right? What is the mindset? But that also goes back to the vision and the clarity. If you don't set that vision and you don't spread that vision that human-centered medical care is important, somebody else will come and Uberize all the doctors, create that ecosystem and orchestrate it and make all the doctors work for peanuts, right? Or replace the doctors with AI at some point. But this is very important. Let's go to you on the trust, the community trust aspect. What do you see in terms of strategies and actions?
बेसिकली हमारा जो इंटरेक्शन है कम्युनिटी के साथ वो और भी हमारे प्रोग्राम्स होते हैं, लेकिन इन हेल्थ सेक्टर बेसिकली द रिक्वायरमेंट कि लोगों को हेल्थ अभी भी रिमोट में वो एक्सेसिबल नहीं है. जो भी गवर्नमेंट के इंस्टीट्यूशंस हैं उस पर एक तरह से क्राउड है एक्सेस में, तो लोगों को एम्पावर कम्युनिटी लेवल पे एम्पावर करके और उनके साथ टेक्नोलॉजी अगर पता नहीं सब तक सपोर्ट करेगा. अभी तो बहुत तरह के प्रॉब्लम्स, अगर वो मतलब कम टेक्नोलॉजी उनको और भी कैपेसिटी बिल्ड कर पाए तो ये बेहतर स्ट्रेटजी होगी आगे ले चलने के लिए.
Okay, well, thank you very much for giving us that perspective. I think the most important thing is the diversity of opinion, right? But having that common understanding from the different sectors or the different parts of or different stakeholders is very important in this case. I want to go back to you now. What is your perspective?
Regarding the community trust, which you are asking.
Well, the general strategies and action needed to drive this future.
So we, what I think is we have enough of system in place. We have the e-Sanjeevani, we have the infrastructure. Mainly, we need to change a bit of the practice. We need to orient our doctors to have a different mindset, because most of them are not actually valuing telemedicine. They're still going with the traditional way of looking at patients. And at the same time, the patient is also not aware of such things happening, like e-Sanjeevani is there or not. So then we have peripheral level health workers who can actually mobilize these patients, let them have a feel of telemedicine once. Once they get a feel and they get a satisfied service, I don't think they will again come back to the traditional way of. So that will actually bring the people, connect the people to the what we are thinking ahead in future. Otherwise, we are moving ahead in technology. We are doing a lot of investment, but then the people are still staying away from all these things because they don't trust. They want the doctor to feel the pulse. So maybe the human element, like we have some hub and spoke model. So at the spoke, we can have some trained manpower who can actually take the pulse, who can take the blood pressure, and he can connect that person with the best doctor.
So that's a great segue to going back to her to give us an opinion. But basically, in the diffusion model that I talked about, we basically get to have innovators, people try, we get to have these people who benefit first, but we get to a chasm where we have not put enough systems in place to now rope in everybody else in this. So that's what we have to pay attention to that strategy in any business model we do. I'd like to go back to you now for your opinion on this.
First, as I would agree with Dr. Manish and everyone else in this room, I feel that doctors needs to be trained at their graduate level, because that is the training. They have rural postings, so that a telemedicine posting can also be maybe for 15 days or a month should be mandate. And that is only possible when we include it as a curriculum. So that is one point which I would like to address. And patient also needs to have trust that can be worked by our ASHA workers and all healthcare providers. We have HCO centers that Dr. Manish had already taken. We can have these, we can meet those heads of village people like Sarpanch, and we can work with them, Pradhans, because they would have a voice which everybody would abide by them. So those leaders can be one of the torch bearers who can tell these people this medicine will also work, and trained people should be appointed at that level so that they are able to orient them. Technology should not be a phobia for them. It should be very friendly to them because they might be very new. They have these voice-to-voice messages, which are now even on Google Speech, we have these which can translate on a multi-language. e-Sanjeevani 2.0 has also incorporated 11 languages now. So that can be there. Infrastructure development, like sir has said, in the rural areas, and training of the caregivers as well, because the people who are implementing at that spoke level will be the ones who can, address. So we would be working on doctor level and they would be working on this, and technology would just be one of the connecting people. So that.
Well, thank you very much. I think this is the last of our speakers. Did I miss anybody?
No, I think that's covered.
Okay, perfect. I just want to resume our conversation today. So we try to paint a picture of where this last mile healthcare will be. We know that there are a lot of technologies already available. There's a lot of proof of concept that's already happening. We know that there are also a lot of challenges in terms of trust, in terms of security, in terms of the stakeholders' collaboration, in terms of the communities actually benefiting, in terms of actually the services being deployed and delivered seamlessly, right? We also have a very good view in terms of what are some of the things we can think about. By the way, there's a lot of things I'm sure we cannot even scope yet, but we'll do it in the workshop when we map the signals. But we also know that at the end of the day, to drive this future, we have to shape this ecosystem. Policymakers have to play a role, whether incentive, disincentive, academia, very important, right? We cannot be training doctors without actually letting them know that they better get on the bandwagon of technology. Otherwise, someday somebody will get them out of the job, right? And so we have very critical, and as you mentioned, it actually capacity building. You have to think ahead. How many years does it take to get through medical school?
5 years. 5.5.
5, okay, that's a bit on the low side even, I would say, right? Some places 7 is even
7,
more.
Germany 7.
So you see, that's a long time. You have to start building that mindset today. So, this is why, again, we want to think 10 to 15 years, because you need to influence all these elements. Innovators, you say they have a lot of solutions, but they have very poor ecosystem. One have a good doctor network here, the other one has a good something else there. None of this is coming together. So if we want to drive this future, and we believe in that future, we have to start thinking of a ways to work together to shape it and to put all of our differences aside, to put all of our ingredients together so we can make a more flavorful, big pie so we can all enjoy it. Otherwise, we will not have an equitable future. And my last word is, if you don't drive your future, somebody else will come drive it for you. We'll be Uberized by some model. I'll turn it back to my co-chair for his last word. And thank you very much for your participation in this panel. And I really enjoyed the discussion, and I hope you did as well.
Thank you, Mr. Muhammad. So we appreciate the session went off and we increased the time to 90 minutes. It's worth, I think. We're not justified by 60 minutes, right? So I think we have covered a lot of things. Like we got a bird's eye view kind of picture, which will be expanded in the last 2 days of intensive workshop in that. So that I think I appreciate the presence of Rajesh Kaushik from SIDAC Mohali, the Sanjeevani National Telemedicine, and they have really given a lot of insights, especially in the version 2 and the future that is going to be. And I really like that the vision they have, that making the realistic situation, like make a patient feel as if she's in the hospital. That the days where patient will definitely get the trust of not visiting the hospital. So that's the future we are looking at. They have got a lot of kind of innovations in terms of the language translation, etc., and many more are in the pipeline. So I appreciate Mr. Ramdev's presence remotely, in spite of his personal issues, he could make it. And Sujay is representing the organization. We'll listen more from them in the last hour of today about the products and solutions they have. They're going to let us know about that. I also appreciate the presence of other experts in the remote audience. Before I go for my in-person experts, they're all here. I appreciate their presence. They come from little away also here. They're from Bahrain, the NGO has come down here. I appreciate your presence. And you really gave us the insight of what is happening ground level. And that's the thing that is going to drive the future. Those are the frugal technologies that we are talking about. You don't go for technology, but who is going to take technology to the people? That is more important. That's what you are doing actually. And lastly, I appreciate my team works to organize this panel also. And of course, Ba at the last for your kind of coordination with a very systematic manner of this panel. So we'll conclude the meeting panel just today, but at the end of the workshop, we'll prepare a summary and we'll circulate to everybody what we have got out of this. The first draft we will be circulating within weeks of completion of our workshop. In consideration.
Yeah, I could just say one thing. Hopefully you have all agreed that you've decided to be part of this journey where we can drive this future together, right? Yes. And that this is not going to be just a report, that we have to put some kind of mechanism in place so we can actually realize this.
Follow up.
Right. So with that, I really thank everybody for your contribution, and actually the very diversity is, because honestly, diversity makes our humanity. This is very important. I always tell people, one thing I love about India is the culture. Culture is diversity. When you go to other places, it's the same. The mindset, the differences you see, all of the things that you can actually make and feel, none of this will be replaced with technology. And our speaker says technology is not going to do anything for you. It's just an enabler. So let's forget about technology, but we need to know that we can really make our lives better. And yes, I will rethink in my island, whether I'll have a connection or not, so I can benefit from the healthcare. This is the first time I'm saying this, and I have to admit it because I really don't want technology. But am I doing?
I just wanted to add that even all the discussions that we've been having today, we've been plotting all of the responses we've gotten from the virtual speakers as well as people in this room. We will be, when we do the workshop day after, we will start from this as a starting point. So even the virtual participants will have a link to the software that we have. You won't be able to switch through all the water bottles, but basically they're full of sticky notes that have the responses. And so we want to just encourage that, just if you can take time out again, I know all of you already invited, just if you join us day after, this will be a very good starting point for us to then dive into the deeper of how do we see 15 years from now. So yeah, just that.
Basically, a toolkit, they have got it, and you can participate remotely also. This software will be real time at your desk. So request all of you to find time to be present in that virtual interaction.
And I think there is one important thing I need to mention here. I did not do any of this. Udita is the one who has been doing all of this. So literally, I'm just here to speak.
Okay. Okay, fine, Udita. So we'll break for lunch. And of course, for the remote audience, we also wish you have a great lunch at your own place. Okay. So look forward to see you at 24th and 24th.
ये कहाँ पे पिक्चर आ रही है?
फोटो तो आने लगी है लेकिन इन लोग म्यूट हैं क्या? RML वाले भी जी।
लीव इट, लीव कर दीजिए।
ये सब म्यूट कहे हैं सर, ये सब कर रखा हुआ था म्यूट अपना। हमारा ऑन क्यों करती है?
I used to enjoy the Pakistani mangoes. Very tasty mango. Corrected.
So are we unmuted also? Oh, because mango.
We'll start now, 2 o'clock. So we start with the move. We start at 2 o'clock. Already start?
Yeah.
Connect. Our dean is connected. So her presentation?
Who is
Okay, welcome back. So we'll have the post-plan session starting from 2 o'clock. We're perfectly in time. It's okay. No, it's just sit down. So in the first part of the session will be presentation from the project deployment site that is at this host institute, Rammohn Lohiya Institute of Medical Sciences. So we'll listen to all the presenters are here. They are the principal investigators of different laboratories. And the first in the line is Professor, our dean, and she's the head of the Department of Pathology. She has done a lot of work in the digital pathology and telepathology, and also has some experience in conducting a project where remotely they'll talk about the quality assurance and technologies capacity development through telepathology network. So she's in Delhi now. It's an official meeting. So I'll request her to join the network and give a presentation. Ma'am, are you comfortable now to present there? Are you able to listen us and see us? Yes, we can hear you, ma'am. Go ahead. We're not able to see you, or neither you can see. Bandwidth problem.
Hi, Professor Nusrat. I think there's some connectivity issue. We can't hear you clearly and we can't see you either.
Meet with all the experts.
We can put up a video, just speak in audio only.
That's why I'm saying, like, maybe she can see my actions.
So
the video.
हाँ bandwidth. ये हमारी bandwidth का issue है या उनकी bandwidth?
Yes.
Take some time for bandwidth to get mature. Let her take time.
फोन के साथ कनेक्ट करके
Hi, can you hear us?
yes, I can. Yeah.
So now we can hear you. We couldn't hear you earlier. Sorry about that.
Okay.
You can just
Okay.
start. Thank you so much.
Okay. Sure. So it's really a pleasure to meet you all online. I wish I could have been there in person. And I must congratulate Dr. Mishra and his team for bringing in this project and this, the meeting at RML-IMS, so that we can kind of brainstorm on methodologies of how we can, get telemedicine to the end point. As of now, RML-IMS is not exactly naive to the use of telemedicine. And we have, way back in 2011, developed our HIS system. And on the HIS system, we developed the technology of being able to sign out our reports online, and which could be downloaded by patients at home. So that was like the first step that we took. Subsequently, we went forth, and what we developed, our department or the lab sciences got upgraded to what is known as the State Referral Center for Lab Investigations. And herein, we developed a network with district hospitals where facilities were not available for high-end investigations. And we provided, like physical hubs at that point at the district hospitals. And the samples got collected there. They were carried to the center, like we were the hub. And then we signed out our reports online, so they were immediately available within a good TAT to the patients who were, away from us at the district hospitals. And that model really worked very well. The project subsequently was then taken up by the UPHSSP, which was funded by the World Bank. And then we were working at one time with 15 different district hospitals where we were giving them, all types of investigations, be it the hormone profiles or the histopathology, the cytopathology, the flow cytometry, the molecular pathology, and so forth. So that was one part. The second that we worked on was, further developing a high-end consultation for the telepathology network. And we acquired the slide scanner way back in 2011. And these scan slides could then be uploaded on what we called as our telepathology network. And these slides were then visible to consultants all over the world, and they could give us opinions in cases which were kind of tricky to diagnose. That, although it was a good experience, was, since we are discussing of, using this at the peripheral level and actually developing the modality for having the biopsy facilities and the cutting of sections and the IHCs being done at a peripheral level, and for them to be scanned and then sent in to consultants to report. The issue mainly that happens out there is the quality of the sections. So, you need to have a good quality section at that end for you to be able to interpret and give a diagnosis. Further, when you're reporting for centers, there would also be, like legal authorizations as well as accountability for the person who is reporting. So that is another thing that needs to be addressed when you're looking at developing a model wherein you're entirely digitalizing the system. So what we found easier was when the physical samples could be transported and the e-system could actually be used to sign reports out online. I will leave this for discussion. I would like this to be more interactive. So if you have any questions to ask as to, how we developed the whole model or how it progressed, what were the numbers we looked at, I'm happy to answer them.
So I have a question, if I can go. I think at a broader level, from where you started to now, what do you still see as challenges that have stuck on from, let's say, year 1 to now? A challenge that is still persistent for you?
So the challenge basically, one is in India is the payment. So if you're doing this on a paid model, then at a very peripheral level, you find, very few people who are being able to pay that amount for the investigations. So the number of investigations that come in at the centers then sometimes become lower. The second issue is we faced it initially, but what you need to actually standardize is the TAT or the reporting time for the test, the turnaround time for the test. Because if that TAT is not very good, the patients actually, they are lost to follow up. For example, now we are using this kind of a model where physical samples are coming in and we are signing out the reports for community health centers. And community health centers specifically for testing for HPV, for cervical cancers. And here again, the issue is that, the patient would be lost to follow up if you're not giving the report back in time. So, and the what we're looking at is actually a self-collection model, trying to do the WHO 70-90 model for covering the entire village population and doing a self-collection for the HPV in collaboration with JPIGO. And these samples are then coming to our lab. We are testing them on the automated systems and the reports get signed out to be delivered at the CHC. So basically the issues are, that if you're doing it for free, then you get kind of more tests. Like, for example, when the UPHSSP from the World Bank model had taken up the project, we were getting a lot more samples. And then we switched back to a model of payment and the samples actually came down. So that was an issue with the sustainability of projects at centers. They have to be financially viable. And the second is if the reports don't go back in time, then you kind of lose the patients and they don't come back for the reports.
Ma'am, actually, I explained in our meeting yesterday with the IT expert visiting us, and also taking some of these proposals that we can pursue it further in the last mile telemedicine concept. So my mother is sitting here and is beside me, that there are certain things very much required for our state. That is, we have so many medical colleges in the state. Every district is going to have a medical college. Already they have many. And also we want to make it quality assurance of the pathology test that we discussed actually earlier. I also explained to them, there's a madam there, how to really improve the quality of the pathology reporting. So when you design some projects, so you will be here day after tomorrow and day after tomorrow on 23rd and 24th. This last 2 days. So request you to be just spare some time and be in the
it
workshop.
will be good to have an interaction. I'm sorry, I'm a little cut out from the discussions and I just joined in, so I'm
actually
not making sense.
No, 23rd, 24th are the key days where you are going to learn from the toolkits they are carrying actually. So in the morning inauguration, Dr. Sonia was very much agreeable to our concepts of creating an integrated environment in the state where 3 institutes, that is RML, KGMC and HGPJ get together and integrate themselves their activities. And even to the extent that departments of telemedicine digital can be created both at RML and as well as KGMC. HGPJ has a dedicated infrastructure. So they are thinking of making it an integrated inter-university center of excellence and working together to improve the kind of digital health benefits of telemedicine reach across the state. Now, you know very well, the eICU is very much in the picture and is getting expanded. Similarly, we can talk of telepathology network. We can talk of teleradiology network. We'll talk of connected health systems and many other verticals in the healthcare delivery system. So that's what I all discuss in the morning. And when you come back, we'll have a separate meeting also to talk about that.
Yeah.
But what is more important is if you can spend 23rd, 24th, that the day 2 days devoted to Mr. Mohammed and his assistant, Udita, to really deep dive us in the technology they have developed, tools they have developed, how we should really plan or measure such kind of program. And he witnessed to the madam's request also in the morning that they will be connected with us to take our vision of integrated telemedicine system for the entire state in the future. So thank you for.
Good. Happy to take this forward.
Yeah. So we'll talk more when you are here. Okay.
Sure, absolutely. Absolutely. So nice meeting you all and good to join in.
Thank you very much, ma'am. Thank you. Okay.
See you tomorrow then. Yeah, see you tomorrow. Bye-bye.
Sure, sir. Tomorrow, of course, we will be traveling to HGPJ as well as KGMU. So day after tomorrow will be full day. Thursday and Friday will be full day here. Yeah.
Okay.
So those 2 days we request you to find some time to join. Program is already with you.
Absolutely.
Have a look at that. Okay, great. Thank you.
Sure, absolutely. Thank you. Thanks.
Thank you, ma'am. Thank you. So we'll go to the next presentation by Professor Sally Mahajan. She is our nodal officer in telemedicine here. She has experience of managing these 2 last mile telemedicine projects. One is the ecosystem, ECHO, and another is the e-Sanjeevani system. So she'll give us a kind of very brief kind of outline of what they have been doing in these 2 projects. Sit down and talk about no issues.
It's okay.
Be comfortable, no issues.
Very good afternoon to all of you. As continuing with what Professor Nuzhat ma'am had spoken, RML has always been on the front for providing any kind of help. And way back in 2011, as mentioned by ma'am, we did HIS. So that was also one of the childlike step, towards digital technology to be provided in telemedicine. So I would be talking about the pursuit of how e-Sanjeevani started in way back. So this is as our Prime Minister, Mr. Modi, has already spoken, that I dream of a digital India where quality healthcare percolates right up to the remotest regions. That is our last mile, what we are aiming at, powered by e-health care. And there, when COVID hit us, I think most of us has never ever realized like how what technology would have us to offer. So this is National Telemedicine Services, which was provided by Ministry of Health and Family Welfare. And it is also a cohesive part of Ayushman Bharat Digital Health Mission. And way back in 2019, it was launched, and Andhra Pradesh was the first state who had to adopt e-Sanjeevani, and now then it was implemented to various other states in India. And basically, it has two verticals. One is the hub and spoke model, which is catered by Ayushman Bharat Health and Wellness Centers, and also e-Sanjeevani OPD, which is stay-at-home OPDs. So we will be talking about how we are taking, and the objective to it was to provide healthcare services to the patients at their home, safe and structured video-based clinical consultation between a doctor as well as a patient. Just to have this bifurcation of urban and rural sector to be combined together, and a step towards digital health equality to achieve universal health coverage, where we can involve all people at one platform. And this is, they have developed an app which is very friendly, even if you are an Apple user or maybe an Android user. So you just have to, they are very simple steps. You have to install it on your mobile. They are for patient, and doctor as well. So you just have to log in with these simple steps. So next slide. So we have these, that first of all, you have to install that app, and that will ask you your mobile number. And then once you get an OTP, you have to register, and also a token will be generated. After that, there'll be a login with an SMS, and there'll be a waiting room, a virtual waiting room, where you would have to wait for your call. The consultants would be there, and they will just show up. You can consult them with your chief complaint, and then they would, based on your clinical symptoms, they would generate an e-prescription which can be easily downloaded by the patient. And regarding the doctor also would have to install the app similarly as the patient does via OTP on registered number, and start with a virtual call, maybe a video or an audio call, and looking at all the symptoms and driving it to the various diagnoses. They have to generate an e-prescription, and the number of calls is directly proportional to the doctors which are available. So the first available doctor is basically connected to the patient, and it doesn't matter like which vicinity of the city you are, whether you are in the remotest of areas and you are being connected to the highest of that. You may be in Srinagar and you're connected to Andhra Pradesh. So it is basically depending on how the doctors are and where they are placed. So next. So the results by the end of the day are depicted on our dashboard. So there are basically how many of the consultations, the number of hours we've been consulted, and also the average consultation duration. So everything is being downloaded, and then it is deposited in a main our cloud center, which is basically made for all the e-Sanjeevani users in Uttar Pradesh. So coming to 1.0, which was launched in 1st March 2022 to 7th July, we had 277 hours of calls, and total calls were 17,614. And they were by the end of it. And you can see the graph will be representing. Next slide. In the graph, you can see there was a boom. We were receiving around 200 calls in a day at one point of time, and which gradually reduced to maybe 15, 20 in a day. Until June, there have been some of the calls which were around 500 so. Next slide. What was the reason of this fall now? So the first is the patient's attitude after the COVID, because a lot of OPDs were changing and patients were not very happy with the virtual way they were dealt. So they had to go to other physical OPDs which were opening up, and also the human resources disruption. There was some network coverage area, even the manpower for that matter who were recruited for e-Sanjeevani have been deputed or have been like transferred to various other places where they were appointed before. Then in July 2023, Sanjeevani 2.0 was introduced, and basically looking at from the patient's feedback and doctor's feedback and also the IT, lot of innovations were made, and there was, first of all, it was a language, because India is a diverse country. So there were 11 languages which have been introduced so that patients can be easily communicating in their own language. And before, the operational capacity was 5 lakhs per day, and now they have been increased to 10 lakh doctors per day. It is AI enabled and Bluetooth enabled devices, which they're still working on. The follow-ups have been made more easy, and there have been integration of labs. So there are an e-Aushadhi as well. So these are the basic introductions, what they have done in 2.0. Next slide. Now the total number of consultations is still 46, and the calls are 1 hour 23 minutes and average consultation of 1 minute. The challenge is, next slide. So looking at the demographics, how they are benefited, so you would see that in males and females ratio, basically the age group of 21 to 40 is the one who's more, using this platform, rather than if you go at the vicinity 0 to 20, there's a dip, and even at 61 to 80 also there is a dip. So the people like who are realizing it is basically between that middle age, 21 to 40 years of age. So they are still to go. And if we look at the geographic locations of the calls received, so we can say that it has worked because there is no as such an urban population which has been catering to. Even you see, so Sitapur and Shahjahanpur, Prayagraj, all these are the vicinities of Uttar Pradesh where we can see. And there you can see where it is reaching. The maximum calls are being catered to the rural areas, as the motive would have said so. Then, so this is like the part where we are residing now, and this is, So this is the part, and this Uttar Pradesh itself is such a big state where we have small bifurcations. So you can see the immense impact it would have on these vicinities where people are not even having things like water, roads. So all these vicinities, it is becoming more and more gradual, so that we can increase our, on the footfall on these areas. Next. So coming to the provisional diagnosis, these were the clinical conditions which were reported. The maximum was like chest pain, fungal infection, diabetes. So all these are not, if we would say they are very acute problems, they are very chronic problems. So they are the ones which can be dealt, on a regular basis, so that we can have a good follow-up for these kind of patients. So what are the advantages? I feel like there is specialized healthcare services to the people, both in urban and rural areas, and also some isolated communities. Like we have people from JAPI and other like NGOs which are supporting these. So we can have a community-based programs where we can bridge a gap in access to the healthcare providers between the urban and this basic strata of, per doctor, like on so many patients that can be bridged and can be removed. And it is for a free consultation service, so that it can be reaching to the masses. So with everything, there is also a challenge. First of all, the network issues, we've been discussing it from a long time now. It has become like one part of coffee cookies. So patients, most of the time, they turn off their cameras. So these are the ones, or maybe we would have challenges like prank calls. So they would be sitting in a motorbike and they would be communicating. So you would not be able to hear, and that they are morally demoralizing. And where would we go for these consultations? And there are system issues, patients follow up. Patients do not want to, because since it is one part where they have explained it to one person, they do not have the same follow-up with the same kind of person. So there has to be some IDs which have to be generated. And hopefully in the next time we would have that the same doctor will address for a follow-up. So with that, I would like to conclude that yes, it is still upcoming and a lot more challenges are there, but definitely the ingoing innovations and all, we would be able to cater to a larger section of society. Thank you so much.
Anything you want to ask?
Anything you want to ask?
What are the challenges at the end of doctors?
At the end of doctors, sir, I told you about HR disruptions. Like we had, there is no as such a particular team which has been assigned. Like, you have to have certain telemedicine team which should be assigned by them, so that, because we had one resident, so she was looking after e-Sanjeevani, and tomorrow this malaria drive or maybe a typhoid drive will come and she will be, recruited from there to cater to the other places. So then we had an OPD of 200 plus, but then it died down to 40, 20, because after 2-3 months, no one was there. So there has to be proper manpower for that. And also the here, they are not even in tuned about what telemedicine is. First of all, it takes some time to guide them that what exactly is going on. System issues are there. So if they have to be provided with a proper room, a proper laptop. So those kind of system, mostly we are not even having our laptop if we are operating on our phone. Know that how much of the productivity goes.
If I can share one experience point from our end also. So we've been working with a lot of ground level people, and this doctor problem in the last 2-3 months, we are hearing a lot. There are two things which have happened, which we've realized, which you've heard. One is with the coming of CHOs, there is a lot of other responsibilities on CHOs apart from the teleconsultation that is happening. So because of which they are not getting the adequate time to cater to this. So initially what was happening was, as ma'am is rightly pointing out, that there were a large chunk of teleconsultations happening, say around 40 consults, 50 consults a day, which have now dropped to 5 or 10. The first point is because the CHO is not able to adequately, market it. And secondly, what is happening? The doctor wait time has increased a lot. But I believe with 2.0 coming in, I think that would be solved. But in the last 2-3 months, that has been the trend across the board. What we've observed.
During COVID, we just had to sit in our system and do it.
Absolutely, ma'am. There are other responsibilities also.
This has become like one part of what we are doing. So it is not given.
We are working with one of the NGOs in Bihar, wherein they have faced a similar issue. So they have a CSR fund who's providing them all these services and all. Until the time they had their own private hub doctors with them, the consultations and the per day load was quite high. But the time they moved to eSanjeevani, because there's a large wait time, and also the CHOs coming in, and then they have other multiple responsibilities, not just this part. So because of that, the capacity building is not there. So that has dropped significantly. But then it would come up again. It's a dip, but I believe 2.0 and all that.
What we have done, we have set a target for each CH. They are asked to do at least 10 consultations. So now that figure has...
Absolutely, sir.
Now, at the end of doctors in medical health, the kind of problems which we faced was so many doctors were trained in telemedicine, but very few are logging in the system. So that was the major challenge in medical health. Because I was asking what is happening here.
Yes.
So
because
is it the same thing or some other kind of thing?
No, sir. Because they're not provided with the main armamentarium which they need to execute that. That should also be a proper room should be there. We had a room when this COVID was there. But after COVID, it was not.
So command center and hub is correct.
So with these kind of workshops, what we are trying to have is an impact that, okay, this is important. And then the administrative part, people would also have a focus in this that, okay, this exists and it is the need of the hour. And it is also given that kind of weightage, which is supposed to be given.
The main thing what Dr. Sali has also contributed in the panel is how to really make the medical professionals, she said only doctors, I'll add entire medical professionals, nurses, technicians, this should all be aware down below to the level of the ground level workers. We have 3 A's in our system, Anganwadi worker, ASA worker, and ANMs. These 3 A's are main pillars at the grassroots level. We're talking about last mile telemedicine, we cannot ignore them. Teach them minimum things. Already the health system is training them, giving them the tablets. So they are acquainted with digital technologies. So little bit of more inputs and practice what the lady was doing in the NGO, they are doing it, app-based system. So what is a facilitator? They can play as a role of facilitator, connecting the patient to the doctors. So it requires a lot of capacity building in our health system. Actually. That is what she was talking, and I'm very passionate about it. One piece of information, WHO has created a group. I think it is given to the WHO Collaborating Center in Singapore. They're working on what kind of courses, soft skill courses will design for the medical students. So at the educational level, medical students, nursing students, technology students, pharmacists, everybody should be talking about it. How can you talk about e-pharmacy without training the pharmacist about these things? And so that is very, very important for capacity building. Capacity building is not in terms of building or computers. Capacity building is making entire system energized towards telemedicine. See, this exercise you are doing today with the help of ITU, you see how much it has risen the inclusiveness, eagerness of the administrators. Now they are ready to give us infrastructure, they are ready to create integrated network of institutions, all these things. So I think we should work in that direction in a cohesive way. Rather than putting, do that, that is not going to work out. Doctors are always busy and they will definitely take an excuse of not executing it. Mr. Jain must have noticed this thing, how much difficult it is to, that's the reason why Minister has decided we have a dedicated MBBS level doctors. First, only focus on this thing. Earlier, the plan was to try with the existing doctors of the hospital. Didn't work. Then they had to appoint dedicated doctors only for these purposes. That you're talking of the system of hub. You go to PGI tomorrow, you will see there. There are 5 doctors, basic medical doctors. That job is only to e-Sanjeevani, nothing else. Wherever this is there, they are taking up the primary calls definitely. Now the secondary calls that already the health system has told us 3 days in 3 experts, you can take it at the cost of 2,500 for 4 hours. So I was telling Dr. Sali, when you organize our system, we should make that kind of system, take appointment to meet neurosurgeons, pediatric surgeons, all these things. Do it, that's not a problem at all. So what I feel is the entire system has to be energized.
So like emergence of various departments has to be there.
Yes. So we have any questions, comment from the remote participants or virtual participant, anybody? If not, anybody in the in-person?
Yeah, I have several questions actually. Just like to step back. Telemedicine. Okay, so e-Sanjeev. Roadmap says we have this consultation, we're connecting, we're matching doctors to patients. Is there, and I don't know the system, I haven't used the system. But we heard throughout the day or earlier in the day, well, there's really several types of care. There's what we call the preventive care. You know, we have the urgency care and we have the long-term care, right? Again, I'm not a specialty, I'm just repeating what I heard during the day. Huh? And I'm also being a patient, I'm saying, yeah, that applies to me. Now, pandemic happened, the world changed. Suddenly, actually, we're telling people, don't go to doctors, only leave to the urgent cares. Urgent, right? Because there is a shortage. So the behavior during that time will be different. There was actually a conversation telling people, only contact the doctor if you have this and this and this, right? Then I saw the picture you shared about the urgency. Okay, I'm not sure hair loss is one urgent. And I like to make jokes because we're humans, right? Yeah. So somebody didn't listen to that message about hair loss, okay? But there was something done essentially. There was something called advocacy. Yes? Now, there could have probably been advocacy done on how you set up the account, how you use the account. There could have been advocacy for the doctors to say, be part of this because we need to save India together. I don't know. Again, I'm just imagining, right? And did they relieve any pressure? Was there any feedback or survey to the customers to see why they're not using it? Because again, remember, you're not an urgency. You're just doing what you need to do. But I also share with you this diffusion of innovation, right? People who will just get the innovation because they love it. People who are looking for the benefit. In this case, you have most people got put in because they're looking for the benefit. There's nothing else they're getting there. But to cross that chasm, it's a complete behavior change. You needed those preventive cares. You needed those family cares. Services on e-Sanjeev was not advocate for family care, was it? Because long-term care is sustainable. If this is long-term, you need data over the long term. You need to know their condition. You're not capturing any of this data. Reset, e-Sanjeev 2.0, pandemic is over. What are we doing? Are we deliberately going and targeting and bringing who's the most likely customer? to actually adopt this Sanjeev? Is it a long-term care? Urgent? But some pandemic goes over, urgent will go to hospitals. They will go to hospitals. Unless they're in a very remote area, they need an urgent advice. Again, is this about customer segmentation? How you go address the customer, how you communicate with the customer? Who is doing this for you? Is it the community folks that were here? In fact, you don't get to a market and you don't get to critical mass without a plan. And if you don't have a plan and you don't execute on a plan, you're not necessarily going to get there. So again, I'm just leaving this as an open thing, but this is what I can just rethink when you share with me. So now moving forward, the plan has to be deliberate. And you have to test out these segments. And you also have to set out what's the priority for this? Who are we going after? What's the priority? Is the priority to alleviate the space here? By the way, because if you want to solve the community, last community one, that's going to be longer because you all talk about all this heavy business. You have to put up the tower. You have to put up this. You have to put if you have to prioritize, I will go after what I have in my house right now, right? And also those people have computers already. They have laptops. They're already in the city. So again, think prioritization, think what you need to go after, and eventually then you will build the nirvana, the dream, where we have that equitable world. That's just a comment, I guess, more than anything. But I'll stop here.
We have a question from the virtual audience also. Would you want to bring it up on the microphone?
Sure. Right. Thank you so much for this wonderful presentation. Very insightful. Just one query. eSanjeevani helps in connecting remote patients with remote clients with the provider. Were there any such incident where a medical legal case or a framework was a medical legal case came up, or any medical legal framework was put in place?
No, so far we didn't have any. We didn't receive anyone.
I think Mr. Jain, I can comment. Do you have any information about that? I don't think so. We do not have. Earlier, of course, people are a little skeptical to give consultations over eSanjeevani. Over telemedicine, let me put it that way. But when eSanjeevani was introduced by the Health Ministry and being implemented by the government institutions, now people feel confident, doctors participated. Earlier, I can say doctors hesitate to participate because there is no coverage to them. So definitely the participation has increased, and because of the awareness and the telemedicine practice guidelines introduced in 2020 March. That also made the change of people to participate in telemedicine. But to the best of my knowledge, neither in the press, anywhere you have heard about any. There is one issue in Bombay, but that also was not so strong to getting anybody victimized on that. So that case was made very popular about that. But best of our knowledge, that is there. However, in the other countries, people are quoting some of those cases of the, I don't know what kind of things, but there are instances. If you go see the literature, there are some instances. But nothing major that has happened actually. Is there enough protection mechanism in our eSanjeevani system?
Because doctors are prescribing medicines which are there in the EDL, essential drug list.
Yes.
So chances are very
basically primary care. So
yes, but these cases are going to come up in the near future, because in the corporate telemedicine, the issue is the charges are very heavy. That's one, and corporate telemedicine is totally directed towards attracting patients to a hospital. It is not delivering the kind of trying to help the treatment at the home from where patient is calling. Instead, there is a kind of mechanism to either make the patient worry about something, or it is totally investigation-oriented advice. So, I don't want to spell out all the details, but corporate telemedicine and public health telemedicine initiatives are totally different. So maybe issues are going to come up in the near future, looking at that. Yeah.
Thank you. Thank you, sir. Thank you, ma'am. Thank you.
Thank you for your comment. Yeah.
Question.
Please go ahead.
And this might come from a little bit of ignorance, so please let me know. But I just want to understand that when the e-Sajivni model was implemented in the COVID time, there was like a very reflex thing. It had to be started immediately. But now that we're in a 2.0, is there sort of a training process that people go through to know, like, how do you speak? Like, it's harder to show empathy and all of that over a phone call.
There's no soft skill workshops which have not been there.
Is there like even a guideline, or as you mentioned, like a methodology or something, like tips on how to deal with patients?
In TPG, it is there. In telemedicine practice guidelines, it is mentioned there how to practice telemedicine.
E-Sanjeevani was already there before COVID also. Because at the time of COVID, there are certain centers who are catering to, like PRT Gorakhpur was doing, it was in SGPJ. But it came on later, it was expanded, the scope expanded to other.
The government also adopted.
No, let me tell the story actually. So, as a witness to all the parts. So, e-Sanjeevani developed as a natural evolution of National Rural Telemedicine Network, which was developed by us in Lucknow, SGPJ, in 2009. The National Rural Telemedicine Network is essentially going to address what today's workshop is, last mile telemedicine. Make a network of PSC, CSC to district hospital. And that was somehow stalled. It's 2009 I'm talking of. After that, a lot of deliverables are taking place. And that document we have been asked to revise so many times. All the time there's an issue. That time COVID was not there. So we're insisting on that please give remuneration to the doctors who practice telemedicine there. Please insist that there's a dedicated doctors. Right? So all these things are getting delivered while COVID has come. Then before COVID has come, you are right very much. We have introduced e-Sanjeevani in the kind of a POC kind of thing to run the telemedicine practices, isolated places, project-wise. But when while that was going on, which is basically Ayushman Bharat Health and Wellness, ABHHY.
Our study was basically on that one.
So Ayushman Bharat Health Wellness was going on, and this e-Sanjeevani online is just an OPD version of e-Sanjeevani. Whereas now, for information of both Udita as well as Mr. Mo, is we have e-Sanjeevani in two formats. One is e-Sanjeevani online, which is just a mobile phone-based system. Somebody can call and get a photograph and get OTP and get transactions over. Whereas Ayushman Bharat Wellness is e-Sanjeevani, which is old one. So they modified their thing to meet the exigencies of the COVID, which is OPD-based systems. However, e-Sanjeevani Health and Wellness still going on. That connects to the health centers, PSC, CSC, whatever you talk about it. So this is the two format actually. But somehow people think they're one. But there is an essential difference. Like what I was saying, promotional aspects, preventive aspects can be only addressed by just a mobile call on e-Sanjeevani online, which was there with COVID time, can be migrated to promotion and prevention. Whereas e-Sanjeevani Health and Wellness, HWC, can be a formal sustenance model of rural outreach fulfillment. That's what we conceived. But now that is all government level what they want.
Yeah, both versions are available.
Yes. And the best thing that happened actually, that time decided that it is to develop by this is a decision taken much later, should be implemented by even the NRPM was supposed to be implemented by our health system. We have National Rural Health Mission, you know about it, NRHM. We have something called NRUM, National Urban NUHM, Urban Health Mission. So many things are there. So they were supposed to implement this e-Sanjeevani. That was done now. And it is a system approach. Now e-Sanjeevani is going far and wide because it has developed a system approach. And being a manager, I mean, you have seen so much things he has talked about it because of experience, how this has been implemented to the ground level thing. Yeah.
I mean,
confused?
No, I am not confused. I'm thinking. I like to keep it very simple first before I complicate things. Mapping. What job are we trying to do with telemedicine? Right? Forget about e-Sanjeevani. Could be something else. It could be that, was it Portea?
Portea, yes.
Portea could be a million other things. Forget about, So e-Sanjeevani is not going to be the answer to everything. Limited resource, limited mandates, limited scope. Period, end of story, right? However, where is the platform that we talked about, which will unify everybody? And the job that we need to do, that, by the way, does not change. Technology will change. The solutions you will use will change, but the job itself will not change. What is Viber, WhatsApp, and all these things doing for us? They allow us to communicate. That was the intent, right? But now, in the communication, we're trying to pipe medical data, which is wrong, by the way, but we have to do it because there is no alternative. So again, stepping back, rural or remote, forget about rural actually, because it could be rural or urban, last mile healthcare, meaning that healthcare that's not provided by some fixed place, by some whatever. It could even be, I think we have to agree what we're trying to solve first, right? What job do we want to do? As a patient, I would like to have access to affordable, good quality healthcare anywhere, right? Anytime, right? That's what I want. To get that, what do I do as a patient? I'm the patient. Forget about it. Put the doctors aside, put the other. As a patient, I need information. Where do I get this? That job is not changing. I could get that job through WhatsApp. Sanjeevani or Portea, Portea, they can reach me through this. Do they have my numbers? No. Do I know they exist? No. First problem, information, right? Information to situate myself so I don't go waste the doctor's time to run 1 million tests. That's useless. That will cost me more money. I just need information. Case in point, I was in Bordeaux for the summer I was in a nice hotel, but I was sleeping on a mattress, good hotel, and I started having pimples on my back, and they were painful. And at the time, there was this, what is that? There was this, one of those diseases going around. Monkeypox, thank you. So what is my worry? That I have monkeypox. Okay, I am not a category of what they call monkeypox, but I have no idea how to determine this. I would have loved, so I'm self-medicating, right? Take Advil. Doesn't work. And I don't know if it's monkeypox or not. I would have loved to just go there, first level orientation, just like I do when I go to the doctor. What's the size of the pimple? Is it painful? Is it reddish? Is it had this little pus head? I don't have that. So the more we alleviate that information before we get to the doctor, the better. So it's an information problem. After that information problem, you're oriented to what's the next step. Just like you do in a doctor's office, orientation. Okay, it's not monkeypox. What is it? Is that a next diagnostic? All of that can be done before we get to the doctor. But these are all jobs. So first, information. Second, orientation to a treatment. Then the feedback to it. And then you gradually go to, maybe you need a medical test. So my point is, these are jobs that do not change. But a lot of it can be oriented in a system before you go. So we design a solution. We look for a problem. We say telemedicine is great. The idea is great. We're going to make it because the idea is just aspiration that is remote. But remote, wait a minute. I have 3 categories: urgent, I have family continuous care. What service is on Sanjeevani to give me any of those? Who's going to create those services? Is the team in Sanjeevani going to be able to create those? Do they even understand? No. They need to start tapping into all these other people who are creating all these other services, frame them into a model, a platform where they can have it access as a service. But the job itself does not change. But if you don't scope the beginning of the job, the end of the job is that I have good healthcare, right? Right? That's the end of the job. The middle of the job somewhere probably is bad that I have to go to a doctor. But by the time I go to the doctor knows everything about me. Then you won't have overcrowding here. By the way, I will go to the best doctor by that time, because if I'm able to reduce the time for the doctor, I could not only go to 1 or 2 doctors, I could go to 5 doctors, plus the AI doctor who support that doctor. Would that provide me the better quality care? Yes. Would that make even that doctor more comfortable so he can enjoy more time with his family? Yes. But we always have this tendency to go create solutions, looking for the problem without understanding the full problem. So I think this is a system issue. What we might do, Rita, the first day of the workshop is map that system. To see those jobs, then to see those problems before we even go back to that feature things. Because I think it's important that we look at this, then we will not get bogged down into the issues about connectivity, because those are after.
I don't know how many doctors over here would agree with me, but I feel that examining a patient is a very essential part of making a diagnosis.
Yeah.
Whether you want to preventive healthcare, in diagnostic care, in urgent care.
Yeah.
I feel, I don't know to what extent AI can replace that examination. And if AI is able to replace that examination, I don't know if we are the doctors who are trained in that way to think and accept the diagnosis of an AI.
AI will never. AI will never. And by the way, nobody's saying you're not going to examine the doctor. What we're saying is before the patient gets to you, you have enough information. So you do a validation, because the AI and the algorithms, they're machine. They just plot a lot of things that say the probability as we have this, but you as a practical person have, and the experience, you have to always replace the judgment, the emotional part. You can just come in, the guy can just come. Let's say data. The guy is stressed, he has high blood pressure, he has high fever, and you come in and say, malaria, take malaria pills. AI say, take malaria pills. You come in and say, okay, tell me what's going on in your private life. And then you realize it's a social issue. When will we code AI for that? We will probably never be able to code AI for this sort of things. And you will never get enough data for AI to tell you this. So you will always need the humans. So this, I'm clear, it's not about replacing the human. It's about augmenting and helping you do your job better.
But diabetes is also being taken care of by recently. So you were to send a picture of your monkeypox scars, or punctures, whatever. Then Shipra would look at the picture and tell you, this is the first line of treatment that you need to take. And then we have a venereal disease specialist or a skin specialist.
Yeah.
That is what e-Sanjeevani is all about. It is basically OPD, not e-Sanjeevani hospital. They have worked on a module of OPD, outpatient department.
Yeah.
So they had the doctor to doctor where we would speak to the HC workers, and they had this Sanjeevani OPD. But now you're talking about hospitals as well. Like they have.
For that, we have a different system called eShishpur. Or any HMIS software.
Yeah, I don't know e-Sanjeevani. I'm just saying all of this is possible. But it's not the only problem. You have to communicate. You have to find the patient. You have to get feedback on the system. So this is a lot. And then you have to create these new services. These new services that may be now targeting the urgent care issue. That team cannot do that. This has to be everybody. It has to be a system, which is what the platform concept has been.
There has to be a system. There has to be a proper documented, evidence-based system, protocols, set guidelines, that this is the way it has to be. There has to be SOPs which have to be formed. And
I think we'll discuss in detail on the WhatsApp page,
Yes, sir.
So
Institutionalizing of that whole command center, as we spoke about earlier, like having a telemedicine command center will not overburden a doctor.
Overburden and have set guidelines.
Exactly.
Guidelines right now are all varied. You have a different set, they have a different set. Need to have a normal common protocol for everything. So
Yeah,
that guideline.
but my point was not to actually criticize anything, to just say that we have to think the system first, then we have to understand which part of the system we can fix, right? And which part of the system others can fix, and which part we should do together, because we just none of that. This is really this is actually the ecosystem, right? Practitioners, there are certain things they can do. Technician solution providers, there are some things they can do. Patients themselves have some pain points, but if we have that shared learning and shared understanding, then we get there, right? So, and it goes back to what I said earlier. I mean, data is king, of course. We can get machines to do some things with the data, but then you have others.
Also,
I think we'll go back to next presentation. We have 3:30. We have to take his presentation early.
Yes.
We have two more presentations for this session. One is from the Dr. Manish Singh. He is talking about his experience analysis of the COVID time telemedicine. Then after that, we have presentation from Dr. Salik on WhatsApp mediated, social media mediated telemedicine practice by a surgeon. So, Dr. Manish, please. Dr. Manish is associate professor in community medicine here, and he has been very actively involved in the telemedicine program of this institution.
This one, PM COVID, इसके नीचे नहीं वहाँ नहीं है इसके बाहर है this one. This one, here. Can I start?
Yeah, please.
So, good afternoon, everyone. I'm Dr. Manish. So, I am sharing this some of the experiences of a study which we did during the COVID times. So, this was the study was titled as Stakeholders' Initial Experience with the Telemedicine Services in UP during the COVID time. So this is the background, like on 25th March 2020, India, which is a country of 1.37 billion people, went into a nationwide lockdown. And the result of this lockdown was that all routine, elective and outpatient health services were put on hold to channelize the scarce health resources for a surge preparedness. And this further led to a more widening of the gap of between the healthcare services and their access by the general public. And UP being one of the most populous state of the country, which caters to around 20% of the India's population, this dearth was even more. So, and subsequent to this, or just before on 24th March, the telemedicine practice guidelines were released and later notified in the Gazette as well. And on the 1 month after this lockdown, it was seen that the patient's condition was a bit of, like, it was very bad, like they cannot approach the hospitals and all things were shut down. So the Director General of Medical Education in UP directed the 21 state-owned medical colleges to initiate telemedicine services. Now, these colleges had no prior experience in providing telemedicine service. They had never seen e-Sanjeevani, also was not there in these colleges. And these were the totally new adopters. So the study objective was to explore the stakeholders' initial experiences with telemedicine services offered by these facilities and their suggestions for improvement, and to generate some critical insights for the program strengthening and to potential scale out of this people-centric telemedicine services. So for this, what we did is we conducted, this was done in government medical college that had operationalized the telemedicine service centers in response to the DGME directive. So here we had a backing, there was a political will, and we had administrative support from the DGME. So all the principals were also roped in, and they had this, that they had to run this telemedicine services. So they roped in some faculty members who they thought were potentially good at organizing these services. And then they started on their own. There were many innovative ways in which they did so, mostly on using video calls with WhatsApp and all these things. So we use this exploratory qualitative research design, and our study participants included the nodal officers who were in charge of the telemedicine units at these new colleges, new adopter colleges. 13 telemedicine nodal officers we interviewed. We did an in-depth interview, and then there were 20 doctors. So these doctors for each telemedicine center that the nodal officer we interviewed, we asked him to give us the number of any two consultants, one surgeon, one from the medical side. And then we also asked to give us the details of a few patients, one male, one female, so that we can talk regarding what has been their experience. So we interviewed them, and then the results we could categorize under three themes. One was what was the perceived benefits of telemedicine services during the COVID-19 lockdown times. And this was what was the response of the respondents. The theme two was what was the challenges or gaps in the telemedicine services as highlighted by the respondents. And the third one was what were the stakeholders' suggestions for improving the services. So when you come to theme one, these were the perceived benefits of the telemedicine services that we got to know from the different stakeholders. One was obviously the ease of access to health services, because at that time everything was under lockdown and there was nobody to approach. So this came in as a very ease of access to health services. I'll just describe it a bit detailed when we go ahead. Then increased participation of patients and caretakers during the consultation. So this time when they were consulting, their family members were there at their home. So everybody was contributing to the consultation. Optimization of patient load at the health facility. So still, as was discussing, that there are three types of patients. One is urgency. So they will definitely come to the hospital anyhow. So, but through this telemedicine that we had launched in these new centers, we could actually optimize the patient load to a great extent. Then cost saving for care seekers, because a lot of cost was involved that time traveling, because there are far off places which come to Lucknow also. Like our center caters to population from Bahraich, which is on Nepal border, to Gorakhpur, to even the western part of the UP. So a lot of travel is involved, indirect cost is involved, loss of wages, and also it was quite a bit economical, cost saving, and it improved patient satisfaction. These were the perceived benefits. Now, when I come to the ease of access to health services, so it was the majority of the doctors and the patients found that it was very helpful for patients with minor ailments and follow-ups for chronic conditions, post-operative conditions, and postpartum patients. So this was the finding of, this was like we cross-checked with the patients as well. Both of them felt that these services were quite good for these conditions. So this is one of the nodal officers what had to say, that although seriously ill patients still needs to come to the hospital, patients with minor illness and follow-up can be attended by telemedicine in future. So telemedicine aided in easier and faster access to specialist consultation in comparison to pre-pandemic times. So in pre-pandemic times, when we see here in our hospital, there used to be huge rush. The person is sitting from 8 o'clock in the morning getting himself registered, and he does not know when his time will come to consult the doctor. And by the time it comes, the consultant is so fed up that he cannot give more than 1 to 2 minutes. But now the patient could actually consult a specialist at his own convenience at a time which was discussed and scheduled for the appointment. So that was very easy for them. Elderly patients and those with disabilities, they preferred the telemedicine services, because that time there was a risk of contracting infections as well. And these patients had difficulty in getting access to the hospital. So they were they found these services very useful. Then the second point which we found beneficial was the increased participation of patients and caretakers during the consultation. So this actually telemedicine offered an opportunity where we had a joint counseling and decision making. So the patient was there, his relatives were there. So if the patient couldn't communicate, even there were instances where we could connect through video calls and this conference calling. That somebody was sitting in, say, Lucknow, and her parents were sitting somewhere in the remote area, and he could connect, and both of them got consulted at the same time. So this perhaps to some extent, some loss of information from the doctor to the patient was like, here we come, there's a lot of rush. Sometimes the patient is unable to recollect even what the doctor said to me. So since the family was consulted at the same time, so they could, there was no loss of information that was there, and there was shared decision making. So this is one of the patient from neurology. This family member of a patient reported. This is a 73 years old woman. Her mother is short of hearing, is unable to walk. She's a patient of hypertension, and no matter what, she will not put on her mask. She does not listen to anyone. She cannot explain anything to the doctors, nor is she able to understand what the doctor is saying. So there needs to be a family member who can explain the things to doctor. And so for us, this has been very helpful, especially during the COVID times. So this then comes the optimization of patient load at the health facility. This was again documented by many nodal officers that actually this reduced crowding at the health facility, because through the telemedicine, they were able to counsel the patient. They were able to communicate to him what all he needs to do before approaching to the medical college, if at all he needs to come here. Otherwise, he can follow up the whatever is suggested at his own home. So by the time he reached here, everything the doctor desired to have was with him at that time. So it saved time and better management of patient appointments. So this was one of the nodal officers had to say that telemedicine resulted in a better management of patients. We schedule and distribute calls as per the availability of doctors and helped in addressing the overcrowding of the OPDs. So cost was a big factor here, and it was appreciated that it was time saving, because we don't have to wait here in the OPD from the morning to the evening to get treated. They avoided the travel time. Travel cost was also not there. Long queues were not there. So direct costs was saved, plus indirect expenses in terms of loss of wages, because patient comes here, he brings in 2 to 3 relatives as well at the same time. So that was even difficult here. So this was a benefit that was quoted by many of the stakeholders. So one of the urology patients had, like, I had to travel a long distance, an hour to reach the health facility, and I landed up wasting time and money in commuting. Because here also it's very difficult. You have to rush from one, your registration is at one end, then you have to go to the OPD that is at other end, then you have to collect medicines that is at the another end of the hospital. So everything that saves there, and investigations, of course, there again has to get in the queue. So this was extremely useful. And improve patient satisfaction. There were timely appointments and better patient-doctor interaction at that time that was reported, because they could schedule the appointment as per their the doctor's availability and as per their availability when they were free, and they had somebody in the family was also there to attend to them. And ease to communicate on sensitive issues, like some of the female patients reported, especially with gynecological issues or those who wanted to seek contraceptive advice, that they felt it was better, like they had a telephonic conversation and they could like talk in a more private manner where there were not many other attendants listening to them, and could get the consultation done. Then opportunity to record and archive the interaction. So patient reported that this was helpful because most of them were actually telephonic consultations. So the patient could record the conversation with the doctor and can use it for later reference as well, so that he doesn't forget on what all was advised to the patient. And electronic prescription and other health records can be easily archived, and cross-reference was also available. So suppose a medicine consultant was, today he prescribes some consultations to the doctor. Before he comes to meet in at the OPD, he can have a cross-reference with the other colleagues also and be ready when the patient arrives. So now these were the gaps or challenges that were there. So these were mostly reported by the nodal officers. One was the inadequate mobilization of the service for service utilization. Like they started it in a hurry on just 1 month after the lockdown. So the complaint was that many of the patients were not at all aware of this. So some medical colleges just advertise it once in the local daily, didn't follow up. Asha, Anganwadi, the frontline workers were not engaged to actually communicate to the community that these services you can use staying at your home itself. So the mobilization part was lagging. Then inadequate administrative preparedness. I'll talk to you in detail in the next slides. There were some challenges with scheduling of the appointment, human resource issues with phone and internet connectivity, logistics, and inadequate confidence with the quality of service provided. So this was like the community, especially rural community, was not sufficiently apprised about telemedicine and what is the process, how they can avail these services. So this I have discussed already. So more of IEC activities were actually desired to get the most of these services. Inadequate administrative preparedness in the sense that it was done in a hurry. Nobody had any standard operating guidelines what to do. The inconsistency in documentation practices or how to manage the health records. Some facilities did it in a very systematic manner, because others didn't even bother to manage any health records. Lack of awareness regarding medical legal implications, this was there. Many of the doctors actually were concerned that since most of the consultation, because of poor internet connectivity, they had to finally go for an audio call consultation. And this could potentially lead to some kind of a misdiagnosis, which can later land them in trouble. And the unavailability of proper documentation of patients' records, they didn't have the physician also changed. Like for this time I called you, the next time when I call at this number, some other physician will be there. So again, he has to explain the entire thing, all his history, demography, consultation. So this thing was not properly documented so that the next physician sitting in the next consultation also has the access to all these information. So this was regarding one of the nodal officers' concern for the medico-legal angle in the telecommunication. So my only concern is the possibility of a misdiagnosis. So we don't have proper guidelines on record keeping, like patient record, audio, video recordings, etc. And at the moment we are dealing with a crisis situation, but the future sustainability of the program, there has to be a system in place. And then coming to challenges with scheduling appointments. So there was actually lack of that fixed time slots were not given for consultation. Only some medical colleges, what they gave is they gave the numbers that these are the doctors you can consult. This is for cardiology, this is for urology, this is for neurology. So, but the time slot was not there. So this often spilled over beyond the time. There were no dedicated infrastructure available. So most of them use their own personal mobile phones. So many call waiting was there. So a lot of problems the doctors faced in the consultations. And the patients reported that in case of an emergency, telemedicine consultation were not helpful for acquiring the same day or emergency appointments. So this was a difficulty reported for the urgent cases. So change of doctors, which I discussed during consecutive consultations, led to hassles of repeating again the medical history. So this was the issues with the scheduling of the appointments. Then the phone and internet issues we have already discussed since the morning. So this was a big issue. Many of the rural families, the rural people, they do not have smartphones. They use the normal call phones. So most of them used to call or give an audio call only. So that was very difficult for the person who is sitting here and giving consultation. And even at the telemedicine center, they had these issues with the internet. A lot of issues, like they were not provided the adequate bandwidth of data for that to communicate with the patients and all. So this was an issue. Then human resources issues, none of them were actually trained in telemedicine. They had neither previous any exposure. This was the first time they were exposed to something called telemedicine. And they were also not dedicated staff. Like suddenly when the load came down towards the end of the COVID wave, they were again diverted to different jobs. So this was one of the demerits. Then inadequate confidence with the quality of service provided. So patient did not feel confident about the treatment protocol prescribed and did not want to delay. So they wanted to rush into the OPD for consultation. And doctors were also concerned that e-consultation, being mostly audio, lacked the visual clues. So there was a lack of confidence at both the doctors' end as well as the patient end. And so most of them were worried about the misdiagnosis. And coming to the suggestions, there are quite a few suggestions as well from the nodal officers as well as the patients. So the first was like need for a proper information, education, communication through frontline workers and promotion of telemedicine in the community. So before, like, we can make this system more popular and more inclusive, like more people adapt to this system only when the community knows about it. knows the benefits about it. So you need to go in there. That was one of the suggestions. Then strengthening of the logistics and a dedicated telemedicine department for a long-term sustainability. So all this was a makeshift arrangement where people who had some interest in telemedicine or those who were good with organizational skills, managerial skills were given this job. So, but everybody felt that there should be some dedicated telemedicine department. The main role was of the coordinator, who was a non-medical person who actually took all the calls and coordinated it with the specialists. So he was also not trained. So capacity building of the existing staff, increase in the availability of telemedicine consultants and consultation appointments. So hours were very fixed for telemedicine. So there's some suggestion that they should increase in hours as well, because the consultants were going beyond the limited time. And setting up of remote satellite center at the village level. So this was one of the recommendations of a nodal officer, that what is happening is the patient is directly coming to them for even minor illnesses. There should be we can take the advantage of, like, which is we are doing in this hub and spoke model, that someone at the health and wellness center can be trained with the basic investigations, with the basic examination procedures, and he can communicate with the doctor. So the doctor will be more clear with the examination part, will get the more better clues to treat the patient. Then reduce the gaps in communication between doctor and patient. So obviously there were issues like the language, and also this could not be solved. Now eSanjeevani, as we say, that has 11 or more languages. So because we had calls getting from Eastern UP, they have a different dialect which we do not understand. And so that was a problem also. And availability of the procurement of medicines. Now somebody is from Gorakhpur or Behraij is consulting a doctor in RML, and he is prescribing the medicines which is not available at that place. So this became a big issue. He was not able to procure those medicines. So again, he had to come to Lucknow or send someone to Lucknow. So that defeated the purpose of the telemedicine consultation. So these were some suggestions from this. That's it. That is what we could get through this study. But but most of the things were very positive about telemedicine from the patient's point of view. The patients whom we interviewed were quite satisfied with the services. Many of them didn't have to come here. So that was one which we thought that later on, after the COVID, can be exploited. And even the consultants, some who had no idea at all before, like this something called telemedicine, some of them took it very positively. They even scheduled their appointments, like in our college.
But they had no other option. They have no other option. They have to follow telemedicine.
There was no option, but so like in pain medicine, sir, Dr. Anurag, he did it in a good manner. Like many of his patients, he consulted on telephonically and got everything done beforehand. The moment they arrived, it was done in.
Thank you, Manish. But even after consultation, the patient can take the prescription and give it to the pharmacy and give the medicines. It's not available.
Medicine was not available.
Yeah, but in hindsight, this is hindsight, right?
Yeah.
You would have actually done foresight to figure this out and solve it in the first place. This is the whole point. What you have done is just great, fantastic. It gives us a great hindsight, right? That's why we call them hindsight. Foresight, I could have guessed all this. I could have guessed that if I live in France, which has, I actually can walk through, I live in Switzerland now, but I cannot walk through France. The medicine in France and Switzerland are different. All this can be built if you forecast where you're going. If you understand what you don't understand, that you don't understand, and you built it in the roadmap and you have your action plan. But that action is not with you. That's with the system. So and I think this is the point. Where do we want to go with this? What is the priority we need to make on this? And how do we actually say there's a workable roadmap, some under our control, others not, but then we have to get those people to join this movement. Very simple.
So it's the same thing actually, literally meaning this workshop is meant for that one. It is making the forecasting from the hindsight. These are things you want to make sure if you want to implement telemedicine. And for example, I'll give 1 point.
We're not making forecasts from hindsight.
We're not forecasting.
We're going to think completely out of the box. We will inform ourselves only from the hindsight.
We're just informing this is the thing, you do it before you launch such kind of program.
The future will be different. The past is the past. So
Are this in the near future? Near future.
The near future may be related to the past, but I promise you, the way things are changing, you'll be surprised.
15 years is so long.
I mean, pandemic, all of you in healthcare, you know pandemics were coming. Why did we not prepare?
So when people are talking of device-less telemedicine, what does that mean? They don't need device, not in mobile phone also. So what to device? Yourself? As you talked about sensors, don't have any phone, you talk to sensors and get all the data and you send it in across, get it. We do not know how it's going to happen in the future. But today, you're talking of the drug disparities. Then you talk about generic medicine. What the government is now proposing is generic medicine. I prescribe ampicillin or penicillin. That is generic. Whatever format is available remotely, they can get it. Now the question is another thing, there is always plus and minus. Then when the government is introducing generic medicine, now the stakeholders are saying, who have interest, no, generic medicine cannot be evaluated as far as quality is concerned. So where to go? Where to go? So anyway, thanks Manish for getting a real hindsight. Was Mohas mentioned it. We have analyzed very thoroughly. This is the stakeholder participation to bring out this information that you have got it. So let's look at it. And any other comment on Dr. Manish's presentation remotely? Anybody wants to give any comment? This is very educational exercise. You have got to know the hard work done by so many nodal officers, a questionnaire. How many respondents came out of 100? How many responded?
Actually, we didn't. We got only one refusal.
As a all of the participants.
Yeah, one of the nodal officers didn't actually got consented.
But the biggest question I ask always myself, during COVID time, all of us practice telemedicine. We don't have anything else. We just sort, everything is sort. This is the only way to interact with the patient. What happened after telemedicine? Why this is complete reverse? 100% with virtual consultation. Now after that it's become 2%, 10% maximum. We converted our routine.
It's the segment shifted, the urgency shifted. So you have to shift to a new segment and to a new target, to the new things. Right. And by the way, rhetorical question, the patient did not come. Was that the hair loss patient?
No.
Rhetorical question.
To your question, I feel there are two reasons. Like, people did not choose telemedicine during COVID because it was super efficient. They chose because they had no other choice. But because the system is not supremely efficient, I would rather go back to physically meeting a doctor now. And that was a lack of choice that
and the same doctor. So I don't get another doctor that I have to tell my story every single time.
Yeah.
But one thing, sir, sir is so dedicated. Sir is following on his own. So there are doctors who found it very useful. So they could actually now also, if we just approach them and give them some motivation, maybe they would be more oriented and try to practice.
See, let me tell you, in corporate telemedicine, all the doctors engaged in corporate, very much interested. They get 700 rupees for each consultation, let me tell you, frankly. They give even 70 rupees to us. We always drop to the well.
Here we are doing.
And let me tell you more.
COPD, then you have all the family that calls you for all the treatment, and then you have telemedicine.
I just wanted to know that I just wanted to contribute that when COVID came, telemedicine was just taken as a temporary solution for that. It was never that it is always a permanent one and it is there.
But sir, initially there was reluctance. But the doctors didn't want to do it by choice.
By choice.
Only because there was an order from the DGME, there was a force from the principal, they had to do it. So they did. Because before that, before the order of the DGME, we tried here in RML. And even the faculty also was not very much convinced, no, will not do it.
Yeah, you need balance between the disincentive, which was that the order, and the incentive, which is the money. But you all heard about the British Cobra story, right? When the British tried to basically kill all the cobras. The incentive was to kill cobras. What did people start doing?
Breeding cobras.
Breeding cobras. Unintended consequences. We'll use the tool to look at all these implications down the road.
Another point I want to bring to attention, Mo. See, in AGPJ, we experimented. We did not stop the consultation through telemedicine completely. What it did, so we made our conventional OPD, which was closed completely, locked up. They opened up and cleaned everything. and we made them protective of kind of infection. We opened in a graded manner, opened the routine OPD, right? But we identified one room for tele-OPD, teleclinic, made it network compatible, and we offered the patients, whoever wants to go for teleconsultations can go ahead, like all chronic patient, follow-up patient, oxy, etc. And whoever wants to come for, they're welcome. Yes. What we found for quite some time, the tele-follow-up or teleconsultation persisted. We have a separate record for that. But at a certain point of time, this came down, like Sheso in the graph, this came down. Then the physical consultation has gone up. Our tendency, our patients, they want a physical touch or something like that. I don't know what it is. Anyway, so we'll put a stop to that. We'll have more discussion in our workshop. We'll have last presentation today, only for 10 minutes. Dr. Salik is going to present. He's there. So very enthusiastic young colleague of mine. So they were all practicing follow-up with social media, WhatsApp for their patients. But the chemotherapy patient for cancer, for scheduling patients for surgery, etc. So I told them, why don't you do that analysis and present in this workshop we are having it. So they have quickly they have done something. Let's see what their results are. Okay.
Ma'am was telling about soft skills. That was one point also raised, that the doctors actually
they have to train.
Senior doctors didn't sit for teleconsult. They sent the JRs and SRs.
Fine, no problem.
They were so patient reported that they were very casual. They're not serious about the consultation. So we don't want telemedicine.
You cannot, you know the story of old horse, right? You cannot take them, you cannot teach them, right? Right. So let's gear up our next generation.
Some people will never follow until you push them to follow. This is in fact the whole segmentation. You have to go after the right customer.
See, all the old doctors, they learned endoscopic surgery because there's a lot of money coming from the laparoscopic surgery, right? But they don't want to learn telemedicine. Anyway, Dr. Salik, he's assistant professor in Department of Cranial Surgery. Go ahead, please.
Good afternoon. I'll be presenting telemedicine related data of our department, endocrine surgery, for the last 1 year, titled as Social Media Adoption in Routine Surgical Service and Impact Study. As we all know, there is a boom in the utilization of medicine of related digital services post-COVID era. And initially there was a gray area in the telemedicine practice, but by March 25, 2020, Ministry of Family Health in association with Niti Aayog laid out some guidelines which has given some clarity on telemedicine. Now coming to a few points regarding our advantages of telemedicine in the Indian scenario. In-person healthcare is challenging in India, particularly given the large geographical distance and limited resources, as pointed out by everyone. And major advantages of telemedicine is obviously saving of cost and effort, especially of rural patients. Aims and objectives of study are to evaluate the impact of telecommunication in follow-up of endocrine surgery patients. That is, whether economic burden on patients can be reduced and we can improve follow-up after primary treatment using modern communication technology and smartphone-based application in the setting of low and middle income country like India, in which the maximum number of patients belong to the rural background and have a low level of education. And secondary objective was to evaluate the clinical safety of this follow-up. We did it on a retrospective basis, and duration from last year July to this July 2023 under Department of Endocrine Surgery, RML. We gave contact number to a single doctor, either junior resident or any of our faculty, for future correspondence, and patients were counseled to call or send a WhatsApp message as per their convenience. Inclusion criteria, age group between 15 to 80 years, obviously these people will be in contact. And all patients admitted in endocrine surgery ward and all patients who contacted the doctor at least once to give their number. And the exclusion criteria for patients whose records were not available or incomplete. And verbal consent was taken prior to recording our questionnaire, which we will discuss later. We follow, our follow-up protocol was patients opting for tele follow-up were examined remotely and data were exchanged in the form of medical reports and written follow-up advice. No physical evaluation was possible with this protocol, as you all know. And wounds were only inspected via video calls or WhatsApp photos. And all patients were called back to hospital or physical examination 3 to 6 months, depending on the necessity. And lab studies and ultrasound surveillance were done at the laboratory closest to patient's home. And reports were shared online. This was the proforma we given to patient to fill up the demographic details, number of calls, their socioeconomic background, their attendance, education level, patient's education level, their socioeconomic status, employment, all this, which becomes important in our setup. Coming to the results, we enrolled around 125 patients from our OPD register. 23 patients were unavailable or didn't give consent for our survey. So the total number of patients 102, and average age of these people who came in contact with 39.35 years, and females were more in touch with the communication. 4.7:1. So this is a map of UP. I mean, all the frequency of these icons denote the frequency of patients coming from that area. UP, as you know, there are so few interesting facts about UP. UP is a very huge state, almost covers 8% of Indian land area. And every district has got around 1.2 million population. And you can find a demarcation. Eastern UP is poorer compared to West UP. West UP is more rich. You can see our population is covering almost eastern side, almost less. And we also had patients from Bihar, Jharkhand, Madhya Pradesh, Nepal. And this is the frequency of patients coming from each district. So this is just a minimum outline of the cost incurred and all the basic demographic details. So annual income, BPL is a benchmark by Indian government to demarcate the socially unprivileged population.
So that you have to qualify. BPL stands for below poverty line.
Below poverty.
The insurance system that government of India has offered. Yeah.
And the Indian poverty line is different from the World Bank and the WHO recognized poverty line.
What is the Indian poverty line?
It's basically higher slightly so that you can indicate lesser number of people under BPL comparatively.
So,
what is the BPL right now?
35,000.
Oh, sorry.
35,000 almost $421. Current rate, $83.
Yeah.
Annual income, and we just divided the patients to 3 groups. I mean, less than 35,000, which is the BPL benchmark, and 35,000 to 1 lakh and more than 1 lakh, which is around $1,203. And our income of patients varied from 16,000 rupees to 12 lakhs, with an average of 1,70,000. And this is another chart showing the number of working members in the family. You can see that the extreme right, 13 people out of 1 or 2 people, there is no earning family members. And in majority of population, only 1 earning member in the family. And government of India has there are certain insurance plans for underprivileged people like BPL, below poverty, like Ayushman Bharat scheme. And so almost like 50% of our population still didn't come under any insurance scheme. But so almost 50% came under BPL and Ayushman, such schemes for this underprivileged population.
But the BPL Ayushman they don't cover the transport and all those things, only the hospital, in-hospital expenses. So naturally, those expenses also have to be borne by the patient. So that way, this contacts through telecommunication really helps them also.
So this is another interesting fact. In our, at least in this part of the country, there is almost 50% of the patients belong to joint families. And the previous chart, we saw that only one earning member in almost like 20-25% of the population. And this is another chart depicting education of the patient and attendant. You can see that there is still a sizable amount of illiterate population and up to 10th class. And graduates, there is a good population of graduates, but there is still 50% of the people are still not graduates. And this
so what I basically aim to say that a basic level education is enough for using this appliance.
Yes, basic level. Right. And joint family, some people will be
sure. Some member can support them.
And this is our occupation patient. This is just to show that the wide spectrum of jobs. Non-creamy layer population, like ASHA workers, manual laborers, farmers, unemployed people. And only few people, obviously this part of the country, the housewives, most of the people doesn't work in the rural area. These people comes to a very huge number.
Move first.
And mobile connectivity is pretty good in this area. Either we can contact with calls or WhatsApp. And most of the people gave a positive answer to internet access availability. And mode of communication, most of the patients communicated via voice call or WhatsApp or combination of both. Most of the people called normal calls as well as communicated through WhatsApp. And this is another chart showing the relationship with the communicator and attendant. This is just another, any member of the family, relatives can accompany the patient with different education levels, different background.
But they're tracking very closely.
Data was collected after.
Yeah, this is a retrospective.
Okay.
This is just a depiction of the cost per visit we have calculated. Cost per visit, which includes travel, cost of travel and cost of stay from all these distant parts of this distant rural areas. 500 rupees comes to around $6.02. And so most of the people had a low income, less than 500. And the average comes around 1,814 rupees, which comes around $21.83. So once we assess the satisfaction level of patients, most of the people were very, very satisfied. And only one patient had a poor impression. The rest of the people had a good, very good, excellent range of satisfaction. This is just another chart showing frequency of contact on endocrine diseases. This is just to show that unlike any other surgical patients, endocrine surgery is a little bit different because we have to follow up patients for long term. For minute cases, BP charting, because it is very much physiological related, we have to follow up for a TSA, thyroid levels. All these physiological things has to be followed. So we can avoid a lot of visits by just communicating the value. I can avoid the visits. We just delineated the number of calls and messages in different organ systems, thyroid, breast, parathyroid, adrenal. You can see here post-surgery. Post-surgery breast calls, they keep in touch for a very frequently because of post-operative wound care, drain removal, and all the dressing, all these issues. In adrenal cases, we have to optimize the patient. So pre-operative calls and contact will be more. This chart shows approximate frequency of contact of different diseases. And main reasons of contact is just a summary. Why they should contact for our endocrine surgery patients. To review investigations of chemotherapy, to guide in case of emergency, to local medical care. Sometimes people will have an emergency situation very far away. We will contact with the primary health center or the private practitioner and tell the situation so that the emergency is thwarted. Post-operative queries, post-operative drain care, wound care assessment to prescribe medication. A thyroid patient also to review TSH, serum calcium dose titration, post-operative queries, wound care assessment, medications, review of investigations. parathyroid patient. Also, this patient, endocrine surgery patient, we need to weekly, monthly monitoring of all these biochemical values. So the communication is very, patients will be very satisfied avoiding a lot of visits. It's also adrenal patients. We need pre and post of BP chatting. They will send daily through WhatsApp, and we can do those adjustments. So conclusion: smartphone-based social media applications are a useful tool in providing post-treatment follow-up of surgical endocrine patients in a very cost-effective way. As we mentioned, the average of $21.83 saved per visit can have a significant impact in a developing country like India. It is clinically safe even in the absence of physical follow-up in a selected group of patients.
Okay, thank you, Dr. Salik. If you have any questions, otherwise we'll go to the last session.
Cost will be actually more.
Just experience the retrospective data. So you can be
and this is all through social media.
Social media, yes.
Lovely. Your hat WhatsApp.
You saved a lot of.
But again, there's a million to get a solution. But that's interesting because then you're starting to narrow in the sweet spot where if you add technology, you can actually have more of the benefit because WhatsApp is not trackable. You need to put a lot of heavy logistic behind this to get there. You know what I mean? So from my point of view, if you're determining the profile of the patient, or because the patient may benefit from telemedicine are not at all stages. They may benefit from the beginning and maybe more towards, so there may be a heavier use in different spectrum of the patient's intervention.
Yes.
And I think this is important, right? And in your old case also to see how this other e-sanjeevni was being used, etc. So again, just put it in the back of your mind when we go through the workshop and we go through this planning, this road mapping process. Prioritization, reality, and especially the actions that you need to take later on. We'll have a prioritization on the future. That's something we'll do because we have to agree to which future we're going to start thinking about. But we also have to start looking at a prioritization on which target, the specific actions that we come up with after we do the foresight, not the hindsight.
Yeah, I can tell you, the last sentence is very important. Come what may, WhatsApp will never go away from Indian telemedicine system. Let me tell you that.
So it's a trend. It's a embedded trend.
That's the point of foresight. You use the word never and you use the word foresight.
So now you make guidelines, rules, regulation, everything around WhatsApp.
Yeah, so he's looking at a short-term future. He's not looking at that long-term future where we will all have computer chips inside us. We don't even have to think. We just transmit our mind to the doctors. The doctors transmit their mind back to us, and all things are sorted out.
I always tell people, WhatsApp is a poor man's telemedicine. Anytime, anywhere, whatever purpose you want it, right? So even WhatsApp itself also changed a lot of things. Those things. But my point is, why WhatsApp become popular? Because it's a patient convenience. I told you I started last time. My patient taught me, what is it also accept my report in WhatsApp? I didn't go for WhatsApp. I used to follow Skype. He said, I don't have Skype and my network is not so good. Allow me to WhatsApp. I was getting scared about the legality of this document. So my point is, it is always the frugal technology, whatever can you tell it. Patient wants an easier way to communicate to the doctors. Health communication is very complex in nature. Okay. There the lies a good doctor. You can speak very well to doctors, patients. Then you will become a lifetime patient. Not only for patient, it's all relatives.
Yeah, but to the point earlier about the frugal innovation is great for a certain targets.
Yes.
Right? But again, your RML, your JK, what is the other?
KGM.
Yeah.
KGM,
exactly. Together, that collective would like to paint both a long-term future where you're actually changing and leading in the topic of this health, equitable health, But at the same time, you have some things that needs to be cleaned up and done today. You need to have both, right? Because one leads to the other. As I said, the future is in the past is in the present, and present is in the future. I mean, just logically. So you have to paint both. So they're probably different areas of this that we may have to touch on. Like, for example, everything we have seen and talked about, it just requires basic technologies that has been here for a long time, right? We have not talked about too much of what our friends from Tata were talking about, augmented reality. Augmented reality can make every doctor's life easy. Augmented reality can turn me into a doctor for emergency cases. Yes? Yeah, I can give you a CPR. I can do a surgery if you're having problem breathing. I can take a knife, warm it up. Okay, I'm off too many movies, but you get my point. It can guide me.
Yeah, you can do emergency.
Yeah, exactly. So all of that also needs to be there somewhere to paint that readiness for that future. But at the same time, there's a readiness for the present. So I just don't want us to be bogged down too much on the readiness for the present.
Okay, more we'll talk about more in the workshop. So thanks, Alec, for quickly preparing this presentation. So now I'll go to the last presentation today is by Sujay. He's from Tata Communication. He's the leader in the product. We'll talk about last one, telemedicine. What kind of solutions they have, the products they have. Go ahead.
Thank you.
The boss is joining. Shall I welcome him?
Sorry, sir?
The boss is joining?
No, sir. Sheshu is there from our team.
Good. So you connect to your remote partners, whichever you want. Okay.
Thank you for giving us this opportunity.
Every time you want to leave the airport?
Yes, sir.
Always.
So thank you for giving us this opportunity today. So our platform, so we've taken a complete platform approach to telemedicine and the last mile delivery of telemedicine. And our platform is known as GlowHeal, a completely in-house developed product by a platform developed by Tata Communication. Next slide, please. So one might ask why a communications company into healthcare. So as we all were discussing that network and communication forms the core of any telemedicine technology. So that is the insight that we got in 2014, and that is when we had ideated this entire platform. So we are Tata Communications. Who are we? We are a digital ecosystem enabler. We provide solutions basis upon the problems that we have, and we have not restricted ourselves to just platforms and products. So that is our motto. Next slide, please. So why digitization in healthcare? So what we identified is there are on a broader level, four, five, six themes. The first one is the user-friendly representation or a patient-centric approach. Then is the optimization of the healthcare services through centralized documentation. And as ma'am was also mentioning about improved diagnostic features, how can we do that? Because a prognosis without diagnosis is just a guess. So that is there. Then assured transparency and backup facility. Being Tata Communications, we have built our own cloud services, network services, and encapsulated that entire together into a solution. And that is why we come with a complete integrated medical devices. Next slide, please. So as I was mentioning, why Tata Communications and healthcare? Because as we've got strong expertise across industries with the trust of Tata, and we are a leading network, cloud and technology capabilities. So we've tried to create some CapEx light, as there was a point regarding infrastructure. So what we've done is we've tried to create a very CapEx light SaaS or a PaaS-based model with high scalability, which healthcare entails. And it's a complete single system integration bus architecture. It's a little technical, but I'll skip this. Next slide, please. So Tata Communication is GlowHeal is an e-health platform. Why we call it an e-health platform? Because it covers your entire range from your preclinical to clinical to post-clinical care. It tries to solve the problem of outreach of healthcare through integrating the OPD and IPD processes as well as the continuous care. So a small snapshot of what we've done. We've been into the business since last 5 years, touched more than 200,000 lives. We've got 200 plus terabytes of radiology scans and reports archived within our systems, because we are one of the official data center partners for NHS. We are also the official certifiers for ABDM for NHS. So we work closely with the governance bodies and the ministries also to keep our system abreast of the entire policies that there are. We've had more than 450 plus doctors on board, and we also had more than 200 plus installations of kiosks, that model. So we've been into the kiosk model since 2019. Next, please. One aspect that we believe is the foundation of any platform is the security standards. So we are HIPAA compliant. We have a DDoS protection, as well as all the regulatory compliances required. As I was mentioning, that we own the cloud. We are not taking it from any third party, so we have a complete control over the data and the protection. So even as Tatacom, we are not able to access the data. Only the patient can do it, and through his or her own authorizations. Next, please. So I'll spend some time on this slide. So this slide gives you a snapshot of what our entire platform entails, right? So as I was mentioning, that there are three aspects to our platform. The first aspect is the preclinical, or we call it the virtual clinic management platform, which entails every use case related to telemedicine, like your virtual clinics or the health kiosks that we have. Our health kiosks are capable of doing more than 80 plus tests as of today. We've got a completely integrated BCA machine with us as well, capable of doing more than 50 plus blood tests. And the devices that we have integrated, we have not utilized any of the IoT devices, but medical grade devices. What it gives us the opportunity to, as I was mentioning, the comparability of IoT based, the diagnostic based, and the medical grade devices. So medical grade devices are superior to the IoT based. Then we have got a complete mobile van solution or an e-ambulance solution. Now, when I talk about all the solutions that I mentioned here, these are commercially deployable. We are already having certain use cases running across the country. We've recently launched, as Priyanka ma'am was also mentioning from IIT Kanpur, that we've recently launched a complete e-ambulance setup, wherein the clinical part of it, as well as the fleet management part of it, is a part of the entire solution. Then we talk about home care. So we've got a complete home care unit with us, for patients who are immobile. They might need 24/7 monitoring at their home. Then we've got the EOPD and the EICU solutions, which HGPGI has obviously mastered in, but we have also come up with this solution. We are also doing a couple of POCs down in Delhi NCR. Then we've got a remote patient monitoring solution, and this entire part is SaaS-based. Now, once the patient goes through this preclinical process, the next part is the clinical part of it, or the administrative part of it. So when we talk about the administrative part, we have a complete HIMS solution. What HIMS solution is, basically, I believe everybody is aware of what HIMS is. We've got more than 50 plus modules with us, a complete end-to-end solution. This is a cloud agnostic solution, and what it allows us to do is it is highly customizable. So ranging from a small clinic to a 1,200, 1,500, 2,000 bedded super specialty hospital, our single system can cater to the entire thing. So we have more than 10 plus installations as of today. We've launched this product last year itself. Government sector? Government sector, we are, there are nothing in government sector as of now. So that is regarding the HIMS.
You say you launched last year?
Yes, the HIMS solution we launched last year.
What about the other ones?
BCIT since 2019, so 2015 actually. Only the virtual clinic chat since 2015. So all these products and the solutions that you see here, we've been implementing them since last year. 2022 starting is when we conceptualized everything. And then what comes is the paraclinical part of it, which entails the archival of the data. Like it's a mandate from the government that whatever scans are happening, you have to archive it for 7 years. So we have a complete image archiving solutions. Also, teleradiology and telepathology, we've developed a complete solution, as ma'am was also mentioning that she has worked extensively on telepathology. So we are also in the process of initiating a couple of POCs very soon. Now, you might think that, oh, all right, these solutions, a lot of different players might have. Now, what we've done is we've integrated all the solutions together to have a seamless interaction between them. So if you go ahead and look at the right side of the slide now, this is where the actual platform comes into play. This is known as a single system integration bus. What this is doing is, this is allowing the data to flow seamlessly across the entire value chain of healthcare. And not just the system which us Glowhill or Tata Communications is providing, it allows the data to flow between a third-party system as well, because we are FHIR compliant. We are using a protocol called as FHIR, and it's a dynamic protocol. So for example, if say RML has system A, SGPGI has system B. Now to make them interact with each other, either we have to migrate one of the systems or we have to manually do the interactions, right? But with the FHIR protocol coming in, this can be done easily. We can create a platform for you, and that platform can become a common integrating platform.
ABDM compliant.
Absolutely, sir.
HFR, HPR, ABHA, all three.
Absolutely. So M1, M2, M3, we are a telemedicine solution is M1, M2, M3. I'll tell you the problem that you might not see us on the ABHA, on the ABDM website. Why? Because we are the ABDM certifiers. So there's a conflict of interest. So that is why we have utilized a third party to provide the certification service. So again, all the users, which is your patients, doctors, hospitals, be it medical institutes, all these users can utilize the entire system according to their needs. And as again, the platform in itself becomes the core, and you just attach things to it on the periphery basis upon whatever solutions you require.
And the tech stack on top is highly customizable.
Absolutely.
Okay, so you just.
Absolutely. So we kind of decentralized the entire thing.
And how long does it take to deploy one of those to customize it? For example, let's say you come to RML as a hospital. You want to deploy this. How long does the customization take?
So it depends on the kind of solution that you're looking at. So if we talk about HIMS solutions, if there is a lot of data migrations involved, we take around 45 days for the entire data migrations to happen, and another 30 days to deploy the new system, and another 15 days for the training. So that's a 90-day period for HIMS solutions. But if I talk about telemedicine related use cases, it ranges from 2 days to 15 days. The kiosk we can do within a week. Wow. The ambulances we can do within 15 days. The home care units we can do within a couple of days. So this is the kind of timeline that we're talking about.
I have a question.
Yeah.
Is there any changes that you perceive now, given that the data protection bill has now become an act, in the way you collect, store, or exchange, or allow the interlinkages of the data to happen? Does that stand?
We are already following that.
Okay, so based on the bill then?
Yes, correct. So our system was future ready in the sense that our Tata Communications consulting team was a part of the team that had drafted the bill. So we had built the system accordingly. There were a few tweaks that our cloud team is currently doing, and we are ready with that as well.
Just a question on the home care.
Yes.
What type of end devices do you have there?
So in the home care unit, we've got IoT and Bluetooth based devices. We'll show you. Okay. But when I talk about the kiosks, they are all medical grade devices.
Okay, but the kiosks are in some centers, right? They're not.
Yes. So yeah, correct. Next slide, Sheshi.
So is this an open stack or is it proprietary? Open in which way?
So so the IP is with Tatacom. The base or tech stack is open source, entirely open source. The backend is open source.
Yeah, I know it's open source, but it's not an open platform.
No, it's not an open platform. It's a proprietary Tatacom proprietary platform.
Okay, that was my question.
Okay. So now, why we call ourselves as a digital ecosystem enabler? Here comes our main strengths, right? So our entire platform or the use cases run from 2G up to 5G. They are capable. We have our own 5G infrastructure. We have our own ISO cloud infrastructure. Then when we talk about the communications platform, we have our own platform called as Digo. And we have an integrated seamless e-health platform. So intertwining all these things, it allows us to interlock the consumer and the service provider, enabling them to be connected, updated, and receive a quality healthcare service, which is scalable, monitored, and offering a transaction-based service. So that is why we go ahead and say that we are a CapEx-like model, which in the market, everybody is. It is not something new, but we have completely moved to a transaction-based service. Whatever consultations you have, you just have to pay for it. Whatever transactions you do, you just have to pay for it. Whatever your live users ask for HIMS, you have to pay for that. Nothing else. Next slide, please. You can skip this. Yeah, so I'll just touch upon briefly what all the 3 different use cases of virtual clinic management platform and the other 2 entails. Next slide, please. So as we've discussed this in length, that low resource utilization leading to poor return on investments, higher costs. The patient experience is very poor when we talk about today's healthcare system. The wait times are the top complaints. At most patients are seen by doctors for only 1/5 of the time, is what we've understood. So the time taken to travel, sit there, wait for the doctor, meet, that takes only about 10 minutes. And the rest of the 50 minutes is what usually is the waiting time and all. Then there is primary care and lack of assessment. So even at the very basic level, primary care level, there is a lot of gaps that needs to be fulfilled. So that is our entire focus was, and some part of it today also is on primary care itself. We are not delving into secondary or emergency and tertiary care. We do have certain solutions for that as well. But our primary focus is on primary care. Next slide, please. So this is the four different solutions that we've come up with for the telemedicine as a base. The first is a smart EOPD, which is a teleconsultation platform that we've built. It has got all the solutions ranging from your scheduling appointment, doctors, onboarding. It is also integrable with, for example, eSanjeevani. We've done some kiosk where we've provided eSanjeevani as a platform to them. Apart from that, we can utilize the same platform to power our kiosks, which have more than 72 plus parameters as of today. Then we have the eICU solution, which is 24/7 monitoring. It's again a completely hub and spoke based model as what SGPGI is currently doing. Then we have an e-ambulance. Now we are live with a couple of e-ambulances. We'll be scaling it up in the next 6 months to approximately 50 odd. And then by the end of the year, we are looking at a number of around 200 e-ambulances, which are both connected in terms of the fleet management. You can track the fleet, you can control the vehicle, talk to the driver, and also in terms of the clinical interconnections, wherein the vitals, the monitor, the defibrillator, the syringe pump, etc., are integrated, and they can be controlled from the command center. So this is all done. And then the continuous care is where the home care units and the corporate care units come in. UP? No, sir. We started with Maharashtra. We'll soon be hitting UP as well.
All private sector ambulances?
No, so we've partnered with a ambulance provider who gives to both public and private sectors.
Which?
ZHL, sir, if you've heard of it, Zikitsa. Correct.
So, question here. I mean, for rural or last mile health, I mean, yeah, the core things is fine. So you only have this teleconsultation, the OPD virtual clinic, and
everything is last mile. Yeah.
Well, when you say last mile, I mean, is that remote care in somebody's?
So if I talk about home care units, a remote care in home.
So you're pushing that in a home remote care.
That can go to home care.
Okay, but that's still the middle or top of the pyramid. So
these home care units are again transactional based. You don't have to pay for anything. So if you're using them for 2 days, just have to pay for those 2 days. It is not a rental based thing.
Okay, but still, chronic disease, chronic conditions, you need these devices for a long time, right? Correct. I'm not a doctor again, but I watch enough movies to know if I can use that analogy.
Your point is correct. If we look at just a very small strata of the rural population, right? Chronic disease. So as I was mentioning again, the entire purpose of this is for primary care. If I talk about the kiosk, if I talk about the teleconsultation, that is for primary care. If I talk about e-ambulances or the mobile van, so the kiosk can be set up in a van that can go from place to place and provide the services. So again, that is for primary care. If I talk about e-ambulance, that small part of it is emergency care, but then again, it is to reduce.
Yeah, so it's not direct to consumers.
Absolutely, it is through service provider. So we are Tata Communications are a pure B2B company. We are not a B2C.
I think that's my answer. It's not B2C. It's really B2B in that sense. But I think when we get into the last mile, we're talking a bit of the B2C in a way, right? Now, if this B2B allow them to be B2C.
B2B2C.
Yeah, B2B2C, which I don't know how much of that you do. This is my thinking.
Okay.
How much of the B2B2C are you enabling? Because at the end, what we're looking for is the B2C, right?
Okay. So for the B2B2C, what we do is we've got a set of partners along with us. Be it your NGOs, be it your service providers, be it your private players, be it your government, be it your...
but those are part of your tech stack. They're not directly transforming the experience of the...
Like for example, sir and the team here sitting, like they were doing the ground level work. So we've tied up with a couple of NGOs who we also help them to get funding from the different CSRs and corporates. And then we deploy these solutions. With the help of them, we provide the care to the last one.
Again, I'm not the doctor here. I'm just asking questions. I think there are doctors in this room who can ask the right question.
A lot of urban located hospitals, they do have their own, even like an Apollo, which is a very business oriented hospital. They still have like a CSR sort of wing that they cater to. So even if, let's say, Apollo Delhi is taking one of these services, they will have a unit that's catering to some like tier 2, tier 3, or even to some rural parts of located close to Delhi. So in that sense, the B2B2C would be achieved through them.
So exactly. So like you're giving an example of Apollo, we've got a set of different partners. They can be public, they can be private, they can be non-profit. They can be even, we also even enter into a PPP kind of a model also. So for example, in Mizoram, we are doing one of the mobile clinics, a couple of mobile clinics. We are going to soon run them. It is in the implementation phase right now. Maybe by September end, we are going to launch it. So there we are doing a PPP model with the government where they are funding some part of it. We are funding some part of it, and then we are running it as a commercial model. And that is why I was coming to it later. So that is why our entire focus is also on the sustainability part of it. For example, once the funding goes away, then what happens? So we are trying to create solutions which are self-sustainable. Even
yeah, I was just explaining it to him.
Okay.
Yeah, but I'm still stuck. I've been a product engineer for a long time, so I know exactly the language you're speaking. I'm a techie, so you cannot fool me. But I am looking at, I think, Ramdev, right? This is them.
Ramdev is my senior, yeah.
Yes, that's what he said. He said, I'm looking for a seamless future where I'm looking at a future where healthcare is delivered seamlessly, right? We talk about anywhere, any place, anytime. I was a product engineer when this whole platform business came in. We at Intel were the one who were going everywhere. Introduce the word platform. I say, here's a platform. We don't know what to do with it. You want you to do any content, anywhere, any place. Cisco takes it, does routing, blah, blah, blah. Apple it's not the same thing. We're talking about this in healthcare now.
That is why we talk about the fire.
20 years ago. 20 years ago. Okay. 20 years later, we're here. We're looking for the practical application of this healthcare business. I am the user directly. You reach out to the businesses, yes, you got, because the business has got a certain enterprise, certain dashboard, certain thing. I'm looking a bit beyond that to say consumers directly. How much of the consumer services or consumer-related services, and you said we're working through partners. How much value add are those partners taking your back end, if I can call it your kitchen in this case, and build a restaurant for the consumers? This is my question. Let's say you, as a company, you're very strong, you got all this infrastructure, you can connect all this, you can make this beautiful thing. But you need a bunch of small companies, small innovators, who will then take your infrastructure and do that last mile customization, which will make it appropriate for the right market. That's the question.
So I'll answer that in two parts. So the first part is the insight that we got was regarding the manpower, right? We've been discussing it at length here. That manpower and capacity building is something that we have to spend and invest a lot of time and money in, right? Being a technology and a solution-based company, that is not our forte and that was not a focus. So why to start something from scratch when you have an ecosystem of partners along with you who have that capability and who can leverage those spaces regarding manpower? So to answer your first part of the question is, how is it enabling or how is it allowing our kitchen for them to open a great restaurant, right? It is allowing them because they have a one-stop shop to get everything, be it the infrastructure, be it the training, be it the low cost, be it the self-sustainable models, be it the cloud services, be it the network services, be it the entire ecosystem, and be it the funding. We even backtrack it to the point from where the money is flowing in and from where the services are going, right? So that is how it helps the smaller partners. Now it might appear that they are smaller partners. They are working across India. Yeah. They've got, I think, more than 10,000 plus workforce, and we've got more than 5 such partners with us, working in different regions, having more than a workforce of more than 10,000 people. So that was to answer the first part of the question regarding manpower. Now to answer the second part is, how is this platform actually doing that, right? These are different solutions. How is it doing that? So that is where the vision of seamless data through a Fire-based platform was, which I was talking about, where a single system integration bus is coming.
Yeah.
I didn't want to use that word, but see, all these systems as a separate entity has been existing and had existed even 10 years back.
Yeah.
There were kiosks, there were HIMS systems, there were VNS systems. What we've done is we've taken them together, optimized it.
So you've added the value for them to be seamless.
Absolutely. And also at the same time, tackle the network problem, not just by providing network.
Yeah.
Because we own the entire thing from end to end, we can optimize it. So as I was mentioning, our entire system can run even on a 2G network and up to a 5G network. Why? Because we own the entire thing. We can optimize it from the word go.
So what is their value add to the end? What are they building on the value add?
The cost, the efforts, and the outcomes, the measurable outcomes. That is.
So that's what they get as the benefit. But what value now do they add on top of this to the clients?
For the patients?
Yeah, for the patient.
So the patient, because they are working at the ground level, right?
Yeah.
They have a, what do you call it?
So they're the one orchestrated the local ecosystem to bring to your platform.
Correct.
And this includes which ecosystem? Includes the one we talked about, the doctors, the or what service? What are they?
The paramedic forces. Then so see, our agenda was not just to provide healthcare services, but to tackle 2-3 problems at once, because our primary focus is public sector. In public sector, if you can hit 2 targets with 1 arrow, that's the biggest thing. So what our systems enable us is they also enable us to generate employment. To run these systems, you don't need a very highly trained employees.
Yes, I get that. But what are they creating as innovation on top of your innovation? That's what I mean.
They are not creating anything. So they are the ones who are who are actually helping us to realize those benefits by taking us to the patients.
Okay, so that's actually the $1 million question I had for you. That's what I'm going to after says, are they innovating on top of your innovation? But that's actually the opportunity.
Yeah, absolutely. So that is why we talk about the single platform. No, once we reach that single platform, we can utilize. Now we have 10 different vendors we are working with. But at the end, if you have a single platform, we don't have to work with 10 different vendors. We can unify them, bring them on a single platform, and then go ahead and tackle any market or any region, not just specific to India, but abroad as well.
Yeah, and again, this comes back or circle back to the question of, is the platform open, or how open is the platform, which was my original question. Is it an open platform, or is it a closed platform? I think you say it's closed, but to really tackle the problem, you need to make it open, right?
So it's
and there is a term these days called open washing. Anybody heard the term open washing? We just say it's open, but it's actually not open. It's a purpose, because somebody has to maintain this business. You just
that is what it's coming to.
Reducing the cost, basic cost, so more people can now customize to the last mile. So it's about the innovation to the last mile. Whether this platform is going to be open to do that or not, and what will that look like? Then you have a really winning success. If it's closed, it will always be seen as closed. You can do open washing like OpenAI is doing right now.
So with your partners, are you participating in tenders as consortium? Or?
Yes, as consortiums. We don't do JVs and all. We directly go for consortiums. Next slide, please, Sheshu. Yeah, so I'll skip this because we've already talked about the kind of benefits that we have. Again, what we call a smart UOPD is basically 2 things. One is your kiosk model, and one is the direct platform or the teleconsultation application that we built. So it's a simple, a very vanilla product that we usually see. What we've done over and above that is you added small different features to actually plug those smaller gaps. For example, today I go to a kiosk, I might have a certain set of reports. I'm going there for the first time. To digitize those reports, there was no solution, right? So we built that into a system. You can digitize the existing reports that you've got. You can scan them because we already have a DICOM platform with us. You can scan them, have them as a complete EMR system that is inbuilt in.
Has anybody started hacking your system? When I say hacking, is because you're not offering a service that they need, they're using your system and putting some other systems around it to.
We haven't seen that as of now because of the different protocols that we follow, but we haven't seen that.
Well, that's why the open part is interesting. The search WhatsApp, I don't think Facebook ever realized that, not Facebook, but the original envision that people will be sending medical records through WhatsApp. because that's where the customization at the end comes in. And also to find that community to do that last mile customization, which you will never be able to do, no matter what you try. You have to have that openness to be able to take it to the next level.
Absolutely. Point taken. Next slide, please, Yushu. So this is our health kiosk. As I was mentioning, it is capable of doing more than 72 tests. We've got different devices, which are again medical grade, like an otoscope, a dermascope, a skin otoscope, ENT, urine strip analyzer, biochemistry analyzer, vitals, both 6-lead, 12-lead ECG, a digital stethoscope, etc., etc.
You have reagents or strips?
Reagent based. So the BCA is a reagent based semi-automatic machine. The urine is a strip analyzer. It's a strip based. Next slide, please.
These strips are available on GEM or?
Yes, sir, they are.
Is it monopoly kind of thing?
It is not, but there are certain specific strips that work with it. But they are readily available. It's a very common system because we're procuring it from our partner who's a 45, 50 years old, you make in India company based out of Chandigarh. So there's another model, a double-headed kiosk. This is primarily for corporate areas. This is a little expensive, and this caters to places where there's a higher footfall because they usually have those executive health checkups done every 6 months. So that is the kind of place that we have this. Next slide, please, Shishu. So then we talk about the eICU solution. I think we've talked at length with it. So I'll again skip this because this is similar to what SGPJ is currently doing. It's a complete cloud-based system. This is the e-ambulance solution. So there are different aspects to our e-ambulance solution. It's an effective audio-video platform with a complete tracking system. It can have a driver head camera or even a camera inbuilt into the van. Then there's a virtual clinic connected tech. As I was mentioning, it can be a monitor, it can be a syringe pump, it can be your ResMed devices, it can be ECG, etc., etc. Then what we've done is, because the entire communication platform is also enabled, so when the ambulance is, say, for example, there's a geotagging also. So when the ambulance is near the hospital will get a notification that the van is reaching, and so on and so forth, and even the relatives can track the ambulance. Next slide, please.
So these ambulances are advanced life support ambulances, or
they can be
normal?
They can be. It depends upon your requirements. So we are just you give us the devices, you tell us that these are the different things that you want to integrate. We'll come up with a feasibility study for you, and if that's doable, we'll do it for you.
This is customizable because the advantage is they have their own locomotive company also, so they design as per your requirement.
So in UP there are 4 kinds of ambulances: 102 for MNCs, for instance, 108 for emergency services. MMU is that mobile medical units.
Yes, sir.
And then ALS is for?
So for the first 3, the answer is 100% yes. For the ALS system, there might be something that we won't be able to integrate because they're not possible as of today. But there are certain aspects that even the ALS ambulance can.
ALS are normally used for inter-district
absolutely, sir.
movement.
So for example, even the ventilators can be integrated. So yeah.
I'm sorry, Mr. Jain. I think there is one for specific for pregnant mother.
That is 102.
102. Okay.
That is also doable. That is also doable. Next slide, Shashi. I'll skip all this because we've had enough discussion on this. I'll just so this is the one of the home care units that we have. It's a very small briefcase which is capable of doing around 10 odd vitals with continuous monitoring. It's a tab-based system, Bluetooth-enabled system, and similar to kiosk, but it is a little limited in its usage. We've got another 2 or 3 models which are even higher in capabilities. We've just completed a R&D on a model which can do more than 100+ tests.
What is important is just these are to be dropped. I don't know whether the case is fall resistant or not. You can follow the US military standard, and we designed was an R&D in SGPGI. So we took the US military standard. We took a Toshiba computer with all the US military standard. So they can be dropped in disaster sites. Earthquake.
So when I talk about the briefcase that we put this entire thing in, that is drop free. I mean, you drop it, that will be safe. Yeah. But if you drop a tablet or something, then that.
There are tablets available which are
correct, sir.
US military standard.
Correct.
Only 2 or 3 companies make it.
So only this is a tab model. The rest we have a mobile based one.
Toshiba is one company only. They make these US military standard tablets. Right?
So then the
when
cost
tomorrow, when you
cost is not
The cost won't be so.
So we have that solution. If, for example, we even have a digital access solution integrable with us.
My point is today the message that I want to give it, everything is possible. When disaster, millions of people lost. This couple of $1,000 is nothing actually.
Absolutely.
So when you come tomorrow, I will not be there tomorrow. So when they come tomorrow, we'll show in a GPGI. We have this US military standard tablets as well as computers.
Absolutely.
Design the disaster sets for R&D purpose, not for
absolutely.
Long ago, maybe 10 years ago also we designed this thing. So this is a lot of importance now. So people realize this can be dropped in some earthquake, great disaster accidents, everything here. So you can design that kind of systems. The time is coming to close. I think you are to.
No. Nothing.
It's up to you. Go.
No, we'll finish this. Sir.
I have to go to the flight test and
next slide, Sheshu. So now this is the HMP or the health management platform that we talk about all the administrative services. So again, I'll skip all these. I'll just directly go to what the solution is. Sheshu, previous slide, please. Previous slide. Yeah, so it's a completely integrated solution touching the entire OPD to IVD to continual care. It's a high modularity system. You can select whatever modules you want. We've got more than 50 plus modules. Why we call it as a one solution fits all? Because we can cater from a small 10-bedded clinic to up to a 2,000-bedded super specialty hospital. And we have an installation in each of these different categories. That is how we usually enter the market. We usually hit each category and then we kind of scale up. And with our partners, we've got a couple of partners with which we are even pitching it in one of the public sectors as well. So with Tata Memorial also, we are doing one of the POCs. Next slide, please. Now you can skip. You can go to the RMP section. Yeah. So we've got a complete DICOM platform as well for archiving all the images, all the scans. I believe RML is also currently doing it because there's a mandate also to maintain the entire records for 7 years. So it's a complete transaction-based system. It's again a vanilla product, but because we own the entire cloud, the kind of cost advantages that we as Tata Communications are able to give, no third-party cloud can give, and we can give it to you as a guarantee that
it's a virtual PACS is now the order of the day.
So and we've got a complete analytics software also built into it. If say you've got the permission to analyze the data, then you can do that. Next slide, Shishu. Yeah, I believe we are done. Yeah, correct. So we've got a complete PHR. So you talk about solutions, we've got everything which is related to healthcare. We can also customize solutions. For example, as I was talking about Mizoram example, so they wanted a solution which was catering to the not just to humans but to soil and animals as well. So we've inbuilt the veterinary solutions using our telemedicine platform. We've given the entire kiosk as well as a complete testing solution for soil as well with one of our leading partners who usually does the soil testing. And we've created an entire van and we call it as a EVS solution. So it is so it caters to the environment, the veterinary, and the society.
In Meghalaya.
In Mizoram.
Why don't you make it One Health?
Absolutely, sir. So that is what we are calling it of.
One Health solution.
So there are certain other examples also. For example, there was a use case for optometry for eyes, wherein we had integrated a complete what do you call that, the machine through which you see the eyes. I'm forgetting the name.
Yeah, I mean, it's all possible.
Sorry, no, ma'am, not the otoscope. There's a then for the dentistry, we got a particular. So we usually do this kind of stuff. Yeah, so we are open to solutions. We've built a technology stack. We can play around with that. That is what we do.
So what's the business model here? You sell the whole stack. You sell. What's the business model?
So it's a SaaS-based model.
Yeah.
So whatever hardware it is, it's a one-time cost for you. Rest everything is transactional based.
Okay. If you have to think, okay, so we can inform ourselves from past trends and figure out what this trend goes in the future, right? If I'm a betting man, I'll put my money on the fact that all of these services will be de-verticalized, because right now what you're actually solving a pain point to verticalize it to get the seamlessness, but that seamlessness eventually will go back to de-verticalizing itself. So which means, for example, for patient registration, there will be a company that just offers a stack for patient registration. It should be a standard and we'll push it everywhere. I mean, just like what's happening in the underlying.
What we are doing right now also. So across the system, we have a single patient registration.
Yeah, but we have, but it's closed.
No, so see, closed in the sense that if you want to integrate a third-party application, you have to do it through us. We won't open our proprietary technology to you for doing customizations on your own. We will do it for you. So we have a complete microservices-based architecture wherein we can do a complete API integration for you.
Yeah, but that's the problem.
But
it
that
has
is
to
what we will do
be
because
open
we invested a
and
lot of.
closed. You understand what I mean?
I completely agree with you. I'm taking your point taken.
Some things are inevitable.
Yes, absolutely.
Centralized. Even today, people talk about this AI. ChatGPT is a big centralized system that's feeding on all of our data. The future of AI is not going to be ChatGPT. It's spread across, I don't know how many data centers around the world. It provides the capacity of 10 trillion neural networks, which is similar. We have 110 in our brain. In the future, there will be quantum computing. All of this will be in that thing. That thing will be a robot, which can replace all of us or enhance us to some ways. So ChatGPT, from a centralized system, is going to go decentralized because the value for the central is done. It's no more. They cannot add any more intelligence to this. If they want more intelligence, they have to go back to the micro data. You go this, it's the same, just going to apply.
I agree.
That's what I'm asking. If we want to democratize innovation around last mile healthcare, you have to already start building that system and opening up that API somehow.
So the point here is that to have a business sense associated with what you're talking about, I completely agree that if you look at the kind of user base, if you build that user base, then it makes a lot more business sense to open up your APIs to third-party customizations on their own. But with a smaller user base, what we are currently facing right now, right? Telemedicine has still not.
No, I agree. For what's happening now, this is the big problem you need to solve.
Absolutely.
But again, what did we say today? 10 to 15 years from now, what does this look like?
That is why we are going for a dynamic file platform. You know, with dynamic file platform, anybody can just come in. It's a plug-and-play system. You plug your system with us, your data will seamlessly flow to whatever system. That is the kind of vision that we have.
All right. We're at the right place then. I'm just trying to go back and forth.
So we'll take up some questions from our remote audience. They have been listening to us for last 2 hours. So anybody wants to ask any questions to Mr. Sujay or anybody in the previous session? Please go ahead.
Please unshare your presentation.
Sheshu, you can stop sharing your screen. Thank you for joining in here.
Yeah. Any questions coming anywhere? Any hands are raising? Let us know. Our audio is stopped, I think.
No, sir, it's
our audio here.
Sheshu's screen, I believe.
Your audio is on, that's somebody else's.
We are able to hear you. Are ask any questions?
Sheshu, you can stop sharing your screen.
It's stopped.
Yeah, now it's stopped.
Okay.
Any remote audience? Ask any questions or seeking any clarifications? So if not, we thanks Sujay for coming over for a day and staying back throughout the session, contributing immensely to the panel, as well as showing off your solutions and products. So look forward to continue participation.
Sure, sir. It's a pleasure.
Till the time you open up free for all of us.
Yes, sir.
We'll pay till that time.
Thank you, sir.
Okay.
I'll take everybody.
Yes, sure.
Try to catch.
You have to catch.
Thank you. Yes.
You got wait today also. I'm very sorry for that.
No,
so So you're based in Delhi. So next meeting will occur in this animation in C.Dot complex. We can invite you there also.
That's
Give permission from.
That's what I was telling him about.
Well, we're at the right place.
We're done. So we are officially closing this session today for all our remote participants. Thank you very much for staying throughout and watching us and listening to us. So we'll meet again tomorrow. If you are interested, we are doing workshop in HGPJ at 9:30 onwards and in KGMC from 2:30 onwards. So if you are interested, you can join us again remotely using the same link. And if not, then on day after tomorrow, It is on 23rd, 24th and 25th. So both the days are grueling sessions and will be grilled by our boss, Mr. Mohammed. Workshops. Okay. So please stop the Zoom share.
Thank
So
you.
tomorrow's program.